Hello. Good morning, everyone. Welcome to Trustwell Hospitals. Today it's a grand day. Post-COVID, we are organizing the first conference, first physical conference at Trustwell Hospitals. Department of Clinical and Interventional Pulmonology at Trustwell Hospitals, in association with Karnataka Pulmonologists Association, ICS Indian Chest Society Karnataka chapter, and Academy of Family Physicians in India. Today we are organizing a unique conference and workshop on respiratory physiology. Apart from all the high funda stuffs like bronchoscopy, thoracoscopy, interventional pulmonology, we decided that we will try and keep topics which are more useful for PGs. And as we all know, our regular spirometry, DLCO, and all our respiratory physiology equipments are more of bread and butter for all of us, rather than going for baby corn Manchurian. I would that's why I preferred, I suggested that we are going to have these topics which are more useful for all the postgraduate students. Thanks for giving an overwhelming response. We are going to start the conference right now without wasting much time. I welcome the first speaker. We'll start the scientific sessions. I welcome our first speaker of the conference, Dr. Suma P. Kumar. Welcome, madam. Madam is a consultant pulmonologist at Excel Care Hospital, Bangalore. I welcome today's chairpersons for the first session, Dr. Mohan Rao KN, HOD, Saptagiri Medical College. Please come on the dais, sir. And I call upon Dr. Kiran Krishnamurthy, consultant pulmonologist at Rangadore Hospital. Thank you, ma'am. Welcome to Trustwell Hospitals. Over to the chairpersons.
Good morning. Welcome to this session, which is a very basic and very important session for all budding pulmonologists. Okay, so this is our basic investigation, which will give you what type of disease you are going to deal. Okay, so before starting the treatment, I will tell you, please, whenever the spirometry is done, please be sure the respiratory technician or the person who is well trained. Don't go on seeing the reports and interpreting it. So please have a confidence, or if you are doing, do it with the well knowing the spirometry, how you read it. Okay, so this is the fundamental thing I am advising you all for this session. Anything?
Thank you, sir. I think we'll go ahead. I just briefly introduce Dr. Suma. Dr. Suma is very well known to everyone. I don't think she needs an introduction, but she is a MBBS graduate from Bangalore Medical College, and then she went on to the UK and completed her CCHT in pulmonary medicine. She also obtained an MD in pulmonary medicine from the University of Glasgow, and also the European Diploma in Pulmonary Medicine. She came back to India in 2009 and has been associated with Sagar Hospitals and running the Excel Care Hospital. In addition, she's an astute clinician, very, very good in diagnosing and getting to the bottom of pulmonary medicine cases. She's also a keen academician and has been at the forefront of organizing many conferences, workshops, and talks. So I'm sure we are all very privileged to have her here. So we'll kickstart our program with an excellent talk. Thank you. Over to you, Dr.
Thank you very much, Dr. Kiran, and thank you for the organizers for giving us this opportunity, and it's really nice to be in a hybrid mode. Many people are benefiting from this, and respiratory physiology, like Dr. Swami said, is the bread and butter, so it's very good to come to this conference and learn from all the esteemed speakers. So today I will be talking about spirometry, the basics of it. So we'll look at some background of what spirometry, how it evolved. Who invented spirometry? I don't know if that's a quiz question. You can answer though now. You want to think for a minute? So we will go through the background, indications, contraindications, how to prepare these patients and the regular parameters we check with spirometry, graphs and some, maybe if time permits, some examples and some conclusions that we can draw for today. So spirometry was invented in the 1840s by an English surgeon, John Hutchinson. So as most of you probably know, it is basically it was a volume spirometers that came along. So they used to have a calibrated bucket really immersed in a bucket of water, and that is attached to kind of a vitallograph that you can correlate to, and when somebody blew into it, the water column displaced, and that caused the volume change that was recorded. So we are all very familiar with this tidal volume graphs that we have learned in our physiology classes. So just to highlight that we are going to be looking at this portion of vital capacity when we talk about spirometry. Definitely we are looking at the components of it, really the FEV1, FVC, and FEV6 is coming into work quite a bit, and we will look at the FEV1 FVC ratio, peak flows, and some mid-expiratory flow rates and what its significance is in its in our daily clinical practice. So at a very basic level, just remember we have moved on from volume spirometers to more pneumotac based or ultrasonic ultrasound based technology to record volume. So resistance is a pressure over flow. So that's a basic formula for all of us to remember, and this will be repeated many times through the day today, so it will just get honed into your minds. And flow is volume over time. So a pneumotachograph basically has got, it records flow by measuring the change in the resistance that happens between two pressure transducers. So that is what is recorded, and from that volume is derived. So this is one of the commonest of all the PFTs that is used, and it is a daily practice for most of us, and we stop thinking about it. So it is time to think a bit more about it and see what new things have come into this. So it is used as a diagnostic modality for maybe at screening for smokers who have been at risk of COPD, or to look at obstructive and restrictive lung diseases, not only to diagnose but also to quantify the level of obstruction to assess the severity of the disease. Definitely we do use this as a follow-up parameter, and in therapeutic assessment when we are looking for bronchodilator reversibility, etc. Definitely also as pre-employment screening. Any particular profession that you can think of for pre-employment screening? So many of our nurses work with glutaraldehyde when they, use to disinfect our bronchoscopes and things like that. So if they're highly allergic, that's one of the things that can predispose them to asthma. So something to remember in our own professions. And certainly printers, bakers, painters, etc., to be more aware of screening in the right population. Pre-op assessment, many people do undergo major surgeries, and especially if they've been smokers, chronic comorbidities, elderly, most of us would like to do a lung function test to know what their lung function is, especially if we are expecting them to go on ventilators and leave and they're going to be on it for few days. It's a very useful parameter to do, and certainly before lung cancer surgery. So there are ways you can actually predict. Approximately, each lobe represents 20% of the lung function, and from that you can sort of work out what the post-operative FVC will be. And certainly in medical conditions, with multiple comorbidities going for surgeries and things like that, a FEV1 level of less than 50% is something that we would worry about post-operative complications and take extra precautions and care as needed. So one of the things I would like to bring upon today, which we probably don't do much in our practice, but we should inculcate this into our practice a lot more, and there is a useful role in people who have got unexplained cough, breathlessness, to look at their airway hyperresponsiveness to do provocative challenge. So this can be done directly by exposing them to methacholine, which causes the airway smooth muscle contraction, and the serial spirometry is measured. And it's PD20 that we look at. So it's a cumulative dose of the methacholine that results in 20% fall in FEV1 is what is looked at. And depending on the level at which they react, you can get an idea of mild, moderate, or severe airway hyperresponsiveness. This will also be useful as a therapy modality or assess your therapies as well. So indirectly, mannitol, hyperventilation, exercise, etc. can be used as stimulants in these provocative challenges. It is a very sensitive test, but not specific for asthma. So if somebody does get a significant airway hyperresponsiveness, it's highly suggestive of asthma. Or if they don't get it, it's more likely not to be asthma. You can be more confident on that aspect. So again, contraindications, lot of it is relative. So if somebody has had a MI recently, cataract surgeries or upper abdominal surgeries, definitely they will not be able to do the procedure. Best not to do in unstable patients. So being on oxygen alone is not a contraindication to do it. Any orofacial discomfort, memory loss, they are unable to comprehend what you're telling them. So patient cooperation is very essential in this test. So if they are not able to cooperate with you, there is no point in doing this test. So preparation is extremely important. So there are some technical aspects of preparation. Sir already highlighted how important it is to have a trained technician. So what we see on the paper is only a reflection of what has been done. So it's extremely important that you look at the way the technicians are doing it, and they're encouraging the patients when they do the test, which definitely adds on to the value of the test. So calibration, regular calibration prior to each session is mandatory. And especially if you're using AC or you're using, temperature alterations in the room is very common. This is a very important aspect to do. And at least biological calibration, by which I mean it may be a trained technician or you yourself on a weekly basis to monitor your lung function test to make sure that it is within the expected range. So when we do the calibration, plus or minus 3%, really it is a very narrow window. We should be maintaining our values at that. Important to ensure that we are using disposable filters, especially with only increasing viral infection load in the communities, and single mouthpiece, which all of us pretty much do. So with respect to patient preparation, we already discussed patient has to cooperate, and SABAs, if we are doing bronchodilator reversibility, please ensure it is done with withholding the LABAs and LAMAs and SABAs. And definitely they should not be smoking for an hour at least prior to the test, no alcohol for 4 hours, no vigorous exercise for 30 minutes beforehand. So we generally take best of 3 maneuvers with less than 5% variability between 2 at least. That's about 100 ml. So please do look out for these values. Just don't look at the best value, but please compare it with the other values that comes on the graph. Always do compare and ensure that the patient has attained a maximal effort. Technically, it is a sound study before you report. So exhalation to at least 6 seconds, and you can go up to 8 maneuvers, but you should remember that if they keep breathing multiple times, one is exhaustion. Second thing is you may be falsely estimating the volumes. So it's very important not to go on making them blow if they are not ready to do the test. So we do get either we can record volume over time, or we can get flow volume loop recorded with this spirometries. So this is a volume over time graph, which many of you will be familiar, and it looks like a normal graph. So restrictive lung disease would produce a graph which is very similar to the normal graph, but obviously the volumes will be a bit less. And in cases of obstructive lung disease on a volume time graph, you would see FEV1 is far reduced in comparison to FVC. So we will look at some of the parameters in a bit more detail. So we are looking at the absolute value of FEV1, which is dependent on FVC. It is important to remember that. And it is the most standardized test for airflow obstruction as of today. So it can be normal or near normal in asthmatics between flare-ups. So normal spirometry should not make you exclude a diagnosis of asthma. And we all know there are many definitions of bronchodilator response, but ATS ERS guideline sticks to 12% increment. and more than 200 ml after bronchodilator. That's about 200 microgram of levosalbutamol or 400 microgram of salbutamol inhalation through a spacer. Or you can also use a nebulizer and recheck the spirometry 20 minutes later to look for reversible airflow obstruction. So it is a suggestive of airflow asthma, but again it's not diagnostic. And in very severe asthmatics, important to remember that the FEV1 FVC ratio can actually increase due to increasing air trapping and things like that. So that is also something to remember. So again, FVC, going back to FEV1, an absolute increase in FEV1 more than 400 ml, we should be thinking very much in terms of chronic, in terms of asthma, poorly controlled. So FVC, again, more than 200 ml increment is a significant bronchodilator response. Slow vital capacity can also be employed if the patient is not able to do forced maneuvers. So I'll spend a bit of time on FEV6, which can be a surrogate marker for FVC. And we will also bring in the concept of lower limit of normalcy. So we are all talking about % predicted values of FEV1, FVC. Is anyone using LLNs? Lower limits of normal? You are. Excellent. So that is where the world is going to, but really that is a more statistically analyzed data and more accurate, and we should be going by it. In very broad terms, LLNs, if we are doing it in at-risk group of patients, can overestimate obstructive lung disease, but in patients who are symptomatic asthmatics, COPDs, etc., we may actually underestimate the disease severity. So that is something to remember, and that is why gold is sticking on to % predicted FVC so far, but more and more we are going to see the LLNs. So FVV6 is equivalent to FVC in predicting both obstructive and restrictive lung diseases. Again, the reference equations are being established, and so it has not come into clinical practice very widely, but it is going to do so. So now we talk a bit about the mid-expiratory flow rate, which is the 25 to 75% of that FVC, the volume time graph or the flow volume loop. And here is where we are thinking that the airflow obstruction can be picked up a lot more earlier than a FEV1 can predict. However, there is poor standardization, poor reproducibility of mid-expiratory flow rate, and high number of false positive and negatives. So just based on that, please do not make a clinical decision, but it can give you an indication whether there is an early airflow obstruction or not. So we look at the graphs, and just looking at the restrictive lung defect, so we know that there is a low FEV1, low FVC, and severity of the disease can also be assessed depending on the fall in the FVC. So if it's between 60 to 80%, we would call it as mild restriction, 45 to 60 as moderate, and severe as less than 45%. So you would all be aware of the diseases that cause restriction: chest wall diseases, pleural diseases, interstitial lung diseases. And coming to obstructive lung defect, so there is a low FEV1, FVC is really normal, but as we saw before, in very severe disease, it can go low as well slightly, and FEV1 FVC ratio tends to be reduced. So again, to highlight that it is not just the absolute values, we can also assess the severity of the disease looking at the percentage fall in these FVC. So if we look at the gold guidelines for COPD, we discussed that. So FEV1 FVC less than 0.7 is obstructive lung disease, and FEV1 predicted more than 80 is gold class 1. 2 will be 50 to 80%. Severe disease less than 50, above 30. Very severe is below 30% of FEV1. And similarly, we can also from GINA guidelines derive for asthma. So we have talked a lot about the lower airways and small airway obstruction. Now we will look at some of the patterns for upper airway obstruction that can also be predicted from spirometry. So you may be familiar with MP's index, which is the FEV1 in ml, recorded in ml, divided by the peak expiratory flow rate in liters per minute. So if it's beyond 8, then it is suggestive of upper airway obstruction. So we also look at this FEF50 to FIF50 graph. So on a flow volume loop, this is the expiratory limb, inspiratory limb. Both are truncated, and this is a fixed airflow obstruction. So when there is truncating of the inspiratory limb, it is likely to be a variable extrathoracic obstruction, like a goiter. And when there is variable intrathoracic upper airway obstruction, the expiratory limb tends to be truncated. So a lot of pattern recognition. So intrathoracic obstruction, there will be truncation of the expiratory limb. So another one will be the opposite. Again, just to highlight this graphically, how it looks. So we will just work through a couple of examples. Okay. Couple of examples. So we have talked a bit about spirometry recordings and things like that. What can you make out from this? Yeah, patient has had a cough. So will you take it into consideration? Yeah. So it's already people who know everything about spirometry. So we will move on to the next one. A 75-year-old, 30-pack-year history of smoking who presents with cough and breathlessness for 2 years. And this is the initial spirometric reading, a typical flow volume loop that would suggest COPD for you. And you do see FEV1 is 44%, FVC is 92%. After bronchodilator response, there isn't any significant reversibility. FEV1 to FVC is 36%. Okay, so very severe COPD. All are happy with the diagnosis. A year later, he presents with worsening breathlessness, and you do see FEV1 has fallen down to 0.9 liters. Not much of a change, but certainly downward trend. FVC goes down to 2 liters. FEV1 to FVC ratio is 45%. If anything, it has increased. What is your diagnosis and what is the next test you will do? Somebody loudly, please. So there are two possibilities. So FVC has gone down quite a bit, so you cannot exclude an additional restriction. Patient might have developed an interstitial lung disease, or the air trapping has worsened so much that the FVC has fallen. So you should be doing some imaging things, X-ray, CT scan to see whether there is ILD, or do more static lung volumes and full lung function test looking at diffusion and things like that. So that's how spirometry can guide you in even following up the patients. So all exam goers will be very happy with this graph. What is this? This is a definite pattern recognition. So let us say it's a 56-year-old heavy smoker presented with hemoptysis on a background of weight loss and breathlessness going on for a few months. It's a biphasic spirogram. So it is generally consistent with main stem bronchus obstruction. So both the inspiratory limb and expiratory limb is cut off in half. Okay, so in conclusion, it's one of the basic tests we all do. It's our bread and butter, and we need to have a very good grasp of what we do, how we interpret it. Ensure that when you're reporting that that it is a technically valid study, and at least 3 maneuvers are done with effort variation less than 5%. And you look at the FEV1, FVC value. If it's completely normal, look at the vital capacity. If it is all normal, then it's a normal spirometry, and interpret it in the clinical context always. So a normal spirometry doesn't exclude the diagnosis of asthma. Please remember that. So if the vital capacity is low, then there may be a restriction, early restriction that you may be missing. Then you will have to go back and do a bit more assessment. If FEV1 to FVC ratio less than 70 to 80%, then you assess the vital capacity. FEV1 to FVC 80%, as we age, because of the values go down, even 75%, 70% may be accepted as being normal. So you assess the vital capacity, and if it's normal, obstructive, then you go to FEV1 and then categorize and see mild, moderate, severe. If it is low FVC, then we know it is obstructive or mixed. We may have to do static lung volumes or do further imaging studies. Okay. These are some of the references. I'm sure most of you will be aware of it, and thank you very much.
Thank you, ma'am, for a very wonderful and lucid presentation on basics of spirometry. Now, all the doubts can be asked after the next section. So, I would like to invite upon stage Dr. Hiranappa Udayanur, consultant pulmonologist in Manipal Hospital, for delivering the next topic. And I would like Dr. Mohan Rao and Kiran Krishnamurthy to stay on the dais to chair the next section also. Thank you.
It is my privilege to introduce my student, Hiranappa, who was my student, and he has did his MBBS from MS Ramaya Medical College and DNB from Medinova, Hyderabad. Oh, he is a very jolly person. He's, you should see him in cultural activities. And he is now a busy practitioner and academician. Oh, hope he will benefit from this talk. Over to Hiranappa.
Thank you very much, sir. I used to visit pulmonology department post MBBS during internship. Every time I started working in endocrinology that time, when I got DTCD, he used to say, since you used to come to us here, you realized what DTCD means and you took the seat at the. I made one of my friend to join his department. He also did DTCD, and Dr. Madhu, he is working in Apollo, Mysore now. He was sitting alone in the department that time in 2004, and it's miles ahead now, pulmonology. After the basic spirometry, sometimes going into physiology, learning, understanding, but when you do the test, it is easy. But when you start reading it more, you get confused. We relearn, unlearn. Sometimes our concepts are not correct, and we learn after few days when you come up with the patients again. And one such topic is DLCO. Nobody used to take it for presentation during our PG time also, because you need to read more John B. Best and read more of physiology and then do this. I will make it slightly interesting also, not go into the depth of it too much, and try to be stipulated 12 minutes. And we know, as we know, this is the alveoli. The oxygen comes in, it's a blood vessel capillary. This membrane is the interstitium. So any oxygen has to go, it has to cross the alveolar epithelium, the membrane, and endothelium, blood vessel, then it has to reach the RBCs. This is the one which is most important membrane which is involved. This, whatever the gas diffuses based on the gas characteristics, whether it is carbon dioxide and oxygen are the most important things which are doing its job in a gas exchange. But we are talking about DLCO, where CO is nothing related. Why we are doing the DLCO, I will just explain why CO. So my talk will be on the history, fixed law. Sometimes we have to go back after 10 years and reading it. It's tough. So components of diffusion, why carbon monoxide is used, indications, measurement of diffusion coefficient, why the different methods are involved, what is the principle behind doing these tests, and how it is useful. At the end of the day, we are interested in this. So I will come to this point at last, and this will make you confused and relearn all the things. So the primary function of lung is gas exchange. So oxygen has to go in and carbon dioxide has to go out. And it is so easy to tell, but lot of things happen right from the airway, larger airways, then going into a smaller airways, then the alveoli, that the membrane, then carbon dioxide, oxygen goes in, carbon dioxide comes out. And this is simple physiology. And earlier, the history behind it, earlier in 1904, Bohr said that in the alveoli, he produced the fish model, and it secretes oxygen. The alveolar oxygen is, they said it is less, and the arterial oxygen or a capillary blood oxygen will be more. And that has been proven, and long-standingly this went on, and we didn't understand the physiology. Later, when this by diffusion theory has been explained by Croft, where gas diffuses across the membrane based on the partial pressure gradient, and it is not active phenomena, means it's not secretory, it is passive diffusion. So it needs some surface, it has to go from higher pressure to lower pressure. And Brakoff proved that the alveolar oxygen is always more than arterial oxygen. So it has to go from higher gradient to lower gradient. So this is a fixed law. So this is a membrane. If you think that it is an interstitium, so any gas, it has to go from higher pressure to lower pressure, and we see oxygen going in there. So volume of a gas is proportional to area of thickness. The area of thickness is more, it needs, it is difficult for oxygen to go, and total surface area. See, lung is a surface area is of a tennis court size. That is the surface area which we are talking about. And this is a gradient, surface area of barrier available for the diffusion, and diffusion coefficient of particular gas in the barrier is based on the solubility of carbon, this based on that gas, whether it is oxygen or carbon dioxide, and molecular weight of that. So this we will keep on exploring how exactly we build, how we are using a diffusion in our clinical practice. Usually it is called as DLCO. DLCO means diffusion limited carbon monoxide testing. Why is it diffusion limited? So normally all gases are perfusion limited. I will explain this. Even oxygen, carbon dioxide, nitrous oxide is also present when you take a air. These are all perfusion limited. So carbon monoxide is diffusion limited, because carbon monoxide is not normally present in our body. Sometimes you are exposed to smoke and other things. We have some amount of carbon monoxide, probably carboxyhemoglobin, abnormal hemoglobin, it can be. So what happens in normal conditions? So when any gas from the alveoli to capillary, if it goes by the gradient, there are two things which happen. Whenever it goes, it tries to reach the equilibrium. So oxygen, when it diffuses from a higher pressure to lower pressure, it will reach the equilibrium. So further pressure drop will not happen. Even for carbon dioxide, the gradient is like that only. Even nitrous oxide, helium, most of the things are perfusion limited, because the 0.75 second, when the circulation, the pressure goes in the RBC, what stays in the capillary, it needs only 0.3 second for the oxygen to get transferred. We have extra 0.75 seconds. And if the circulatory load is high, then if they are exercising, then oxygen diffuses, but it meets the demand. So we have some amount of reserve. So what happens in carbon monoxide is diffusion limited. Diffusion limited means we normally have carbon dioxide in the body, it reaches equilibrium, oxygen, both sides we are having. For carbon monoxide is not there in our body. So it doesn't reach the equilibrium. It is always, the pressure is always downward gradient. It always continues to diffuse longer, more than 0.75 seconds. So that is the quality of that gas that is used to indirectly measure the diffusion coefficient of a membrane, of respiratory membrane. So that is called as diffusion capacity. So what happens? Carbon monoxide has high affinity to hemoglobin, 250 times more than oxygen. So when it diffuses across the membrane, it just binds the hemoglobin. So there is no soluble carbon monoxide in the blood. So the gradient is always positive, and that's why it is useful to measure. And that is used as a surrogate for oxygen, because we are normally measuring oxygen diffusion coefficient. We want the information of diffusion. We use carbon monoxide to assess the diffusion capacity of a lung. So normally it is expressed as ml per minute of carbon monoxide per gram per Hg. So it is expressed as ml per minute, and it is called as transfer coefficient in Europe, and diffusion coefficient, whatever terminologies you see, it is the transfer coefficient, how exactly the mechanism works. So we need to know what is the difference between that diffusion and perfusion limited. So it is like, it is an example which I feel I have conveyed the message of how exactly the diffusion and perfusion limitation helps. So if you think that 0.7 second, the RBCs are staying there, if it is in the capillary, it is equivalent to some, this is a coal chute. Perfusion, the solubility of a gas in a membrane is equal to like a coal chute, and solubility of a gas in a blood is like a railroad cars. So when the membrane and blood solubilities are well matched, so it happens when oxygen and carbon dioxide, the car leaves with full this thing, transfer is perfusion limited. So this will not help to measure This will not help to measure. So we need to have some different characteristic gas which is not in the body and maintain the pressure difference gradient, and we can measure that. Here what happens when the solubilities differ, because when carbon dioxide is there, for a membrane it has different characteristics, but to present in the blood it has a different characteristic. So it takes longer time. So it diffuses longer time, 0.75. That quality of carbon monoxide is used to measure the diffusion coefficient. So we'll come into, but it is a simple membrane. I was talking about, it is not a simple membrane. So in life the membrane is complex. So it has 2-3 components. So like diffusion, whatever we are saying, diffusion, what we are saying, by Rofton and Foster equation, so 1 by dl by 1 by dm is a membrane component, and this is the hemoglobin component. As you see there, in the first component is from alveoli to the interior of red cell. That is a membrane component. So anything which affects, like if there is interstitial edema in pulmonary edema like picture, then there is a decreased DLCO. If there is a interstitial lung disease, there is a decrease in DLCO. Anything happens in the membrane, right from the alveolar epithelium to a membrane, anything which affects, so it becomes easy to remember which are the conditions where you see DLCO decreased. If something happens in this pathology across the larger surfaces in the lung, then that will get affected. So this is the first component. The second component is from the membrane within this has different characteristic altogether. So when it comes here, surrounding the RBCs in the blood vessels, in the solubility of the gas determines the partial pressure gradient. But when it binds it doesn't contribute to partial pressure. So it just binds, hemoglobin and oxygen binds, oxyhemoglobin, there are binding sites. This is so anything which increases the volume of blood, anything which delays, if there is abnormal hemoglobin, or anything with a rate of reaction of oxygen and hemoglobin, something present, it affects the overall diffusion capacity of the particular lung. Why carbon monoxide is preferred? Ideally, it is a volume of a gas across the pressure gradient. This is the alveolar oxygen. This is the capillary oxygen. It is a gradient. So normally this is higher, this is lower when it goes into it. So this oxygen gas, it is difficult with this gas because it is not diffusion limited. So carbon dioxide we can use, carbon dioxide diffusion we can use. But PCO2 is difficult to measure because while doing a testing, we do it by ABG, but while doing a capillary carbon dioxide is tough. So why we are using carbon monoxide is, it is not present in the lung or in the blood normally. It is totally new for the lung. You can be exposed to air pollution, smoking, that can increase some amount of carbon monoxide, but it is not present. That's the beauty of this. This gas is used to get the diffusion. So high affinity to hemoglobin, 250 times of oxygen. Transfer is diffusion limited rather than perfusion limited. This is the characteristic of this gas which makes it easy to find out. Like helium, it doesn't diffuse. Helium helps in only measuring the volumes. Like residual volume, even after doing any kind of spirometry, dynamic functions, we can't get it. So helium is a gas which is used. So helium gas characteristics, carbon monoxide gas characteristics, and oxygen, carbon dioxide, and nitrous oxide. All these gases have their own characteristics. Nitrogen acts to the volume of the gas. So this characteristic is used for measuring the DLCO. So diffusion, carbon monoxide diffusion is less affected by other factors. Means compared to oxygen and carbon dioxide. A relatively large difference between alveolar carbon monoxide and capillary carbon monoxide. Normally this capillary carbon monoxide is nil because it is not present in the blood. Whenever carbon monoxide gets into the blood, it binds hemoglobin. It doesn't stay in the blood. It doesn't stay in the plasma. So it doesn't excite. So this parameter, you can be devoid of measuring it. There are small component, if he is exposed to some carbon monoxide poisoning and other things, it can happen. But this is negligible. So you don't have to measure the gradient at all. So if you get the value of alveolar carbon monoxide, when it stays in certain amount of time in the lung and volume is filled overall lung, his concentration comes down while expiration. So this volume is good enough to get the volume of a gas can also be measured by a difference in initial and after the breath holding time. And if you get this PaCO, alveolar, capital A, this is capital A, it's not arterial, alveolar carbon monoxide, if you get it, DLCO can be surrogately used as oxygen transfer. It can be used. So normally if you get DLO2 only you want, diffusion coefficient of oxygen only you want, if you multiply it by 1.23, then we get a DLO2. Normally 21 ml per minute per mm of pressure gradient. It diffuses in 0.3 seconds. We have a reserve of 0.75 seconds because RBCs and blood circulation is happening. If you exercise, it increases, we get lesser time. In anemia, there is a circulatory overload. So this is the reason why carbon monoxide is chosen. So we'll come to equation of this again. How exactly we measure diffusion, we derive that equation of diffusion coefficient. It is not possible to measure a area and thickness during life. So it is combined into a coefficient. So this is rewritten as DL capacity, diffusion coefficient with all the three area and thickness, because it is individual lungs, it is a characteristics of it. So these three parameters have made it as diffusion capacity. So any gas into DL capacity into pressure gradient, we derived that equation. So blood carbon monoxide is extremely negligible, which I told. Its solubility, it is not stay in the plasma. It just blinds the RBC hemoglobin. So this pressure gradient, it actually becomes the alveolar carbon monoxide, and alveolar volume of carbon monoxide will get the value to a diffusion coefficient of carbon monoxide. This is the value which we are looking at. We are not looking at absolute number when you are practicing. We want whether it is decreased or increased. Numbers doesn't have much of a role. We like brain, when there is a, like we need to assess where exactly is the center. Like in the lungs, we have functional classification. As Dr. Suma told, it is obstructive airways, we have restrictive airways. If it is restriction, it is intraparenchymal restriction. If it is restriction, whether it is extraparenchymal restriction. So know that it is intraparenchymal restriction, sometimes diffusion helps. So if you want to extraparenchymal restriction, we need additional static lung volumes like RV by TLC, and all those things are required. So this is the way we look at. So if you want to assess the interstitium, DLCO is the one thing which we need to look. If you want to assess obstruction or restriction, it is regular spirometry which are dynamic. We don't get absolute value of the volumes. And then it is the static lung volumes. So what are the methods to do DLCO? There are many methods, like single S, these are the methods. The best which is clinical utility is there, which we are using in routine practice. That is more important. It is single breath hold technique. We will talk about this. What is the principle behind this test is, as we derived the equation of DLCO, what exactly they do, a small amount of carbon monoxide is breathed into the alveoli. There is some alveolar gas which comes in. There is a group of gases. We inhale it slowly and take a breath. We will breath hold. Okay. Breath hold. And capillary carbon monoxide is actually 0, and HB combines with so rapidly, pressure is not built up. The gradient is equal to PaCO2. By measuring all these things in short period, we will get into the DLCO. Patient preparation, smoking should be, they should not smoke alcohol, they increases the blood volume, it will reduce that, and certain physiological causes are there where DLCO can increase and decrease, and these are pre-test, this thing we need to see, he should not be on oxygen and all. So this procedure, I will show the video. So there is an unforced exhalation to RV. So we need to do a breathing exercise in such a way. We have to breathe out to RV, means residual volume, and take a normal breath. Take a rapid inhalations of this group of gases and hold the breath for 10 to 12 seconds, and rapid exhalation for 4 seconds. And alveolar gas, whatever comes in the first is in the upper airways, that is a dead space. If you can discard that and take the volumes of the gases, and that is measured, and initial carbon monoxide and post breath holding carbon monoxide concentrations and helium concentration, we can get the value of RV, residual volume. If you can get the residual volume amount, we can derive most of the capacities, and then carbon monoxide, we can get that. This is a procedural video. How exactly it is done. Normally, this is the way the initial concentration and final concentration. Then he will blow out. First few seconds it will take off, and then want to see it again. Whatever alveolar gas comes, that will be measured. The machine only will do it. And it has a the one, the equations. Once they breathe the tidal volume, take a deep inspiration to a total breath holding, then expiration, that space washout will be there. This is the sample which is collected. This sample will analyze what is the concentration, and that we can derive the equations, pressure, barometric pressure, all we think. This is the initial and final concentration of carbon monoxide. This is this equation is written as Croft constant, and it is always dependent on alveolar volume. So sometime post pneumonectomy and all, diffusion will come now. When you correct it to alveolar volume, it will be normal. The whatever lung which is there as a single lung, that diffusion capacity will be good only. So we will always see other factors in it. What is the hemoglobin, smoking, all other things has to be taken into consideration while we are interpreting it. So these are acceptable criteria, because sometimes it is reproducible. 5% is not taken, 10% is taken. They have to take a good breathing, and breath holding time, Valsalva, those maneuvers should not be there. So there are acceptable criteria like a basic spirometry, repeatability. So there should not be any abnormality, means they should be matching 2 or 3 tests, and take a best test to do that. And more than 5 tests to repeat, it takes a gap. If they have obstructive airway disease, 10 minutes. If they don't have that, it is 4 minutes. So it usually takes 1.5 hours for this test if they are not doing it properly. And the reporting is measured DLCO, predicted. You get the predicted values based on their height and characteristics, and any adjustments with hemoglobin, carbon monoxide, alveolar volume has to be noted. So these are the physiological factors which will alter. I will go through hemoglobin, because in that equation we have seen hemoglobin. It includes the, so if something happens in hemoglobin less or more, diffusion gets affected. In alveolar hemorrhages, it actually shows more. So alveolar volume, I told you pneumonectomy, these patients, or interstitial small lungs volume, obstructive large lung volumes. If there is large lung volumes, it should actually increase. But the problem is in emphysema, there will be attrition, means there is a loss of surface area. Surface area will be less, so you will get it less. Carbon monoxide levels, circadian rhythms, these are gender, exercise, body position, menstrual cycle. These are the certain physiological parameters. These are clinically irrelevant, because we still have to know it. But sometimes if you have a large changes, it should be okay. We want whether DLCO is increased, diffusion limitation is there or not, we need to see. These are the values which you see, the percentage, severity, of all the DLCO 60 to 120. So in normally this is total lung capacity, restrictive is miniature of the normal lungs, and air trapping RV will be increased, total lung capacity will be normal. Hyperinflation, we have all the things increased. RV can be normal, total lung capacity, we just need to know that. So indications, evaluation of dyspnea or hypoxia, emphysema, interstitial lung disease, monitoring of interstitial lung disease, differential diagnosis of lung volume restriction, detection of pulmonary vascular diseases. Sometimes DLCO is only parameters which will be reduced. Disability or impairment assessment. These are the severity classifications, whether it is severe. So certain conditions like where alveolar volume gets affected. So DLCO will become normal when you correct it to volumes, pneumonectomy and other things. So emphysema, alveolar hemorrhage, high blood volume. So we need to know this thing. So increased DLCO, we have in asthma, because of the perfusions and other things, we can have normal or increased DLCO. That is the one thing which we need to remember. Alveolar, anything which increases the hemoglobin or alveolar hemorrhage, it increases. So, and low DLCO with normal spirometry, it can have early interstitial lung disease or vascular diseases. Sometimes we don't know what is the cause for low oxygen, we get to know this. So with the combined, if FEC limitation, as Dr. Suma's patient showed, FEC was limited in a severe obstruction or FEC, we need a CT or imaging, and before going to a CT or X-ray, and you do this, and if you really find that diffusion is limited, we see it is intraparenchymal restriction, then you assess for early ILD to be ruled out. These are the things. Any interstitial lung disease can cause low DLCO with restrictions, pneumonia, and other causes. Supplemental oxygen, bronchodilator can increase DLCO. These are the things. Another 30 seconds. So when you see if FE1, these are TLC. TLC is less than, it is restrictive. When you see restriction, if DLCO is decreased, then we think that it is intraparenchymal restriction. We need MIP and all, maximum expiratory pressure, maximum inspiratory pressure, to look for extra parenchymal restrictions like neuromuscular diseases and other things. So in obstructive airway disease also, DLCO, how exactly is interpreted? If there is an obstruction, if you see a DLCO, if DLCO is normal, it is normally asthma. If DLCO is decreased, sometimes without resorting to a advanced lung function where lung volumes are required, DLCO can be done without lung volumes also. So there we can get to know whether it is predominantly emphysema or asthma. So this is the algorithm. If FEC and FEC is low, obstruction, bronchodilator, obstruction normalizes, it is asthma. It's partially improved, DLCO is low, emphysema or bronchiolitis. If it is normal, asthma or COPD. If it is normal, it can be asthma, bronchoprovocation challenge testing. We still can diagnose asthma. If PFT normal, will not rule out asthma. So DLCO, if it is low, there are other conditions we should be very careful. If isolated only DLCO is low, then it becomes a tougher challenge. We need imaging, we need clinical improvement, clinical inputs, and these things have to be taken into consideration. In restriction, we know low ILD, chest wall, DLCO will be normal, corrected to our volumes, and we need these tests to know whether it is a neuromuscular. Thank you.
Thank you, sir, for a wonderful talk. It's a very good insight on DLCO. Thank you, chairpersons, Dr. Mohan Rao, sir, Dr. Kiran Krishnamurthy, madam, for being with us and chairing the session, sir. Thank you, sir. For the next talk, I would like to invite Dr. Gayatri Devi Hejje, HOD, Pulmonary Medicine at MS Ramaya Medical College, to please occupy the chairperson's chair. And I request Dr. Ataullah Khan, sir, a consultant pulmonologist at Malige Hospital and Manipal Hospital, Sehbal, to please occupy the front chairs. The next speaker would be Dr. Mahesh P.A. He is a renowned pulmonologist. Yeah, he is a renowned pulmonologist. He is head of department pulmonology at JSS Medical College, Mysore. Sir will be joining us online. Just give us a minute, we just have to connect it. Over to the chairpersons.
Good morning. Good morning, Dr. Mahesh. Don't think he's able to hear us.
Yes,
At the outset, I would like to congratulate Dr. Shivalinga Swami for organizing this conference and workshop in a private sector for postgraduate students. I have come to know that many students have participated online, and I can see good number of postgraduate students. And actually you have taken the trouble to organize this respiratory physiology, which none of us have organized so far. We have chosen only certain topics of basic physiology, but you have covered all the areas of respiratory physiology, that is applied aspect of respiratory physiology. And Dr. Suma has already spoken about the basics of spirometry. And what we look at spirometry is whether, when we look at the flow volume, whether it is obstructive or restrictive airway disease. When we look at the obstructive airway disease, we tend to look for whether it is COPD or asthma. Apart from that, when we don't pick up that obstructive airway etiology, asthma, but clinical suspicion is high, we have other tests like FeNO. We have Dr. Mahesh, who will be talking about FeNO. And Dr. Mahesh is professor of pulmonology at JSS Medical College, and he has several publications. I think he has around 243 international publications and 29 national publications, and he has written 3 books and 8 book chapters, and his areas of interest are asthma, COPD, air pollution, drug allergy, and food allergy. Over to you, Dr. Mahesh. Hope you are able to hear us.
I'll tell him. Sir, we are able to hear you, sir. You can start, sir.
Share screen has been disabled on both.
How's that, sir? 1 second, sir. 1 second, sir. 1 second. Yes, sir. Make host. Okay. Yes, sir. Madidin, sir. Yes, sir. All set, sir. Yes, all set, sir.
Okay.
You are audible, sir. Yes, sir.
Audible also, lah?
Yes, sir.
Okay. Sure. Yeah. Shall I start, Swami?
Yes, sir. Yes, sir. Yes, sir. You can start.
A very good morning to all of you. I must first congratulate on having organized this CME and training program on the basics of respiratory physiology and the diagnostic tests. He was our first MD student, and we always wish that the students perform better than the teachers. So I'm happy to see his progress. And good morning all. I will be dealing with the FeNO and its role in asthma. I would like to dedicate this talk to my mentor, teacher, philosopher and guide, whom we lost last year, Professor P. Ravindran. I have no conflict of interest. These are the scenes from the Dasara, I'm sure most of you are aware. Now, FeNO is a device, it is a small handheld machine. It is portable as well to measure the fractional expired nitric oxide in a single expired breath. It prevention of the eosinophilic inflammation in the airways. It is not considered, like spirometry, an aerosol generating procedure, and it rarely induces cough. Alongside a detailed clinical history, examination, spirometry, and other important tests to assess airway variability, such as diurnal challenge testing, FeNO is an important tool that can be used to support the diagnosis of asthma. It is very, very important to know that a positive test increases the probability of asthma. A negative test does not exclude asthma. So that's very, very important to understand. Because a lot of types of asthma have been described, and especially when there is a neutrophilic asthma, the FeNO is likely to be negative or low. So why should we use FeNO at all? Why should we care? Why is this an important tool? If you look at the assessment inflammation based on spirometry, if you say about 4% of them still have poorly controlled asthma, if you were to add FeNO, you will find that the same population, you will have about 22%, that is 1 in 5, will have controlled asthma due to airway inflammation. So the conventional assessment without FeNO that we use does not pick up most of the cases of poorly controlled airway inflammation. Therefore, FeNO is an important tool. Long-term studies have also shown if you manage patients only with spirometry, serial spirometry and clinical examination, versus if you can manage patients adjusting the dose of ICS based on FeNO. They have observed that asthmatics, regardless of their lung functions, if the FeNO is high, have an accelerated loss of FEV. And we all know that lower FEV1 means lower lifespan. FEV1 is very strongly correlated to death. So faster we lose the FEV1, earlier the death. So it is important for us to use FeNO in the management of asthma. In the same group in Australia, one is the Managing Asthma in Pregnancy trial and the Growing into Asthma GIA trial. When they found that if you adjust the dose of ICS based on FeNO in pregnancy, it translates to more than 50% reduction in asthma in children over the next 6 years of follow-up. So the symptoms may not be there for the patient. The spirometry may not reveal an abnormality, but the FeNO does, which means the patient needs higher ICS dosage. And this fine-tuning of the management helps to reduce asthma in children. Now, what is the mechanism? Inflammatory milieu in the mother leads to changes in the DNA methylation, acetylation in the offspring, and therefore has a bearing on asthma in later childhood. Now, where is this nitric oxide coming from? It's coming from various cells. Earlier we thought endothelial cells, which was very important for the cardiologist. Now we know that airway epithelial cells are also quite important source of this nitric oxide. It can also come from the inflammatory cells, it also comes from the nerves. It is synthesized by the nitric oxide synthesis from the amino acid L-arginine. Now we have the inducible is the one that is induced during inflammation and causes a pathological disposition, whereas normally we have the constitutive, which is coming from the endothelial or the neural, and they are generally protected. Now, NO in the picomolar range has a physiologic role. It's important for the lung development, the bronchodilation. It all protects against bronchoconstriction when exposed to external stimuli. Even in the nanomolar range, there is a physiologic role. And then there is an immunity against pathogens. This is a quick one. And also the natural killer cells, killing of these malignant cells. But if it is prolonged, then the nanomolar range, it can lead to chronic inflammatory disease. How does chronic inflammation come about? Now, these are dependent on the reaction between nitric oxide as well as the superoxide anion, which are formed in the airways during inflammation, which leads to the peroxynitrite. It's a highly reactant oxygen species. Now we have enzymes, arginases 1 and 2. Now the arginase can be catalyzed to proline and ornithine, which again leads to airway damage. The third mechanism is the asymmetric dimethyl arginine, ADMA. Again, this was an important cardiac biomarker. Now it is of importance in asthma also. It's an endogenous inhibitor of nitric oxide formation, reducing intracellular arginine and increases the action of the superoxide as well as the peroxynitrite. If you see that this is the protective pathway, the constitutive nitric oxide synthase, wherein you have bronchodilation, bronchoprotection, and anti-inflammatory effects. Here you can see that. Now this is the L-arginine, the main source of nitric oxide. Cationic channels, it will enter into the cell, and this is the pathway that we talked about for the ADMA, which leads to increase in nitrating stress and peroxynitrates. You can also have the arginases 1 and 2 leading to these, which are responsible for airway remodeling, smooth muscle contraction, mucus production. Again, the nitrative stress leads to cell damage, protein dysfunction, and airway hyperresponsiveness. Then we have the host defense also, it is important. Inflammatory cell infiltration, sometimes it is also relevant when it is short and quick and destroys. But if it continues for long term, then you are going to have persistent inflammation. So when do we say a FeNO is abnormal or high? Nice guidance is FeNO of 40. The others use FeNO of 25 in adults and 20 in children, call them as low. If more than that, up to 50 and 35 in children, it's called intermediate. More than 50 in adults and more than 36 in children is called as high. Subjects with high FeNO are at increased risk of the exacerbations, though not, it cannot increase severe exacerbations, as we shall see. So what are the causes of high or low FeNO? We ask the patient to blow and there is a resistance, and that resistance closes the nasal passage, and therefore, because even the nose is also a rich source for the nitric oxide. So if you want to measure this, then we need to close this. That's why when we blow there is a resistance. I'm sure Swami will show in the afternoon, and that will close the nasal passage. So all the air that comes out is coming from the lungs. Now the high FeNO we can get in old age, so you should be careful if you want to interpret a high FeNO in a 70-year-old person. Height, male, some ethnicity, atopy, rhinitis, also give rise to high FeNO. Low FeNO in smokers, passive smoking as well, obesity, acute bronchoconstriction can give rise to a low FeNO. So even if the patient is on inhaled steroid treatment, the FeNO will be low. Recent hot drinks, especially the caffeine, including alcohol, FeNO can be. A diet rich in nitrate, such as green leafy vegetables, FeNO can be high. So these are some of the other. So when you want to do a FeNO is always done before spirometry, because by the time you do 8 maneuvers, you will have pushed out all the nitric oxide. So FeNO is always done before, and you have to give the instruction 1 hour before, avoid eat, drink, and smoke. Avoid significant exertion or exercise for at least 1 hour prior. And these are the other nitrate-rich foods such as celery, leek, beetroot, lettuce, spinach, other green leafy vegetables for at least 3 hours. know when to do it and when not to do. So if there is an intermediate or a high probability of asthma based on clinical history, especially when spirometry does not give you a good clue, we can do a FeNO. Now there are asthmatic patients who are not improving with medications. You are thinking of biologicals, you are thinking of alternate diagnosis. Again, these complex asthma patients, it is important that we go for a FeNO. If you want to assess the etiology of respiratory symptoms, eosinophilic asthma phenotype, response to anti-inflammatory medicines like steroids, you want to have a baseline FeNO for a clinical stability or subsequent monitoring. You want to step down inhaled steroids, you want to step up inhaled steroids, you want to stop inhaled steroids after stepping down altogether, and then you can do a FeNO to decide. If you want to know whether the patient is taking the drugs properly, because after using inhaled steroids, his FeNO should come down. If it is especially an eosinophilic phenotype, if it doesn't come down, then patient is not adherent. That's the most common reason why they don't have asthma, good asthma control. Then we can always use this, show this. Last time you were 50, even now you are 50, which means you're not taking the asthma medications properly, and you can educate them. When not to take, of course, very children, if there is viral infection, you have to postpone. Other bacterial infections also, you have to postpone. Now, FeNO as a biomarker is now gaining traction. For several of these, it's one of the important Th2 high biomarker, along with the IgE, periostin, or sputum or blood eosinophils. To decide on these various therapies, FeNO is important. Now, where all it has a good correlation and where all it has some clinical utility. In bold, you have good evidence, good correlation. Dotted line, either studies are not done or studies are done, the correlation is poor. So if you look at asthma severity, though FeNO can give you good evidence for exacerbation and frequency, increased frequency of severe exacerbation, the prediction of severe exacerbation itself, we don't have strong evidence. We don't have, again, strong evidence for risk of exacerbations. Spirometry, diurnal peak flow, asthma control test, there is no good correlation, which means when there's no good correlation means you have to do spirometry and FeNO. For the use of rescue medications, there is some evidence, especially nocturnal symptoms, there is good evidence. Atopy and skin prick test results, there is good evidence. IgE, eosinophil, generally there is a good correlation. Bronchial hyperresponsiveness, good correlation. Markers of airway inflammation on induced sputum and FeNO, there is a good correlation. Now let us go to the pathways we have from the NICE guidelines as well as others. So if you want to look at a patient, first thing with the clinical history examination, you suspect asthma, you do a spirometry. I won't go to the whole pathway, but just a bit quickly. And if there is an obstruction, you do reversibility testing. If it is reversible, FeNO is more than 40. Straight away they go with the diagnosis of asthma. If the FeNO is less than 40, you can do a peak flow variability. If it is present, you treat as asthma. Now there is no variability in peak flow also. And FeNO levels is intermediate. You can still suspect asthma, you can treat for asthma and review after 1 month and see what has happened. Because if it's inflammation, or heart inflammation, especially neutrophilic inflammation, FeNO may even be low. But if the FeNO is less than 25, you may have to look for other diagnoses. On the other hand, there is an obstruction, there is no reversibility, FeNO is more than 40, then again you suspect asthma and you can treat and see what happens. If FeNO is intermediate, then you can look for diurnal variation. You have good diurnal variation, suspect asthma. If there is no diurnal variation, then this is the patient for bronchial challenge. And if it is positive, you diagnose asthma. So even when the spirometry does not show an obstruction, if you get a FeNO of more than 40 and peak flow variability, You can know. So just go through a case. A 32-year-old male presented with dyspnea, wheeze, cough, mucoid expectoration, severe nocturnal exacerbation. His clinical examination was normal. Spirometry with reversibility testing was observed, and he had a FVC of 90%, FVC of 94%, reversibility of 6%. Now, one of the key options, the other option, of course, is to do a challenge testing. So and his FeNO was 72, and his peak flow variation was 30%. So though he has no reversibility, though his spirometry is normal, now this is a patient with asthma. Now what about a patient who has a symptomatic with respiratory symptoms? You don't able to make with the traditional tools. Again, I won't go through the whole pathway. If the FeNO is high and if the lung function is normal, still understand that there is a high likelihood of asthma and high likelihood of this patient responding to steroids. So even with normal lung function, if the FeNO is high, even with abnormal lung function, we are going to treat this patient asthma if it is more than 50. On the other hand, if the FeNO is low, it is less than 25, lung functions are normal, unlikely to have asthma. Maybe there are other causes for their cough or other symptoms. Even if they have asthma, it is unlikely to be good, to have a good response to inhaled steroids. You may have to consider other diagnoses. If the lung function is abnormal, you may have to consider others. We'll go through a quick second case. A 28-year-old female presented with wheeze, cough, mucoid and mucopurulent expectoration during infections. Until treated with antibiotics, it was mucopurulent, which were at least 6 to 8 times a year. Continued to have symptoms in spite of treatment for asthma for the last 12 years. Clinical examination showed bilateral bronchi. Spirometry with the reversibility testing showed lower lung functions without reversibility. In this case, FeNO was only 12, so you're thinking of an alternative diagnosis altogether. CT is the next option, which showed a bronchiectasis. The small bronchiectasis can lead to bilateral bronchi due to bronchial hyperresponsiveness, and therefore they have been wrongly treated as asthma. CT would have picked up, X-ray may be normal, but CT would have picked up the bronchiectasis. Low also value in helping us to think of alternative diagnosis, keeping in mind neutrophilic asthma will have a low FeNO. Now already patient is asthmatic and he is already on inhaled steroids. Now what should be the care pathway in the use of FeNO? Again, patient has a high FeNO, patient is symptomatic. Use of the steroids or add additional medicines like montelukast. Patient is asymptomatic, you may still consider optimizing the medicines and see whether the FeNO reduces. You can continue the same dose and see if there is any triggers that makes his inflammation worse, such as the exposure to allergens during specific seasons. Now, if the FeNO is low, patient is symptomatic, likely, as we have seen in the second case. To be asthma, you may have to start looking at other diagnoses. Patient is asymptomatic, he is on steroids, you may try to reduce the dose of ICS. So once you reduce the dose of ICS, you have to do a FeNO in the next 4 weeks, just to make sure that no longer. Now, this is a 22-year-old asthmatic on LABA ICS, no symptoms, good asthma control according to GINA. All the 4 questions are no, and he comes for a routine visit. This is his spirometry. Is he ready for a step down? Again, FeNO is a good option. Scenario 1, FeNO is 55, you can't step down. Scenario 2, FeNO is 8, you can definitely step down. 25% of ICS dose can use. I will quickly go through some data that we have on FeNO from the community study. We have 2 of the cohorts, urban and rural, mainly for COPD. Nobody else in India has these cohorts for such a long period of time. Mudra we have for 17 years. We have about 8,450 people, but in this study we are looking about 1,000. COPD, gold, urban, 8-year follow-up, we have about 500 women. Now I'm just presenting data quickly for about little more than 1,200 people. This is biomass, and this is women from the urban area using LPG. We did a spirometry for all of them, and we had normal, we had restriction, and we had COPD. If you see biomass COPD, almost 40% of them have a FeNO above 25, which means these people have significant eosinophilic inflammation. Even people with restrictive disease, this could be again pre-COPD. They had almost about 24% of them also had an elevated FeNO. Of interest, even people normal about 16% of them demonstrated a FeNO above 25. So there is maybe an ongoing inflammation due to eosinophilic inflammation. So this could be a particular type of biomass COPD. I'm not going to go into details, but we found no correlation between LPG and FeNO in women who have normal lung function. But with restricted lung function, we had a significant link between lower FEV1 and increased FeNO. We also found a significant correlation between FeNO and biomass exposure index, as well as FEV1 reversibility in women with normal lung function. Good correlation again with biomass exposure index in women with restrictive lung function. FeNO for 21, whereas we had several hundreds in the rest. We found a trend is definitely observed, as you can see, between the biomass exposure index as well as the FeNO, but the number was small, we could not get a significant association. Thank you very much.
Dr. Mahesh, thank you very much for your nice presentation. You have showed different clinical scenarios and clinical applicability of FeNO in different clinical scenarios. Thank you very much. Thank you for joining us.
For the next presentation, I would like to call Dr. Archana B., Professor and Head of Department of Pulmonology in Rajarajeshwari Medical College, Bangalore.
Vote chairpersons.
Good morning, everyone. I would like to thank Dr. Shivling Swami for inviting me, and probably it's one of the conference for the postgraduates. Probably after COVID, I think we have to start from the start. So probably we are starting from the beginning. I would like to invite Dr. Archana, who's the head of the department from Rajarajeshwari Medical College, to give a brief talk about 6-minute walk test.
Thank you for that introduction. Good morning, everyone. At the outset, I would like to congratulate Dr. Swami for organizing this very useful conference, especially for the postgraduate students. Now I'll be speaking on 6-minute walk test. Under these headings, we all know that 6-minute walk test is a very simple, objective, and reproducible measurement of functional capacity in patients with respiratory and cardiovascular diseases. This test not only evaluates the pulmonary and cardiovascular systems during exercise, but it also evaluates the global and integrated response of all the systems, including circulatory system, peripheral circulation, blood and neuromuscular units, and muscle metabolism during exercise. Coming to the history of this test, in 1962, Balke first introduced this test as a time-distance walk test, as a straightforward and objective measure of the functional capacity. And the patient were required to walk for a required period of time, and the objective was to measure the total distance walked in the time allotted. Then Cooper developed specific time of 12 minutes, thus came the 12-minute walk test. In 1982, Butland and colleagues reduced this time patients required to walk because 12 minutes was too long for the patient who are already having poor health status, lack of motivation to walk for even 12 minutes, and patients were limited by their symptoms. So they compared 2-minute, 6-minute and 12-minute walk test, and all these three tests had similar measures of exercise tolerance, and 6-minute walk test correlated better with the 12-minute walk test. So this led to the introduction of 6-minute walk test. As the test became more useful, there were protocols began to differ in terms of shape and length of the walking course. Some performed 6-minute walk test on the treadmill, patient walking with the patient or walking behind the patient, even differences among the use of verbal encouragement. So to avoid all these variations, in 2002, ATS came with the guidelines for 6-minute walk test. Since 6-minute walk test, there has been a lot of literature published on 6-minute walk test, and also there is growing evidence on shuttle walk test. So in 2014, ERS and ATS jointly came up with the guidelines for field walking test. So what are the key changes in this 2014 guidelines? In addition to 6-minute walk test, they also have guidelines for incremental and endurance shuttle walking test. The saturation has to be monitored continuously. If you see in 2002, we were monitoring saturation at the start of the test and at the end of the test. But in 2014, it came up as continuous monitoring of saturation. This is because the lowest saturation always does not occur at the end of the test. And also, we are going to miss exercise-induced desaturation in about 20% of the patients, especially with the ILD, if we consider end-test saturation. The absolute and the relative contraindications of the test are similar to that of CPET, and 6-minute walk test repetition. It is recommended to repeat 2 tests and take the best 6-minute walk distance. So what are the indications for this test? This is used for pre-treatment and post-treatment comparison in patients who are undergoing lung transplantation, lung resection, LVRS, pulmonary rehabilitation, COPD, heart failure, and pulmonary hypertension. It can also allow the patients to measure their own changes in the functional capacity. This was very useful during the COVID-19 times. And it also helps in assessing the functional status in COPD patients, cystic fibrosis, heart failure, peripheral vascular diseases, and older patients. And it can also predict mortality and morbidity in patients with heart failure, COPD, and primary pulmonary hypertension. As I said, the contraindications are similar to that of CPET. To name a few, the absolute contraindications are acute myocardial infarction within 3 to 5 days, unstable angina, endocarditis, myocarditis, pulmonary embolism, DVT, and the list continues. And the relative contraindications, untreated hypertension, AV blocks, etc. So what are the equipments required to perform this test? At least one chair positioned at the one end of walking course, a validated scale to measure dyspnea and fatigue. We use the modified Bogue scale, BP apparatus, pulse oximeter, stopwatch, a pre-measured walk along marks along the track, access to oxygen and telephone, an emergency backup plan, portable oxygen supplement if the patient is already on oxygen, and a clipboard with reporting sheet and pen. So how do we prepare the patient? The patient should be wearing comfortable clothing and appropriate shoes. If they are using walking aids, the same walking aid should be used during the test, and they have to take their usual medications. A light meal is acceptable before the test. Vigorous exercises has to be avoided within 2 hours of the test, and if we are performing any other lung function test, at least 15 minutes before the 6-minute walk test has to be performed. So how do we perform the procedure? It is performed on a flat, straight course with a hard surface with less pedestrian traffic. A walking course can range from 20 to 50 meters. Usually we use 30 meters. The starting point and every 3 minutes is marked with a tape, and the turnaround points are marked with a cone, and warm-up should not be performed. If at all a practice test is done, at least 1 hour gap should be given. Absolute and relative contraindication should be checked, and we have to check for a heart rate, saturation, blood pressure, dyspnea and fatigue scale at the start of the test, and the patient should rest at least for 10 minutes before the test, and we should tell the patient that the objective of the test is to walk for as far as possible in 6 minutes, but do not run or jog. And the timer should be started as soon as the patient starts to walk. And as already told, monitor the saturation continuously. The assessor should pace the patient, but should not pace the patient, but should walk behind, and use the standardized phrases like "you are doing good," "keep up the good work." If the patient stops during the test, the timer should not be stopped, but we have to note down the time of stopping and restarting the test. The reason for premature cessation should be documented. The assessor can terminate if the saturation goes below 80%, and the walk distance at the end is measured by counting the number of full laps and the partial final lap. And at the end of the test, we have to again check the saturation, heart rate, dyspnea and fatigue level, and congratulate the patient. So what are the reasons for stopping the test? It is chest pain, intolerable dyspnea, leg cramps, staggering, diaphoresis, and pale appearance. This test is a very sensitive test, so quality assurance is very important. The technician who perform the test should be trained using the standard protocol. Quality control and standardization are very important to reduce the variability. Only standardized phrases should be used. If the patient is already on prescribed oxygen, the oxygen should be delivered in the same way with the same flow during all the tests. And if they are on any medication, we have to note down the type of medication, dose, and number of hours taken before the test. So what are the factors that can reduce 6-minute walk distance? This includes shorter height, old age, higher body weight, female gender, short corridor, pulmonary, cardiovascular, and musculoskeletal disorders. Which can increase walk distance include taller height, male gender, higher motivation, patient who has already performed the test, if the patient is on any other medications for disabling disease, and oxygen supplementation. So what are the measurements we take during this test? 6-minute walk distance, this is the primary outcome of the test. It has excellent reliability and validity, and this shows a strong relationship to important clinical outcomes in respiratory and cardiovascular diseases. This should be reported in meters or in feet. Oxygen saturation, another important measurement. It provides the information regarding the exercise-induced desaturation, disease severity, and disease progression. Multiple studies have shown the exercise-induced desaturation is associated with impaired physical daily activity, faster FEV1 decline, and worse prognosis. There are few novel desaturation indices which can predict the mortality in ILD. These include distance saturation product, desaturation area, and desaturation distance ratio. However, these indices are not validated. Another measure is heart rate. We have to measure the heart rate at the start of the test and the end of the test. Heart rate recovery is the reduction in heart rate with the rest that occurs after 6-minute walk test is concluded during the first minute. And heart rate recovery is associated with poor outcome and increased mortality in ILD and pulmonary arterial hypertension. However, there is no universally accepted cutoff for heart rate recovery. Both dyspnea and fatigue should be measured at the start of the test and at the end of the test. 6-minute walk work, it is the product of 6-minute walk distance and body weight. It provides a better estimation of the work required to perform the test than the distance alone, but no studies have investigated the sensitivity of 6-minute walk work. So after the test, how do we interpret the results? A single 6-minute walk distance can be interpreted as an absolute value or percentage predictor for age or gender. If we use the test for prognostication, we have to compare the 6-minute walk distance with the previous value and express the change in as absolute value or percentage change or a change in percentage of predicted value. Minimal clinically important difference in patients with chronic respiratory disease can range from 25 to 33 meters. It's about 30 meters. So what is the normal reference value? It can range anywhere between 380 meters to 782 meters, and the male walk more than female around 30 meters. There is a geographical variation in 6-minute walk distance. Age is the greater impact, and the walk distance decreases as we age. So what are the advantages of this test? It is simple in concept and performance, ease of standardization, it is readily accepted by study subjects, it's easy to administer also, it's inexpensive, quick to perform, and very little equipments are required. It is a very safe test. It is self-paced test performed at submaximal levels of exertion. It is reliable, valid, and reproducible. However, it cannot identify the cause of dyspnea, it cannot identify the mechanism of exercise intolerance, and it cannot determine the maximum oxygen uptake. The information provided by this test should be considered complementary to CPET, but not a replacement for it. Now let us see the utility of this test in various clinical settings. Can 6-minute walk test predict exacerbation in COPD patients? Yes, this is the in this retrospective study about 50 COPD patients were enrolled, and they were divided into two groups. First group less than 80% of the predicted distance, and more than 80% of the predicted walk distance. And exacerbation over the 2 years was analyzed, and they noted that COPD patients with a walk distance of less than 80% predicted had a 2.6 times more the risk of exacerbation compared to those who had more than 80% predicted. This is the another study published in European Respiratory Journal, where they compared desaturating COPD patients with the non-desaturating COPD patients during walk test, and they noted that desaturating COPD patients had twofold increase in the risk of death, 50% increase in experiencing COPD exacerbations, double the yearly rate of decline in FEV1 and FVC, and increased yearly rate of loss of lean body mass compared to the non-desaturating COPD patients. Can it predict survival? Yes, it is a stronger predictor of survival in COPD patients. In fact, 6-minute walk distance can predict mortality better than other traditional markers of disease severity like age, BMI, FEV1, and comorbidities. In a study in COPD patients who had a walk distance of less than 150 meters, the overall survival rate at 3 years was only 34%. This is because the walk distance is not only influenced by the pulmonary impairment, but it is also influenced by the skeletal muscle dysfunction. And it also reflects both primary pulmonary and secondary manifestations of COPD. 6-minute walk distance can also assist us in selecting the patients for LVRS and transplantation. In pulmonary arterial hypertension patients, severe impairment of walk distance is seen. A walk distance of more than 400 meters is considered as a favorable prognostic indicator, and less than 300 meters is considered as a adverse indicator. Especially the desaturation during walk distance is a better predictor of mortality in these patients, and the studies have shown a 26% decrease in death for each % decrease in saturation during the test in these patients. Also, in clinical trials for the drugs for PAH, exercise capacity is an important outcome. The regulatory agencies have also accepted changes in 6-minute walk distance as an endpoint in randomized control trials. In IPF patients, it is a strong independent predictor of mortality. A baseline walk distance of less than 250 meters is associated with twofold increase in the risk of disease progression and mortality in IPF patients. Even in heart failure patients, a decreased performance is related to increased mortality, non-fatal cardiovascular events, and hospitalizations. However, walk distance is not a sensitive marker for change following the medical therapy in these patients. So summarizing my talk, 6-minute walk test is a useful measure of functional capacity. The test is widely used for preoperative and postoperative evaluation and for measuring the response to therapeutic interventions. Walk distance is a primary outcome of 6-minute walk test. Saturation has to be monitored continuously during the test. A lower walk distance is strongly associated with increased risk of hospitalization and mortality in patients with chronic respiratory disease. A low walk distance is non-specific and non-diagnostic. And when the walk distance is reduced, a thorough search for the cause of impairment is warranted. Walk distance is very sensitive to variations in methodology. 6-minute walk test has an excellent safety profile if the test is stopped if saturation falls below 80%. And lastly, minimal important clinical difference in chronic respiratory patients is about 30 meters. Thank you for your patience listening.
Thank you for a crisp presentation, madam.
Thanks a lot, Dr. Achanabi, madam, for a wonderful presentation. I thank Dr. Gayatri, madam, Dr. Ataullah Khan, sir, for chairing the session and sharing their knowledge with all of us. Thanks a lot. We have come to the end of the first session, the morning session. Now we will have the inauguration ceremony and felicitation program. It's an important program for all of us. On behalf of Trustable Hospitals and in association with Karnataka Pulmonology Association and Indian Chest Society Karnataka chapter and Academy of Family Medicines, Family Physicians of India, we are going to have an inauguration ceremony of this wonderful conference, and we are going to felicitate a wonderful dignitaries here. Thanks a lot. Please bear with us here. Chairs picking them.
Trustwell Hospital's logo or something?
We have this. This is enough. This is enough.
Hello. I would like to welcome all the faculty and delegates and all the guests of honors to be present here and blessing us. I would like to call upon Dr. Satish K.S. sir, a consultant pulmonologist at Manipal Hospitals and Fortis Hospitals, Cunningham Road, Bangalore. And sir is our president of Karnataka Pulmonology Association. Really grateful to have you here with us, sir. Thank you, sir. I would like to call upon Dr. Ravindra Mehta, sir, Senior Interventional Pulmonologist, ABAPS, Apollo Hospital, Apollo Bangalore Advanced Pulmonary Services. I welcome you on the dais, sir. Please do come. I would like to call Dr. Shashibhushan BL, Professor HOD, Pulmonary Medicine at Bangalore Medical College and Research Institute. Please occupy the dais. I would like to call Dr. Sandhya Nanjundaya, Madam, Senior Pulmonologist, St. Philomena's Hospital and Ramakrishna Hospitals, Bangalore. I would like to call Dr. Vishnu Sharma M, sir, Professor HOD at AJ Shetty Institute of Medical Science and Research Center. Sir is an amazing person. He's been a quizmaster for all our national conferences and he's been a wonderful PG guide. Thank you, sir, for being with us. Please do come, sir. Come on, the occupy the dais. Yes. I would like to call upon Dr. Harihara Murthy P. Sir is our senior ENT surgeon and sir is representing our hospital, Trustwell Hospital. Sir is special interest in sleep and thank you, sir. I would like to call Svecha for the invocation song.
गणनायकाय गणदेवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
I would like to invite all the dignitaries to please light the lamp and inaugurate this conference. I would like to call upon Dr. Hariyamurthy P. Sir to welcome the dignitaries.
Thank you, Dr. Shivlinga Swami. I deem it a great privilege to be standing before you here today. I am standing in for my colleague and director of the hospital, Dr. Deepak Haldipur, who's been called away on an emergency. Nevertheless, it's really a pleasure and privilege to be amongst you today. When Dr. Shivlinga Swami was talking to me about conducting this particular workshop, I thought it was a pretty novel idea to get to the energetic minds who are entering into pulmonology and interested in pulmonology, and get them exposed to some of the stalwarts sitting over here and off the dais. It is the best thing that can happen, wherein the best minds are able to instruct you in what would be the best way to go about evaluating and treating your patients. And I must congratulate Livewire Dr. Shivlinga Swami Salimat for having put together this particular workshop. It's my pleasure to invite and thank the dignitaries over here. To start with, Dr. K.S. Satish, who's the pulmonologist who most people know in Bangalore. He's heading the pulmonology department at Manipal, erstwhile Vikram. Yeah, Manipal Hospital and Fortis. He's also the president of the Karnataka Pulmonology Association. Welcome, Dr. Satish, to Trustwell Hospitals. Dr. Sashi Bhushan BL is the head of the Department of Pulmonology at the Bangalore Medical College and Research Institute. Sir, we are especially proud to have you here today. We have heard of the immense kind of work that you've been doing during the last 2 years, the challenges faced by your department in helping the people in the pandemic. Thank you for being here, sir. Dr. Sandhya Nanjundaya is a senior pulmonologist from the St. Philomena's Hospital and the Ramakrishna Hospitals. Madam doesn't need an introduction to anybody in this room, I'm sure. And we've heard a lot about her, and I've many of my patients have been taken care of, though she doesn't know about it. Thank you very much for being here today, madam. Dr. Ravindra Mehta is a senior pulmonologist who heads the Apollo Hospitals group in the Advanced Pulmonary Services, and my patients have never been disappointed when they meet him. Thank you very much for being here today, sir. And Dr. Vishnu Sharma, who is the head HOD of the A.J. Shetty Group of Institutions in Mangalore. We've heard about him being a very good quiz master and a great trainer of postgraduates from Shivling Swami. Thank you very much for being here, sir. We are also gathered here today to inaugurate the Trustwell Integrated Institute of Sleep Medicine. This is something that we have been thinking about for a long time, but like they say in Kannada, galige serig bandila. So we were never able to get together and make it happen. So when we have been treating patients with sleep disorders, sleep-related breathing disorders, we've always found that there is something missing, you know. And that something missing was precisely what we decided to address when we decided on getting this institute started. Coming together of different varied professionals is one of the biggest challenges in medicine today, wherein we work in our own silos and we are not willing to, you know, give up our position of preeminence, so to say. And here we were able to actually come together because in Trustwell we've got a very dedicated group of people. And I must say, with somebody like Shivling Swami, who was egging us on, we decided to put our heads together, because unless we are able to specifically look at the causes of sleep-related breathing disorders, and be it snoring, sleep apnea, etc., it's not possible to really treat the patient well and give them the relief that they're looking for. We decided the context that we will have is good sleep, not only for the patient, but also for their partner. So a rough estimate says about 20 to 25% of the adult population in Bangalore at least has got a sleep-related breathing disorder, which means we're talking about a huge number of people. All of you have to pitch in and, you know, make it happen to make this thing a reality. It's not only the responsibility of one institute. I think we need more hands on deck, as it says. So this is the context with which we started. So our institute is going to have a group of different specialities: pulmonology, ENT, facial-maxillary surgeons, oromaxillary surgeons, as well as physicians, psychiatrists, nutritionists, as well as pediatric surgeons and physiotherapists. So it's a motley group of people, and what we are coming together is to see which is the problem that this person requires. We are literally tailoring the treatment to suit each patient. And the speciality of this institute is we are going to have a sleep board. You heard of tumor boards for cancer. We are going to have a sleep board, a board of different specialty people who will be part of this decision making for the excuse me, so that we are able to comprehensively evaluate and treat a patient, literally a horses for courses kind of a treatment. This is what our intention is, and I'm sure with the intentions of Dr. Shivlinga Swami, who is helming this particular thing, we will be able to do that too. So I really would like to welcome all of you to this wonderful workshop, as well as being here at the start of this particular institute. And I'd like to thank all the dignitaries over here for having gracing this occasion and making us proud in Trustwell Hospitals. Thank you very much.
Thank you, sir. I would like to call Dr. Satish K.S. sir to give a presidential speech.
Hi. Good morning, everyone here. It's nice to see so many young delegates here, postgraduates. I hear they have come not only from Bangalore but also from outside. That shows how important is this workshop. And Dr. Swami, you've done a wonderful job getting, first of all, good speakers, who are going to deliberate throughout the day, and also good number of delegates. Also, you're on offline also available. So, which means many youngsters who could not make it can watch this workshop. So, when he came up with this idea about a month or two, and then asked me, I'm going to do this workshop on physiology, I said, okay, fantastic idea. First thing I said was, very good. I don't think anybody has done this physiology, respiratory physiology workshop. And I said, go ahead. And then he explained to me what he's going to do. It sounded very attractive and very interesting. Because I remember when I went to UK to do my fellowship in respiratory medicine, my consultant, Graham Sterling, he is a respiratory physiologist and a pulmonologist. He gave me his book first day and then said, Satish, you read about this and then we'll talk to you again. So I read about the applied physiology. All of us have read physiology to pass the exam. The MBBS exam we have read. But applying that, that is applied physiology. So that was very interesting to get back my memories of the spirometry, the drum that we used to use in physiology, and then various formulas, and then Barlow's law, Charles' law, Laplace's law, Henderson, Hasselbalch curve. So many things came up, and then I read about all that, and then was ready for the clinical as well as for taking care of patients on ventilator. Talking about 30 years back. And there was this guy, John, who was very well known, who was a PhD and some scientists on spirometry. Every time he used to come and discuss, this is like this. I could never figure it out what he was speaking and what he was saying, because it was so complicated. And he would explain everything about the curve, about this, and so on. So that's what I did in my fellowship. And then when Swami said, please do it, and then fantastic the topics that is being covered today, from ABG, FeNO, spirometry, 6-minute walk test, body box, and sleep, and everything is there. We generally hear about dialects about asthma, COPD, IPF, and pneumonia, tuberculosis. But this kind of a workshop is truly amazing. And thanks to Swami and his team, who have toiled for last 2 months or so, getting everyone together, getting the topics together, and also the hospital, Trustwell Hospital. Dr. Deepak is known to me from his undergrad days. When I was a PG in Victoria Hospital, he was a final year student, and he is a tough master. He's worked so hard in his life. He's an example for working so hard and coming up in life. And I've seen his clinic when I used to take my dog out for a walk in the evening, 10 o'clock, his clinic is still open with lots of people waiting outside. That's how he has worked. He's not here. Otherwise, I would have, ragged him nicely. So that's only to tell you about, hard work pays. There is no shortcut in medicine. There's absolutely no shortcut. If you want to become famous, like Dr. Ravi Mehta is, who's sitting here, who works from morning 7:30, 8:30 till whatever time. I'm just saying, everyone here, Jairaj is here, Revdi is here, Suma is here, everyone have worked hard and hard. For the youngsters, I'm saying, and focus in medicine. That's what is important, which will take you. Just don't worry about the future. Just focus, do your job, and learn, and be inquisitive to know about the subject and how to take care of your patient, and that will take you to the whatever destiny is, whatever the goal. So keep doing that, and this kind of workshop will help everyone. I wish I had time. Actually, I was supposed to be in Mysore, but I'm here because Swami insisted that I should be here, so I cancelled my Mysore trip. No, I didn't. I'm joking. Because of the rain, it happened. So he said, at least you send me your talk, and then I'll play it. I said I will be there. Honestly, I felt like being there from morning and listen to all this, and then refresh my memory. But I'll get to see he's got a nice book on that. So I'd like to end here, looking at all of you here, and I feel very happy and very proud. And I'm sure Sandhya, much senior to me also. When we came, we were just 5 of us or 10 of us in pulmonology and TB, and now the pulmonology in Karnataka, in Bangalore, is in safe hands, is in good hands. I can see here with all of you, and to take over the pulmonology for the future. Thank you, Swami, and all the best. Good luck also for your sleep medicine lab that you are planning. Very interesting that you're going to have a board and to discuss. It's complex, and Ravi can help you. Ravi is known as interventional pulmonologist, but his sleep medicine, and every 2 years or 3 years or I don't know, 1 year, he does a lot of work and then gets accredited from the American Sleep Medicine Association. So you can get help from him as well. All the best, good luck, and God bless. Thank you.
Thank you, sir. Your words are blessings for us. Thanks a lot, sir. I would like to call Dr. Ravindra Mehta, sir, to just give a speech and enlighten all of us. Thank you, sir.
Thank you so much, Swami, and thank you, Trusteal Hospitals, for calling us. It's a lovely venture. I think little is to be said after Satish speaks over here. It is after the final words have been said that we have to come with the epilogue, so to say. To add to what he has said, I think it's 2 ways to look at the field. Suppose I'm in your footsteps and starting now for the younger people. For the older people, we are either happy, disgruntled, or reconciled. So we're okay in life one way or the other. For the younger folks, it's always doubts. And recently, when I had a chance to interact with some of you, especially coming out of training, and we completely understand what's going on. The system is, you feel, has not taken care of you. The jobs are limited. You are bound by these rural postings and all, which are both in principle necessary, but in practice challenging. You don't know the writing on the wall. There's a whole bunch of subspecialties out there. And the biggest thing which nobody will tell you or you realize is that have you trained enough? And what you practiced, what you learned, can you practice or no? Or are you going to basically be taught how to drive what is a Mercedes, but you're ultimately left with a bullock cart on the road? So that is the biggest challenge right now. Well, we're here to tell you, and what Satish just said, is that 2-3 things matter in life. A, as he said, unfortunately, you feel very paternalistic when you say that, but it has to be reiterated and repeated, that there is no option to focus and hard work. Hard work necessarily doesn't mean that you slog day in and day out. There are people who do efficient work also. Ensure that if you decide that this is your agenda in life, and then if you can put it in a certain time frame and be efficient about it, you can get the same thing done. Why is that? Lovely resources, amazing resources. The days Jairaj, Satish, Dr. Nanjundayan and all and us trained, the one with the book was the master. The physician who read the book kept the book with him, and for 25 years he could carry on with the book. The rest he depended on a cultural system which was based on respect. That if you don't respect me, I am not going to do anything for you. The third was, I hold you for your examinations and your growth, that unless you play up to me. So that was the system. Come Y2K, everything has changed. It's all, knowledge is gone. No longer knowledge bastions can say that I know this and you don't know it. You know, as Jairaj, you must remember 15 signs of aortic regurgitation. I'm sure you're torturing your younger people still with all that over there. But all that is history. It's gone. It has no meaning at all. So knowledge is gone. You guys can get knowledge from wherever you want. Today, if I say something and it doesn't sound right to you, you'll open your phone as long as you have a good connection and you'll tell me, Dr. Mehta, you may not be right. This is the latest over there. And that's accepted. So with this strength of knowledge, if you can now sift through all the clouds and then move ahead, as he very rightly said, with efficient hard work, I will not say hard work only, with efficiency and hard work, with focus, and the last secret, just be consistent in what you do. Anybody who has been consistent, the sycamore tree for 70 years is a sycamore tree because it stood out there and just kept growing, and people who come 70 years later will say that, of course, this is a masterpiece. You don't have to be around for 70 years. None of us will master that. But by and large, if you're just consistent, you go in and day out, you're plugging at the same place every day, opportunity will come knocking at your door. So, and who can say better than that? In Bangalore, we're used to potholes. We drive every day. We're used to negotiating 10 potholes. We never think about it. Still, this crowd reached here in time. Still, we have this lovely session going. So, in short, if the new tools of life are, knowledge is there. Don't worry about it. Stay focused. Everybody who has stayed focused, hard worked, and consistent has been successful. Without exception, I can say that. And lastly, if you can find a mentor somewhere, and I think something we should look into as formal mentorship programs, get onto that bandwagon, because the job of a mentor is to make sure that you don't go through what we went through, and what we did in 20 years, you do in 5 years, so that somebody else behind you will do it in 3 years. If that can be done, there's nothing else required. In short, great time to be in the field. First, great time to be in medicine. Thank God COVID came as a calamity which stamped the fact that we are required as a field. You can't do away with us. 2, as a focused field, pulmonology, critical care, and everything else we do, it's lovely. 3rd, the expanded nature of the field. You know, you call yourself pulmonologist, but you're also internists, intensivists. I mean, look at this. Without a multidisciplinary plan, nothing can happen. So just get into that. You will. It's a lovely time, I think, for the next decade or two. As long as we can sift through the grain and figure out what is the most important thing. And with this positive note, you will approach learning, practice, and your future with much more energy, which I think is the need of the hour. Thank you so much.
Thank you, sir. The words of enlightenment, I can say. Thank you, sir. Now I would like to call upon Dr. Arun Vijay, sir, to please come and introduce our chief guest, Dr. Shibhushan BL, sir.
Good morning. Good morning, everybody. Without wasting much time, we are half an hour behind. So first at the outset, congratulations Swami for having us all here, and then wonderful. It's been repeatedly told what's the importance of this conference or the workshop is. Here, when he said that I have to do this job, I said, one, it is a proud privilege that I'm introducing my teacher to all of you here. And then I said, since I'm not the host, how would it look that I am saying the achievements of my teacher. It's always, the student is always proud of his teacher. Sometimes they even, what do you call, follow and become like teacher also. But yes, I am happy that Swami wanted me to do this. I've known Professor Sashibhushan sir from almost 20 years now, when I joined pulmonary medicine as a PG in 2002. So I have had a lot of firsts with sir. Sir has done his undergraduation from KIMS, and then he went for his post-graduation from JNMC Belgaum. I am sure, I think only he and 1 or 2 batches have MD pulmonary medicine, rest all have respiratory medicine or respiratory diseases. And he's been associated with Bangalore Medical College for about 22 years now, since he joined Bangalore Medical College in 2000. Sir has been actively involved in all respiratory activities. From 2000, he was involved in, initially we were the only people dealing with MDR tuberculosis. All over the state, referral used to be with MDR tuberculosis to begin with. Then we had one more pandemic we have seen. This is the second one that we are seeing. We saw H1N1, where again we were the referral center, and I'm proud that I was associated with sir during that time also. We were involved in managing H1N1 patients. All the patients, VIPs, VVIPs, everybody referred to our institution. And then, sir, after post-graduation, he was involved, like even when he was there, when I was a PG, he was involved in PG teaching and very, very close to students. He will go out of his way to do whatever is required for the students. Even today, he is that way. And in the recent pandemic, sir, I have to tell this to everybody, that we might have taken 1 or 2 days off, or we might have had quarantine period, but all the 2 years, I keep telling him now also that he came every day to the hospital. Every day he came to the hospital. And one thing more which I have to learn, or if I have to still inculcate from him, is punctuality. If he says I will be there at 9, he will be at 9. Even before that also. And for last 22 years, I have seen him. He is on time and he is there available all the time, 9 to 4. And during the pandemic, he had to go around places, meetings. He did a lot of guidelines were issued for the management of COVID patients. And one more thing I always keep telling him is, he drew his way all through. He did not take anybody's help, and was involved in a lot of, I don't know how 2 years he kept himself without getting into any infection, I should say. He's still COVID negative in our department. So all of us, so I strictly following guidelines, sir, preventive guidelines. So if I, like I said, a student is always inspired by his teacher. So if I keep telling about sir, I can go on for the day. Here are some of his contributions during the recent pandemic. He was a member Technical Advisory Committee, Karnataka State, Nodal Officer for Central of Excellence, Department of Health and Family Welfare, Government of Karnataka. He was also member technical expert for treatment protocols, Rajiv Gandhi University. Yes, through the university, he was also involved in training all the healthcare workers, not only doctors, nursing staff and other healthcare workers. He is a core committee member at Victoria Hospital, dedicated COVID hospital for almost 2 years now, and is a vice president of Sleep Association of India. Sir has a keen interest in sleep, and we are proud to say today Swami is also starting one of the wonderful sleep centers. We also have a wonderful sleep lab and run RGHS recognized sleep fellowships. I don't think any other university has a sleep fellowship across the country. We were the first. Because of such interest, we could get fellowship in sleep medicine. So I hope there is many things to happen. So thank you, Swami, for this opportunity.
It's a great honor to felicitate Dr. Shibhushan BL sir. He's been a teacher of teachers, and sir has been a great inspiration for all of us. I would like to invite all the dignitaries to please felicitate our chief guest, Dr. Shibhushan sir, on this wonderful occasion. Yes. Thank you, sir. I would like to call upon Dr. Suma P. Kumar, madam, to introduce our second chief guest, Dr. Sandhya Nanjundaya, madam.
It's a great honor and my pleasure to introduce Dr. Madam Sandhya Nanjundaya, who has got over 4 decades of experience in the field of medicine and pulmonology. She is our senior most accomplished woman pulmonologist. She is the first woman bronchoscopist of our state. And Madam tells me that there were only 3 women bronchoscopists in the country when she started doing it. So it's a huge honor and pleasure for all of us to be with her today. So we are proud that she is here with us. And after her MBBS from BMC, I'm an alumnus of BMC, as many of you are, so we are very proud that she is also from BMC. She pursued her postgraduate studies in the United States of America, in Washington, D.C. and Georgetown University. She is a founder member of Asia Pacific Association for Bronchology, which she headed in 2007, and a founder member, past president and only lady president for the Indian Association of Bronchology as of today. She has served as a member of Governing Council of Indian Chest Society for about 3 years, and that's when an APCON happened in Bangalore. That's the only time. So it is a great honor for us. She has been conferred as a fellow of American College of Physicians, Indian Chest Society, and Indian Association of Bronchology. She is also a patron of KPA. She has Lifetime Achievement Award conferred in 2015 by Indian Association of Bronchology, in 2016 at the PulmoCon, and at 2017 the AC Shaw Oration Award at IAB. Madam has contributed to many textbook chapters on tuberculosis, extrapulmonary tuberculosis. She has keen academic interest. She has been part of the many surveys of bronchoscopy, surveillance, etc. in the country. And she also, as in 2022, she has contributed to a chapter in pulmonary diseases in women, which has been recently launched, as many of you may be aware. Madam has done a chapter on pulmonary endometriosis. So it's a great honor and privilege that she is here, and she has really lit and paved way for many of the pulmonologists here today, and it's a great honor to invite her onto the stage.
I request all the dignitaries to please felicitate Madam. She was the one who first, when I came to Bangalore, I wanted to start private practice. When I met Mr. Prem at Ramakrishna Hospital, she said, Sandhya Madam is there, why don't you go meet her? I just went and met her, and she was a source of inspiration for me to start my private practice career. Thanks a lot for that, Madam. Amazing. Yeah. Thank you, sir. I request all the dignitaries to please felicitate Madam on this occasion. Of course, and I'll call Dr. Gayatri Madam, Kiran Krishnamurthy Madam, Kavita, Dr. Archana Madam to please, Dr. Uma Devraj Madam to please come and felicitate me. Of course. Of course, sir. Of course. Thank you, sir. This is the picture which was taken in Chennai, where this Pulmonary Disorders in Women book was published and launched just 10 days back. This is the book where many of our beloved pulmonologists, lady pulmonologists have written across India, and Dr. Uma Maheshwari, Dr. Uma Devraj Madam, Dr. Priya Ramchandran, and Dr. Sanjay Nanjada Madam are all the authors of multiple chapters in this book. It's definitely a must-read book. As soon as it's published, definitely I'm sure Madam will share some of the all those books with all of us. Thank you. We'll proceed to vote of thanks. No, sir. It's launched, but the copies are not been made available still. Yes. Yes. Yes, sir. Sir, if you can just so please occupy the desk. Yes, for the vote of thanks. Yes, sir. Yes. I'd like to thank. Yes, sir. Yes. I would like to thank Dr. Ravindra Mehta, sir. He's been a great inspiration for me during my international pulmonology journey. Thanks a lot for being here with us, taking your time out, sir. Thanks a lot, sir. Yes, sir. I would like to thank Dr. Shashibhushan, sir, for being here with us and accepting our heartful felicitation on this day. Thanks a lot, sir. I would like to thank Dr. Sanjay Nanjada Madam for being here with us and accepting our felicitation on this occasion. Thanks a lot, Madam. I would like to thank Dr. Vishnu Sharma, sir, for coming all the way from Mangalore and guiding all the PGs. We are yet to listen from sir. He is an amazing personality. Thanks a lot, sir, for being here with us. Thank you, sir. With this, we come to the end of the inauguration felicitation program, and we will continue with the second session, the scientific session. We have to call Dr. Vishnu Sharma, sir, to chair the next session, and I'll call Dr. Jairaj, sir, to chair the next session, sir. The next speaker of the day is Dr. Satyanarayana Mysore. Sir is a renowned pulmonologist. Yes, sir. Yes, sir. I'd like to call upon Dr. Satyanarayana Mysore, sir. Sir is a senior pulmonologist, a renowned pulmonologist. He's been a pulmonologist of all the VIPs in Karnataka. And one second, sir. Sir has treated almost all the VIPs across Karnataka during the pandemic time, and also sir is a great academician. His special interest in respiratory physiology is tremendous. It's glad to hear from him. I'd like to call Dr. Satyanarayana Mysore, sir, to please come over the dais. Yeah, keep the chairs down. Yeah.
So, one of the most daunting challenges in real life practice is when you find patients coming in and saying breathless. I am breathless, I want to know the reason. And you do a spirometry, it is normal. you do other tests, you do scans, and you will find that at times most of them turn out to be normal. So what causes breathlessness and how do we evaluate? And can we make use of cardiopulmonary exercise testing, CPET or CPET, which is a great tool. So George D'Souza was my teacher, and I have at times in my practice, I don't shy away from using a phone a friend or 50-50 and get advice. And this is exactly what was discussed here, that it is broad consultative approach. There has to be no ego. Now dyspnea, you all know, is subjective discomfort that comes in with for accustomed activities you start noticing awareness of your own breathing. But when you try to look for a cause, it has got to be, is it ventilatory, is it diffusion limitation, is it gas exchange abnormalities, or is it due to pulmonary vascular abnormalities, or simply a bariatric limitation on breathing. Therefore, it is easier to find pathway to salvation rather than finding the cause for dyspnea. The reason is the very act of rate, depth and rhythm of breathing is very complex, and it is an integrated pathway. Therefore, evaluating that in reverse order, that is looking for the cause of dyspnea, is actually difficult. You will need to know what is inspiratory drive, what is operating lung volumes, muscle conditioning or deconditioning, gas exchange and dysfunctional dynamics to the pump. When we look at this particular graph, end expiratory lung volumes, or in other words, I will try to keep it very, very simple. The lung has the natural tendency to expand towards outside, away from the hilum, and you have a counter regulatory force that is the resilience that brings the lung towards the hilum. So the balance of these counteracting forces at equilibrium is the FRC. So here when we see what happens in normal state and disease state, simple way of saying is that if the operating lung volumes, that is end expiratory lung volumes, are higher than normal, as it happens in COPD, the way to describe that is, it is easier to squash a 5-liter balloon compared to trying to push down a 15-liter balloon to empty it. So that is exactly what happens here. You can notice that volume versus pressure, the amount of dynamics required in a hyperinflated lung is very difficult, and that is what causes dyspnea. So if there is dynamic hyperinflation, let us say somebody tries to breathe 40 times a minute, and can they overcome the dyspnea? That is one of the speakers had put up all the lung volumes and capacities. 2 volumes, when you add up, you get a capacity. So even if there is dynamic hyperinflation, or let us say you increase the RR, you will only end up compromising the tidal volume, and the buildup of RV and ERV in relation to TLC increases, and that is what we call as dynamic hyperinflation. Now there is neural drives that control the respiration. There is also the mechanism of all the PEEPs, 3 PEEP, intrinsic PEEP, auto PEEP, extrinsic PEEP. Now the basic meaning of PEEP is that during the process of deflation, air moves from point A to point B with high velocity, and you have a collapsing lateral pressure which will compromise the lumen, and that adds on to retention of some amount of air distending the alveoli and incomplete evacuation. So when this happens, you will have that you need to take a bigger breath to satisfy that sensation of suffocation, and that creates air hunger, which will have stimulation on the inspiratory drives. So impact and measures of dyspnea. We know that we have standalone FEV1 from spirometry. Speakers have spoken very well about it. But FEV1 does not reflect all the systemic manifestations of COPD or even the physiological impairments. All of them cannot be fixed to one particular value. So also the board's index, which incorporated many variables into one, including the body mass quotient. However, when you look at it, excluded heart failure, unstable angina and other illnesses. Therefore, you need one single integrative matrix, and that is CPET. So what is CPET? A subject will sit on a bicycle and various parameters are measured. We will go through each parameter, and when you start exercising, the amount of air moving in, moving out, sum of all ventilation is called VE. You can calculate V max by looking at FEV1 and multiplying it by factor of 35 or 40 in men. The carbon dioxide and the oxygen consumption. So at aerobic respiration, when there is a ramping up of effort, say you are starting cycling or jogging, your aerobic respiration will hold for some length of time. By then, in the next phase, there is a limitation to what oxygenative energy can provide, and therefore you also end up producing lactate from the muscles. You have loss of bicarbonate and the buffering of hydrogen ions from the lactate that is getting released from the muscle starts, and this is the second phase of subjects doing any aerobic activity. And here you will notice that the VE will keep increasing. There is no VE limitation. The max is defined by the person's FEV1. Static spirometry will give you that. The VCO2 will behave differently. In a patient with heart failure, the VCO2 will tend to be on the lower side because constantly they are hyperventilating and blowing out their CO2. Let us say we take individuals with peripheral vascular disease, the muscles are atrophied, their ambulation is less, and they will not produce that degree of lactates or exercise commensurate with the activity to produce a buffering mechanism from the muscles. So the isocapnic buffering can fail in certain individuals. This failure of buffering will give us an idea of what is the exercise limitation in these individuals. When the buffering mechanism is exceeded, you will find that the individual is in metabolic acidosis, and that is where the point at which you have the lactate buffering system going up as what we call as anaerobic threshold. And at anaerobic threshold, we can also define that is the point at where the respiratory equivalents will come in, or respiratory ratio, which is VCO2 divided by VO2. This is a kind of complex equation, but in a simple way to understand at the level of postgraduate students is that aerobic energy, aerobic metabolism has been exceeded. You have anaerobic energy kicking in, so you are making use of alternative energy sources. Your buffering mechanism is at the maximum. So in a view to simplify, the best parameter to look at is VO2. Peak VO2 when we measure of an individual, what we mean is oxygen in, oxygen out, and what is the residual quotient. That is what you are looking through, and the tachometers is what measures the pulse waveform and absorbs the VO2 that you are breathing out or taking in, and this will give us the measurable peak VO2. If that is normal, peak VO2 is normal, and VE max, that is ventilation is not limited. Heart rate tends to be a initially hyperchronotrophic response. Heart rate is going faster because they are deconditioned, but no desaturation, and VO2 levels are normal, cause of dyspnea tends to be either anxiety, obesity, or mild disease. If the VO2 peak is low and the anaerobic threshold was reached very early, and the VE or breathing reserve is low, then it is a mixture of both cardiovascular, pulmonary, vasculature, and airway diseases. It's a mixed lesions. If the breathing reserve is normal in such a situation where the AT was very low, it is circulatory impairment. So this is a very simple way of interpreting. There are algorithms, automated algorithms. One such algorithm was released by ATS in 2007, I think. However, that did not have reproducibility of values. So CPET is an extremely important tool. There are handouts given on easy interpretation of CPET. So looking at some of the variables which I said we will define is the highest value of oxygen consumption during peak exercise, expressed as liters per minute or liters per kg per minute. 80% predicted means generally means not much pathology either in the heart or the lungs. VE I defined earlier. So you can measure that by multiplying the FEV1 times 35. It can be derived from minute volume ventilation as well. More than 80%, meaning no further increase is possible. So that is a finite value. So with this, I think this will be an introduction towards CPET. The handouts provided will be more illustrative and will be available to explain that one on one. Any questions? Okay.
Any questions from the board? It's a vast topic actually, very important. CPET, as far as CPET is concerned. How often? Not all the order of CPET. How often is it done?
Correct. So CPET, you are basically asking about the indications for CPET. Right from evaluation of undifferentiated dyspnea, we do not know what is the cause of breathlessness. You have done an X-ray, your clinical examination is normal, your spirometry is normal, there is no diffusion abnormality, yet you are wanting to find a cause of dyspnea, then you ask for a CPET. Suppose you want to look at heart-lung transplant, then you need to do CPET. Now there is another valuable parameter that I have not alluded here called VE by VCO2 slope. Now that slope has been taken up in a big way in perioperative assessment of patients before any surgery, including bariatric surgery. So these are some of the most important indications for dyspnea, and you can use it in athletes. Suppose somebody was swimming at a national level, suddenly they are experiencing dyspnea at the finish line and they want to know what is wrong. So sports medicine has indications, and generally even in airways disease, we have found at Manipal people who have normal spirometry, FeNO almost borderline or variability in FeNO levels, clinical history very suggestive of asthma, but patients don't want the label of asthma at that point of time. You do a CPET and you find that you are able to explain. Any other questions? Thank you.
Thank you, sir, for the brief introduction of CPET. Actually, not every institute has the luxury of having CPET. That's the problem now, because the huge cost involved. But it's a very, very important tool when we are not able to know the cause for dyspnea with all the routine tests that are available, like simple spirometry, ABG, exercise ABG, walk test. So many things we are not able to explain. Some people, we need to have CPET to pinpoint the cause for the dyspnea. So in that situation, I think definitely this is going to help us a lot. But we don't have a luxury of having this in every institute. So sir might help us if you get, sir, you have in your institution other CPETs? Yes. Then I think sir will help us out in case we have any cases we need to be evaluated by CPET, we can refer those cases to him. Thank you, sir. Thank you for your brief and excellent lecture.
And thank you, sir. Thank you, sir, Satyanarayana sir. Sir, amazing talk, sir. It's always good to learn basic physiology, understand dyspnea much better, so that we can apply it in our regular practice. Thank you, Jairaj sir, and thank you, Vishnu sir, for chairing this session, sir. And all the postgraduates, there is a separate CPET station, so all of you can have a look at the instrument and know how exactly it functions, and you can definitely have the benefit of it. Thanks a lot, sir. Thank you, sir. For the next talk, I would like to call Dr. Shashibhushan sir to please chair the session, and Dr. Kishan sir is a consultant nephrologist at Trustwell Hospitals to please chair the session. I would like to call Dr. Srivatsa sir. Dr. Srivatsa Keshwaran sir is a consultant interventional pulmonologist at Aster CMI Hospital. Recently attended sir's program at Aster CMI EBUS Ace the EBUS workshop. It was amazingly organized, and sir has been a source of inspiration for all our youngsters, and he actually leads all of us. Thank you, sir.
Is it an asked? Okay, so I hope all of you can hear me. Yeah, very good morning. I'm Dr. Srivatsa. At the outset, I'd like to thank Swami for organizing this program, and kind of fascinated how all of you are sitting here stomaching, physiology lectures one after the other, and this has always been a very intimidating subject for me to grasp. And I'm quite puzzled how actually to present physiology to you in 15-20 minutes and how you will grasp the major concepts. Though physiology, nevertheless, I must underscore, is interlaced and ingrained in the basic practice of critical care medicine and respiratory medicine. And it's very essential to have your basic physiology concepts good to approach any kind of clinical case which you deal with on an everyday basis. So Swami tells me to talk about ABG analysis. So I will stick in the interest of time to understanding the basics of interpretation of ABG rather than technical aspects, because there's various ways of drawing ABG or VBG, and then you have arterial lines nowadays. So we'll not go into too many technical aspects. That will be dealt in the workshop. So I'll concentrate basically on interpreting arterial blood gas. So ABG analysis basically refers to the measurement of pH and the partial pressures of basically two important gases, oxygen and carbon dioxide, in your arterial blood. Now from these values, we can assess two primary functions of the lung. One is the gas exchange, and the second is to maintain acid-base balance in the body. So first, let's focus on understanding ventilation through arterial blood gas. So before we go into that, when you have a vessel filled with a particular gas, and that gas is exerting a particular pressure, for example, let's assume that to be P1. Now, your lung is a mixture of gases, so you have a mixture of gases exerting their different pressures. So we will usually have the prefix as P, that is the partial pressure. So if you have P total and there are two gases in the vessel,
you will call it P1 plus P2. Very simple. This is called Dalton's law of partial pressures. Now, translating that into real life, if you're breathing in air, there is a mixture of gases, and predominantly we are interested in two gases, that is oxygen, carbon dioxide, and your PaO2 in the gas exchange unit before gas exchange starts is around 105 mmHg, okay, and your PCO2 is around 40. Now, as we go down the gas exchange process, you will see that there is a transition of the partial pressures from oxygen going down to carbon dioxide going up, and then the blood is returned back to the air, to the lungs, so that the carbon dioxide is thrown out. So when you go into the pulmonary veins, you can see that the PaO2 is roughly around 100 and the PCO2 is about 40, and then once it passes down into the systemic capillaries, you see there is significant dissipation of oxygen that happens there. Your PaO2 goes down to 40 and your partial pressure of carbon dioxide starts climbing, and this venous blood is come back to the right heart and then goes into the lung again, and this is the way this circulation happens. Now, there are certain things in medicine that needs to be remembered or rote read, because I will be going through many more formulas in the future about how compensation happens and other things. So these are values which you must keep in mind, and for any pulmonologist this should be at the back of his hand. So for a normal arterial blood, the pH is around 7.35 to 7.45. The PA pressures of carbon dioxide is roughly around 35 to 45, and your bicarbonate levels are at around HCO3 is bicarbonate is around 22 to 28 milliequivalents, and your partial pressures of oxygen are around 80 to 100. And then when we move on to venous blood, it is roughly around 7.3 to 7.4, slightly more acidic as you can see, and the carbon dioxide is slightly higher, and your bicarbonate 24 to 30 holds good, and your PaO2 of course drops in venous blood. Now, there are various circumstances where you will draw only arterial blood or venous blood. Venous blood is more easily accessible because you don't need to secure an arterial line, or you don't need to do a difficult puncture into an artery. So, but nowadays, since most critical cares would be using an arterial line, it is very easy to draw arterial blood gas. But venous blood gas has its own importance in day-to-day surveillance, most of the time in metabolic critically ill patients. So what is respiratory failure? So respiratory failure is when your oxygen levels in your arterial blood gas PaO2 is less than 60 millimeters of mercury. So that is the clear-cut definition of how you are going to define a patient with respiratory failure. Now, based on mechanics, this can be further classified as a hypoxic respiratory failure, or otherwise called a lung failure, or there is a pump failure. The mechanics fail. Okay, so the problem is either at your gas exchange unit on one hand, and the problem is at the mechanics on the other hand. And quite simply put, this would be classified as type 1 respiratory failure or type 2 respiratory failure, which is very essential to understand and how to interpret this on the ABG. Now, there are numerous causes for type 1 as well as type 2. The intention to put this slide up is so that you basically understand the basic pathophysiology of these two types of respiratory failures. So in type 1 respiratory failure, it's very easy if you go through it sequentially. As the air enters inside, you're always wondering what is the fraction of inhaled oxygen in the air, and this varies both at sea level as well as high altitude. And most of you know, as we go higher in altitude, the fractional inhaled oxygen automatically falls. So lower partial pressure or inspired oxygen is one such reason for hypoxemia. And then when you go on to the next part of it, that is alveolar hypoventilation. So one example is opiate overdose. So you have a patient who is hardly breathing, he is hardly pushing any kind of breathing. then you will have your oxygen levels gradually decline in the blood. And then you have something called as impaired diffusion. So your oxygen that has gone into the gas exchange unit has to pass through a thin membrane and go into the blood vessel. Now any kind of disturbance in this membrane, as we call it diffuse parenchymal lung disease nowadays, can cause some kind of hypoxemia. And these are some things that we come across in our day-to-day clinical practice. Then we have something called as a ventilation perfusion mismatch. Some of the diseases that we commonly see, like for example COPD or pulmonary embolus or even pulmonary edema in our day-to-day practice, happen because there's a lot of disturbance of how ventilation happens and perfusion happens across the lung. Normally there is a VQ gradient from top to bottom of the lungs, as you're all aware, and any disturbance either causing a shunt or a dead space in the extremes and anything in the gray zone can cause a VQ mismatch. And then you have a shunt. For example, you have arteriovenous malformations or pneumonias that can again lead to hypoxia. So now we are dealt with type 1 respiratory failure on your right side. Let's move on to type 2 respiratory failure. So the lung is like a bellow, it's a pump. So the mechanics of the lung are controlled right from your central nervous system all the way down till the neuromuscular junctions. So any problem in the drive of respiration involving the brain. So for example, you have a patient, I'll not go through all the examples listed there, just throw up few examples so that you understand what we are talking about. So any person who comes in with encephalitis or hemorrhage or any kind of trauma to the brain will have some kind of dysfunction in his breathing bellows, which will consequentially increase the carbon dioxide levels in blood. Then comes the high load. So for example, you have a muscle that can only sustain a particular type of load, and this person is having a lot of wasting of the muscles. Then also you will have this person going into type 2 type of respiratory failure. And then you will have an innate deficiency in the muscles where the muscles don't contract itself. For example, muscular dystrophies or inflammatory myopathies, and that itself can lead to type 2 respiratory failure. Last but not the least, we have patients who have polio. In fact, the reason for ventilator or the invention of a ventilator came because of a primary neuromuscular dysfunction caused by a disease like polio, and the understanding is that the ventilation doesn't happen well and carbon dioxide doesn't get thrown out when the neuromuscular junction is involved. So differentiating type 1 and type 2 respiratory failure, like I already have gone through, basically what happens is your PaO2 alone reduced is called type 1 respiratory failure. In addition to a drop in your PaO2, if your PCO2 is climbing and is above 50, you will classify it as type 2 respiratory failure. Now your professors will go ahead and ask you whether, if making sure that you have read Harrison's, whether you know about type 3 or type 4 type of respiratory failure. But this is purely based on lung volumes, and it does not have any significance in the ABG as such. I thought I'll put out this so that this is a learning point to take home at the end of this lecture. So basically type 3 type of respiratory failure happens when the FRC or the functional residual capacity falls below the closing volume as a result of atelectasis. Usually seen in patients who will undergo anesthesia or are in the supine posture or splinting. You know, we have a rib fracture and you splint the patient's chest. This is the type of respiratory failure that you will encounter. And then you have the type 4 type of respiratory failure, which is shock with hypoperfusion. That is, a proportion of the cardiac output to the respiratory muscles rises by as much as 10-fold when the work of breathing is high. And this can seriously impair your cardiac perfusion, and that is called as type 4 respiratory failure. Well, it is always, I think Dr. Gayatri kept telling us that it is important to understand the clinical application of any tool or respiratory physiology that you're learning about. and if you do not apply it clinically, it's not going to stay inside. So ABG is very simple, I'll tell you. It might be intimidating, but it has 5 basic steps that you will have to master. So if you know these 5 basic steps, ABG is very easy to master. But if you do not practice it, on a day-to-day in your clinical practice, it is not going to stick with you. So let's go. I always like doing my presentations with cases so that it is more interesting for discussion's sake. So here we have a 65-year-old lady with a history of COPD who presented with 2 hours history of worsening dyspnea, and on a recent admission she had been intubated and ventilated, but she recovered quite quickly. Her exercise tolerance normally was about 100 meters, and the past medical history was of chronic low backache and some restless leg syndrome. On examination, you have expiratory wheeze. She is tachypneic quite obviously, but she is oriented, hemodynamically stable. Investigations just giving us clues of what possibly might be going wrong, but X-ray shows absolutely hyperinflated lungs, no possibility of pneumonia or anything, and the arterial blood gases were collected. The pH is about 7.28, PaCO2 is around 67, PO2 is about 52, and your bicarbonate stands at 26. Now anybody wants to try what this person is having? Any what type of respiratory failure is this person? Type 2. So quite obviously your PaO2 is less than 60 and your PCO2 is above 45. So this patient is having a type 2 respiratory failure. But the next question comes, is this patient compensated or uncompensated? So uncompensated. How do you know that the patient is uncompensated? Is there a way to calculate that? Yeah. So before we go on to that, let me be clear here that inevitably any derangement, physiological derangement in the body has an innate capacity to compensate only. Underline that, compensate only. The body will never overcompensate. Okay? So we must understand that when a patient comes to you and you feel that the pH is kind of overcompensated, you might be actually dealing with 2 problems rather than 1. So I shall deal with mixed disorders later, but basically what this patient has by approaching this by the 5-step method is first acidosis, second is you have a combination of raised bicarbonate and raised PCO2 indicating respiratory acidosis. There were no other clues apart from the patient having COPD, and the compensation you will calculate by using a compensation formula. But basically before I jump into the formulas, let me say that expected rise in bicarbonate is about 1 millimole per liter for any 10 mm Hg rise in PCO2. So roughly a PCO2 has risen by 17 mm Hg in this patient. The expected bicarbonate is just under 26. Very close to the actual measured value. So we are very clear here that there is no evidence of a second acid base disorder. Now this patient has a acute respiratory acidosis. Okay. Now let's go on to the next thing. Now I showed you sequentially how type 1 respiratory failure happens and type 2 respiratory failure happens. Now is the ABG good enough to tell us to position ourselves on the sequence of events that happen, that the respiratory failure is happening at the level of the muscles, the respiratory failure is happening because of diffusion fault, is happening because of ventilation perfusion mismatch? So what exactly can help us on the ABG to understand that? There comes something called as a AA gradient. So what you are looking at as the AA gradient is the total PO2 entering the alveoli minus the total PO2 leaving the alveoli, and that is getting absorbed in the blood. Okay. Now the formula is quite complex. Basically you need FiO2, the partial pressure, the barometric pressure, and your inspired air which is already humidified. You will try to remove the water, the pressure exerted by water vapor, and your partial pressure of dissolved carbon dioxide as well as the respiratory quotient. Any which ways, remember one thing, the AA gradient in a normal healthy adult is about 20. Okay, so now let's go on to the next problem. You have a climber who's coming down from the summit of Mount Everest, and at an altitude of around 8,400 meters, roughly 272 mmHg, he has a blood gas drawn while breathing ambient air as a part of a research project. Now the blood gas reveals the patient's pH is around 7.55, PCO2 of around 12, PO2 of around 30, and a bicarbonate of 10. So what is this patient having? Is he having acidosis or alkalosis? Alkalosis. Okay. So that's the first thing which you will approach. Now tell me, is the patient having respiratory alkalosis or metabolic alkalosis? Respiratory alkalosis or metabolic alkalosis? Look at your PCO2. It's washing out almost all the PCO2, and PCO2 is far below the normal range. Now, what is the compensatory process for this? So, the metabolic acidosis is the compensatory process. So, the summary is primary respiratory alkalosis with metabolic compensation. Now, that's done. We have already approached that in the first step. Now, what am I dealing with? The AA gradient. Now, if I plug this 272 mmHg in this formula here and calculate this guy's the AA gradient, it will roughly come to about, I don't have time to sit and calculate and show you, but it will roughly come to around 2.3. This is far below the normal AA gradient. Okay. Now, let's go on to how to approach the AA gradient. So, this algorithm is very important. So, you have a patient with respiratory failure, you obtain an AA gradient, then you match it with a calculated AA gradient or predicted AA gradient to the person's age, and that is calculated by below age divided by 4 plus 4. Now, if it is a normal AA gradient, check for the PCO2. If your PCO2 is less than 45 or the person is basically trying to hypoventilate himself, it means that the fractional inhaled oxygen is less or the person is at high altitude. If the clinical scenario is given, it is very easy that this patient is at high altitude. Now, let's go on to other types of hypoventilation. Of course, you will have patients with CNS as well as neuromuscular problems who can lead you to have hypoventilation, like I already discussed. There what you need to have is another value called maximum inspiratory pressure. So, if your maximum inspiratory pressure is normal, it indicates that this patient is having a CNS pathology. If there is a decrease in the maximum inspiratory pressure, then you can put your pathology in the peripheries, the chest or the neuromuscular junction. Now, let's go on to the increased AA gradient. Now, what if the person has increased AA gradient? You keep tuning up your oxygen. The person is in respiratory failure. Even before doing all that, your attendant would have already started the patient on oxygen, and you will be wondering why the patient's oxygen levels are not going up. Have you encountered a case like that? Especially if you see a large right to left shunt and you keep tuning up the oxygen and it does not improve, quite obviously it is a case of shunt, right? Well, if that does not happen, then you move on to a VQ mismatch, right? So here we have two different scenarios where your ventilation perfusion ratio is increased or decreased. So increased when there is a decreased perfusion or something called as a dead space. Not exactly dead space, but that forms the gray zone, it's a spectrum of dead space. So you have pulmonary embolism, pulmonary hypertension, vasculitis there. And then when you have decreased ventilation, you have obstructive, restrictive or alveolar pathologies. You will further classify it based on DLCO. So your ABG stands a very crucial point to determine the type of pathology you have in a person with respiratory failure. You can actually play around with your ABG and determine where exactly to place the physiological dysfunction of a patient who comes into your critical care practice or emergency room. Now, summing up the respiratory impairments, I have one left. I will cover that later. I'll tell you why. So in type 1 respiratory failure, you have your PaO2 go down, PCO2 also go down. In type 2 respiratory failures, you have your PaO2 go down, but your PCO2 shoot up. But the only difference there is your compensation. So if you see in chronic, your bicarbonate is already going up, whereas in acute, your bicarbonate stands still at the same point. Then last of your respiratory impairments, which you will assess, is something called as a hyperventilation, where the patient's PaO2 is constant, but your PCO2 is getting washed out, right? And your bicarbonate depend on whether this is an acute issue or a chronically happening hyperventilation syndrome. So most causes, usually there are primary as well as secondary causes. The primary causes are anxiety, hypoxemia, salicylate toxicity, and hepatic cirrhosis, pain, fever, or CNS disorders. Secondary causes are metabolic acidosis. So as a compensation, your patient will start having hyperventilation. I will not go into the clinical signs and symptoms of hyperventilation, which is a separate talk by itself. Now let's move on to the next important point we are deciphering while dealing with an arterial blood gas, and that is, I don't know, I'll have to rush. Give me at least 5 minutes. So the normal pH of the human body is about 7.35 to 7.45. Okay. Now what is an acid? So an acid is a solution when dissolved liberates free hydrogen ions and it lowers the pH of the body. A base is a solution that accepts hydrogen ions and hence it increases the pH. So acidic is less than 7.35, alkaline is above 7.45, quite simply. Okay, and a buffer is a substance that can change its attitude depending on the environment. So it will either receive a high H plus or give a H plus, and that is what is a buffer. Most importantly, why I am trying to tell you this is the most important formula in acid base gas interpretation is this formula. One is this carbon dioxide here combines with water in your blood to form carbonic acid, and that carbonic acid will dissociate to form hydrogen and bicarbonate, and this formula will go to and fro. You understand? So any compensation or decompensation happens because of change in this formula. Now a lot depends on the ratio of carbon dioxide to bicarbonate in the body. Okay, so I'll tell you a simple rule: whichever direction carbon dioxide goes is the direction in which the bicarbonate will also go. Okay, follow that. So if the carbon dioxide goes up, the body will start pushing the bicarbonate up. If the carbon dioxide comes down, the body will start pushing the bicarbonate down. Very simple. Keep that in your mind. Now, unfortunately, we have two different organs dealing with this. We have the lung that controls the carbon dioxide, which is good, and the bicarbonate that is being controlled by the kidneys. So this highlights the role of two organs that help in acid. Very important, and that's why we have a nephrologist sitting here in the podium moderating this session. Now, there are various causes of acidosis as well as alkalosis. You have metabolic acidosis, respiratory acidosis. So again, metabolic acidosis is of two types. You have high anion gap acidosis, you have normal anion gap acidosis, and alkalosis, again you have respiratory alkalosis and metabolic alkalosis. Let me not jump into the causes. I think most of you are aware of the most common causes for these types of acid-base disorders. Now let's look into compensation. Very important to understand compensation. So you have a patient who have respiratory acidosis. The carbonic acid excess causes blood levels of CO2 to go up. Now what does the kidney do? This is a respiratory acidosis. The kidney pitches in as a friend to compensate. So the kidney eliminates the hydrogen ion and retains bicarbonate ion, and it also generates new bicarbonate ion to maintain homeostasis. Similarly, in metabolic acidosis, what happens is the renal excretion of hydrogen ion as fast as possible happens, or there is an exchange of potassium with hydrogen which is in excess in the extracellular fluid, and that is why in metabolic acidosis you will have hyperkalemia. Okay. Now let's go on to alkalosis. You have respiratory alkalosis. What happens is the kidney conserves the hydrogen ion or excretes excessive bicarbonate ion, and then in metabolic alkalosis, what would you expect? Respiratory compensation. But kidney usually excretes alkaline urine and retains hydrogen ions, which is very easy for the kidney. The kidney works both ways, even in metabolic as well as respiratory. But respiratory compensation is always difficult. Remember this point. Respiratory compensation is always difficult in metabolic alkalosis because hypoventilation is limited by hypoxia. You understand? So you cannot ask a person to stop breathing at any cost just because he has to compensate a type of acid-base disorder. So this summarizes the compensations. Now I want all of you to remember these formulas and stick it into your mind. So this will come of use for you in the workshop when they give you, the various ABGs to interpret. I'm not going to run through this. These are formulas that have to be by hearted. Okay. So let me go to the last problem. We have a 60-year-old man who seriously ill at arrival at the hospital, and he is told he had vomiting several times, dark colored brown fluid every hour or two, and several episodes of melena. He has a past history of alcoholism, cirrhosis, portal hypertension, whatnot. On examination, he looks like a classic CLD patient with portal hypertension features. I'm just rushing through because of the lack of time. And this is the sodium potassium chloride which you have and bicarbonate. Why am I mentioning these values of electrolytes here? Is because I'm going to introduce a concept, something called as an anion gap. So this patient has acidosis, no doubt, and this patient is having, either a metabolic acidosis or a respiratory alkalosis. But then I'm very sure that this patient has a metabolic acidosis because of his bicarbonate there. Then I go on to do something else called as an anion gap calculation. If I calculate his anion gap and it is increased, it is called high anion gap metabolic acidosis, whereas if it is normal, it is called non-anion gap metabolic acidosis. Now what is the compensation? Of course, you're going to look how the respiratory compensation has happened, and you will use the Winter's formula or the other formulas which I've already showed to look at the respiratory compensation. So the rules of compensation are overcompensation will never occur. The second rule is patient is always more important than the ABG. Look at the clinical context. This, to summarize, is how you calculate your anion gap, and a normal anion gap is roughly around 6 to 12 milliequivalents per liter. And you have various reasons why anion gap changes, and I think you can look into these slides later to understand better what is normal or increased anion gap metabolic acidosis. But for your exams, you need to learn certain mnemonics. Basically, for increased anion gap metabolic acidosis, just remember mud piles. And for normal anion gap metabolic acidosis, which is hyperchloremic, usually it is due to saline administration. And for narrow anion gap metabolic acidosis, remember hard ups. So this is the summarization of what I have taught you till now. Okay, so you have an acid-base disorder, classify acid or alkali, metabolic or respiratory, anion gap normal or non-ion gap metabolic acidosis, and in respiratory acidosis you have acute or chronic, and in respiratory alkalosis you have acute or chronic. Now let's go on to mixed disorders. So the body is not always perfect, that your acid-based disorders are only in one direction. It doesn't mean that you always have only metabolic acidosis in the body. You can have metabolic acidosis with normal anion gap acidosis, or you have metabolic acidosis with metabolic alkalosis. So how do you approach that? In that instance, you look at something called as a delta gap. So either you use a delta Ag minus delta bicarbonate, where it is anion gap minus 12 minus 24 minus bicarbonate to arrive at this, or you use something called as a delta ratio. In most discussions, you will see that they will approach it through the delta ratio, where if your delta ratio is between 0.0 and 0.4, it is a normal anion gap metabolic acidosis, where if it is between 0.4 to 0.8, it is a mixed normal and a increased anion gap metabolic acidosis. If it is between 1 to 2, it is a raised anion gap metabolic acidosis, and if it is greater than 2, it is metabolic acidosis that is coexisting with metabolic alkalosis. Okay. So there are some tips for mixed disorders. I'll rapidly run through them because of the lack of time. Swami is actually just behind my back asking me to get off the stage as soon as possible. But tip 1 is, do not interpret any blood gas data for acid-based diagnosis without closely examining the serum electrolytes. Okay? And even dissolved carbon dioxide plays a very important role when you are interpreting acid-based disorders. The second most important tip is, when you have a normal pH on your ABG and you have your bicarbonate and carbon dioxide going in opposite directions, always think of a mixed disorder rather than a single disorder. And the third rule is, if the simplified rules predict pH and bicarbonate change for a given change in PCO2, and that is your formula which I have already spoken about. If you put in these values into that formula and it does not match, then obviously you have a mixed disorder there at play. In a maximally compensated metabolic acidosis, the numerical value of PCO2 should be the same as the last 2 digits of your arterial pH. A very important tip. And this observation reflects the formula for expected. This is called as a Winter's formula, like already discussed. You can the expected change in PCO2 you can calculate by putting in the other values here. So let's rapidly run through one mixed disorder for sake of discussion. We have a 55-year-old insulin dependent diabetic woman who was brought to the casualty by ambulance, semi-comatose. You see the potassium is quite low here, glucose is low, and anion gap is around 34. And this is so is the patient having a normal pH here? Yes. So quite confusing whether this patient is now in acidosis, alkalosis, what is the patient having? So, but look at the PCO2. PCO2 is, there's a washout of PCO2, right? So there is definitely a component of respiratory alkalosis. Look at the bicarbonate. There's a component of metabolic acidosis. So metabolic acidosis, respiratory alkalosis, normal pH. Very easy from the tip I told you, this is a mixed disorder. But we need to follow the rules, right? So you go through every set of rule I have told you till now, and then you calculate for the compensation, and then you will arrive that this is basically a high anion gap metabolic acidosis in a patient who had pre-existing metabolic alkalosis. Even though originally considered possibly, there is no real evidence of any significant respiratory acid-base disorder. Okay. So to summarize ABG, first look whether this is acidosis or alkalosis. Look what is driving respiratory or metabolic. Then look at metabolic acidosis, classify as normal anion gap metabolic acidosis or high anion gap metabolic acidosis. And then finally calculate the delta gap ratio or delta delta to find out whether this is a mixed disorder or a normal straightforward single acid base disorder. Okay. So thank you. I hope I have time for questions. Okay, thank you. I'll just pull this out. Thank you, sir.
I would like to congratulate Dr. Srivatsa. It's an excellent presentation. ABG is a very complex topic to finish in 30 minutes. So it's you did excellent job to cover all aspects of ABG. I hope in workshop residents will understand these concepts better. And as you already emphasized, all these rules we can't by heart. unless we apply in day-to-day practice, they will like memory, this motor memory, like driving car, all these compensations we can get into our minds, unless you apply them day-to-day in our bedside practice. And as he told already, in metabolic alkalosis, always that golden rule is there. Respiration, your lungs will never compensate adequately. And among all mixed disorders, any combination can happen except respiratory acidosis and respiratory alkalosis together. It will never happen. Any other combination can happen. There will be quadruple acid-base disorders, there will be triple acid-base disorders. But combination of respiratory acidosis and respiratory alkalosis will never happen, because patient will never be hypoventilating and hyperventilating together. Okay. Thank you.
Thank you, sir, for that elaborate presentation. ABG is definitely a hard nut to digest, but once we learn it, once we practice it every day, it's definitely a most easiest thing, which has to be practiced for the benefit of the patients. Thank you, chairpersons, Dr. Shibhushan sir and Kishan sir, for being here with us and giving your valuable time. Thank you, sir. I would like to announce that for all the postgraduates, we are conducting a postgraduate quiz competition in the afternoon. Before that, we have a prelims round which will be online. As we have already informed all of you that to join in the PG Respiratory Physiology Conference group, which we have already made it available, and most of you are already there in that group. Before the lunch break, we are going to put that Google form on the group. 15 minutes time you will have to answer around 40 questions, and that within 15 minutes the whole timeout will happen. So you try and answer those questions, and the top 8 people will be selected for the final round. It's an amazing quiz competition. It would be Dr. Vishnu Sharma sir, who is a legend by himself, and sir has always been a quizmaster for all our for our NAPCON conferences every year. So we are privileged to have him here to conduct that quiz competition, and he will impart a huge amount of knowledge to all of us. So please, all of you, if you are not there in the group, kindly contact Dr. Anjali and Dr. Nitin, who can help you out to get into that group. Thank you. I would like to call Dr. Jairaj BS sir. He is my teacher, beloved professor and head JSS Mysore, to please come on the dais to deliver his next lecture on aerosol therapy. For your kind information, tea and coffee will be served inside the hall only. Since we are running short of time, we are already half an hour to 40 minutes late. We are not going to have a tea break. Tea coffee will be served here. If anyone wants to use the washroom and everything is right available right opposite to the hall, so you guys can walk out and come back in for the lectures. And I would like to call Dr. Rajesh BP sir, professor, Department of Pulmonology, JJ Medical College, Davangere, to kindly chair the session. And also I would like to call Dr. Shigri Revadi sir. Sir is a senior pulmonologist, Bangalore. Sir, please occupy the dais and chair the session, sir.
Good afternoon. I think all of you must be hungry, waiting for the lunch. Respected chairpersons, at the outset, I thank Trustwell Hospital and Dr. Swami for giving me this opportunity to come here to interact with mainly with the postgraduates, and it's really a good opportunity to meet our colleagues, friends, post-COVID. Otherwise, we would not have met them. So what I am going to do in another 15 minutes, I am going to touch upon the basics, the very basics of aerosol therapy, physiological basis of aerosol therapy, which most of us would not have given much importance actually. Though we have read it in our physiology classes, we read about it, and then probably would have forgotten it actually when it comes to the clinical practice. Why we are doing that, why we are using inhalers, and why we are using roda caps, whatever it is. Simply blindly or following it, but probably would not have given thought to why we are explaining certain steps to the patients who is taking this, using these devices. So, as you know, this aerosol therapy is not new to us. It has been there from time immemorial. The ancient civilization knew the role of inhaled aerosols for the treatment of disease, spiritual enlightenment and pleasure. You know this Datura Shamonium plant, this is the seed. The seed they used to crush and they put it in a boiled water and they used to inhale it. That contains atropine. This used to cause some kind of euphoric effect actually. This has been used from our ancestors as well. If you ask a smoker who has been an habitual smoker, he knows how to take maximum benefit of smoking. He he takes the puff, he slowly inhales it, holds it for some time to get the maximum effect. That the smoker who knows it actually. So that means the aerosol therapy is a very good, the lungs are very good site of delivery of the drugs to the body. In fact, the nicotine will reach the brain within 11 seconds. There is so rapid the absorption from the vast surface area of the airways and the lung. Okay, what are these aerosols? Aerosols are nothing but suspension of liquid or solid particles in the air. So medical aerosols are generated with atomizers, nebulizers and inhalers, which you use it day in and day out with all our, every other patient you see as a patient with airway disease, we keep using them. And the delivery of the aerosol is complicated by, because of the anatomy of the respiratory system, which you know, disease state, device which you use, and drug formulation. So as you know, the key to aerosol therapy is aerosol particle size, and also importantly, delivery devices actually. So we know the lower airway, respiratory tract is always kept sterile. Nothing can get into the lower respiratory tract. Whatever goes there, noxious substance, whatever particulate matter will be thrown out because of the robust, the system which we have. That is a defense system. So to overcome this natural defense system is very, very important for any formulations, whatever the drugs which deliver into the lung. So this, I will not go into the details about the natural defense of the body. This picture explains everything about the natural defense of the lungs actually, how the lower respiratory tract is maintained sterile, devoid of any foreign bodies. Okay, we have got two host defenses in the upper airway, the different the dichotomous branching, angulation will try to filter off the airway particles, suspended particles, starting from the bristles in the nose, that will filter off these suspended particles, and whatever enters into the airway will be taken care of by the other systems in the body, including in the gas exchange system, that like your surfactant, the secretory IgA, the alveolar macrophages, so many things which take care of whatever goes into the lower respiratory tract. So the human airways are designed in such a way that this will avoid any deposition inhaled particle that is going to be retained inside the lungs. So this is very important. This is self-explanatory. This is what you call mucociliary escalator. So whatever it is, there is a normal functioning cilia and the different layers of your solar gel layers along it will act as an escalator. Whatever gets inside stuck there will be thrown out because of normal ciliary activity. So that means it is a complex process to deliver the drug which should be retained in the lung, which should be in a respirable range. Okay, if you look at this particle size, as I was telling, the important thing is the size of the particle is also very, very important when you are talking about aerosol therapy is concerned. So any particle more than 100 millimicron will be filtered in the nose and the upper airway. So and the particle size between 2 and 5 with what you call respirable range will be delivered into the lung. Less than 1 to 2 will be remain suspended in the air, will be taken in, and it can be expelled out through expiration. Okay, this is how. So what are the factors that influence the delivery of the drugs to the airway? Number one, the particle size, and as I said, it's the anatomy. So the bigger particles, they get stuck in the upper airway because of inertial impaction. So when because particularly in the oropharynx, this is what you call the particle traveling in the straight line. So whenever there is a bend in the airway, it gets stuck at the site of the bend. This is what you call inertial impaction. So greater the speed of the particle moving, greater will be the deposition. Greater the size of the particle, greater will be the deposition in the upper airway. So the particle size between the range of 2 to 5 millimicron, they are what you call respirable range of the particle. They are the only particle they are going to get settled in the airway. So that is going to be influenced by the pattern of breathing. So breath holding. You have to give some time for these particles to settle in the airway. And particle less than 1 millimicron diameter, say 0.5 to 1, so they will be suspended in the air. So beyond the distal respiratory bronchiole, near the alveoli, there won't be any bulk movement of the gases. Only the gases travel because of diffusion, brown onion diffusion, what you call. These are the suspended particle. Either they remain there or they will be thrown out during expiration. So that means we need to have a particle size of around 5 millimicron for these drugs to be effective. So these are the factors which are going to influence the deposition of the drug and ultimately the action which you expect from this particular drug. So if you look at the normal delivery devices which you use to deliver aerosols, be it rotacaps, inhalers or nebulizer. So if you look at this simple inhaler, so when this is what you call emitted dose from the inhaler. So most of it is deposited in the mouth and naropharynx, 80%. Another only 10%, less than 10% will be delivered to the airway. So another 10% will be retained in the device itself. So 1% is exhaled out. So whatever the thing that is there stuck in the oropharynx, again swallowed, it goes to the gut, then to the liver, bypass metabolism. Some of it is metabolized there and enters the systemic circulation. That means very little part of the drugs goes to the circulation, so it's very safe as far as the side effects are concerned. So only, as I said, 10% will reach the lung. Very little part of it goes to the circulation again. So classification of aerosols, we have got bland aerosols, includes just simple heated or cool sterile water or saline. Medicated aerosols, lot of medicine can be delivered through aerosol like bronchodilators, inhaled corticosteroids, anesthetic, mucokinetic agents, surfactants, insulin, so on and so forth. These are the list of drugs which can be delivered through aerosols. We will not go into the details about that. Just name anything, most of the drugs can be delivered through aerosols. For example, in ARDS, particularly in neonatal period, we have got surfactant delivery, okay, pneumonia, we have got various antibiotics we can use, aminoglycosides, cholesterol, like that. Then COPD and asthma, you know, the bronchodilators, inhaled corticosteroids, how we deliver, okay. So on and so forth, there are many diseases which can be treated through aerosols. These are the list of drugs which can be used as an aerosol to deliver into the lungs or to treat the diseases. I will not go into the details again. You can get it in any textbook. So the aerosols, though the dose delivered is very small, it is not without any hazards. It also involves a lot of adverse effects, like medication being delivered. If it is hypotonic, it will cause mucosal edema. Again, further worsens the airway resistance and spasm. And importantly, particularly when you are advising your nebulizers, chances of cross infection, contamination is very, very important. So that's why we try to discourage using nebulizers at home. Most of the times they can be managed with inhalers and your rotailers, whatever. So airway reactivity, cold and high density aerosol will cause bronchospasm, increase airway resistance. Certain medications like N-acetylcysteine, steroids themselves can cause airway irritation and bronchospasm. Okay, distilled water if you use, that's why you use normal saline when you are diluting the drugs with water. This is known to cause airway resistance and bronchospasm and wheezing actually. That's the reason why sometimes if we give only ipratropium bromide, some people they have paradoxical bronchospasm, may be related to airway irritation actually. So administration of bronchodilator before or with the administration of these agents with the bronchodilators or prior administration of bronchodilator will take care of this airway irritation and bronchospasm. This is what we have to keep it in mind actually. So as far as why the aerosols or inhaled drugs are preferred, I will not go into the details about that, because we are going to deliver the drug to the site of action. The quicker action, as I said, the nicotine can reach the brain within 11 seconds, like that. Many of these drugs will act immediately. Local concentration is achieved fast, and the drug delivered is very less. So systemic side effects also very less, because we are going to deliver it directly into the site of action. So I will not go into the details about that. We have seen, as I said, aerosol delivery devices is very, very important when you are using aerosol therapy. So there are many aerosol delivery devices. I will not go into the details about that. We know wet particle inhalers, dry powder inhalers. Among that, jet nebulizer. Again, jet nebulizer, we have got breath activated jet nebulizer, something like that. So only when the patient breathes, it will deliver the nebulizer, something like that. Then we have got ultrasonic nebulizer. We have got again metered dose inhalers, conventional, again breath activated, and spacer devices to deliver these aerosols. And you got dry powder. A lot of devices are available there, and we have to choose the devices depending upon the individual. How the person likes it, or is it easily usable? Person can without any problem can use this. Depending upon the individual choices, you can select them. And of course, selection of devices is also very, very important to have proper delivery of these drugs to the lower airways. I will not go into the details about it. Already you know about all the different devices that are available in the market. Again, aerosol, in a patient who is on ventilator, you can deliver aerosols either through nebulizers or through metered dose inhalers. This is one of the connector which you use to deliver, holding chamber, whatever you can say, to deliver aerosol in a ventilated patients. These are some of the connectors which you use. But I'll just concentrate on this. Is very, very important. Device comparison. If you use metered dose inhaler with reservoir or nebulizer, what we have is a small volume nebulizer. We have got a large volume nebulizer which we use in the ward, where we can have at least 250 to 300 ml of solution which you put in there. You can continuously nebulize them 4 to 5 hours. Particularly when you want to humidify the airway, or you want to use continuously bronchodilators in severe airway spasms, we use large volume nebulizers. Whatever the nebulizer which you have, either jet nebulizer or your ultrasonic nebulizer, they are called small volume nebulizer, because we use just for 2 to 4 ml of solution there. That's why it's called small volume nebulizer. Okay, metered dose inhalers, you see, only with the metered dose inhalers, the maximum of the drugs is deposited in the oropharynx. Okay, this is a drug lung delivery. As I said, only 10 to 20% can reach the drugs, particularly with with use spacers actually. Then with the comparison with small volume nebulizer, metered dose inhaler with reservoir, if you look at the lung delivery, almost they are equal. So that means if you use the metered dose inhaler with spacer, it is equally as effective as using your nebulizer. That's what I wanted to just stress upon that. And dry powder inhaler and metered dose inhaler, oropharyngeal deposition is very, very high. When we use them without spacer, MDI and DPI, one has to be very careful about the goggling immediately after using that. This is what I wanted to stress upon that for the PGs here. So MDI with reservoir and small volume nebulizer, be it ultrasonic nebulizer or your jet nebulizer, the delivery of the drugs is almost equal. So aerosols, Indian scene, because if you just, I will not go into the studies which you have done in our hospital also, but there also we see less number of clinicians in India use inhalers regularly. Very few patients are on aerosols. They think still that the aerosol therapy is the last resort. There is a lot of myths regarding inhaler therapy. They think it is strong, addictive, last resort, expensive. Okay, the steroid phobia with ICS, inhaled corticosteroid. If you give steroid, even without steroid also, if suggest them to use aerosol, the rotacap or inhalers, they think that it contains steroids. So there is a lot of steroid phobia associated with that. I will not go into the details about the individual devices which you already know. So only thing is that the aerosol flow, once you actuate the inhalers, the rate of gas that's coming out of the actuator is around 100 km per hour. That means once you actuate it, immediately it has to be inhaled. Otherwise, it will get deposited in the throat and the larynx. So these are some of the parts of the aerosol. I will not go into the details about that. Canister, actuator, metering valve. The drug inside has got 3 components actually. Drug combined with surfactant, which will prevent the clumping of the drugs, and the another one is your propellant. Nowadays we use instead of CFC, hydrofluoroalkane actually. That's ozone friendly. So CFC has been removed from the market actually. So this is what happens, why you shake the inhaler before use. This is the reason. If you leave it for more than an hour, you see the upper part, there is floating something, that's the drug particle. So if you use without shaking, you will be delivering only the propellant, which is airway irritant. So that's why some people will develop airway spasm when they inhale the drugs without properly shaking the inhalers. Then they'll come back to you that because of taking the inhalers, their problem is worsening. They get more spasm when they use inhaler. The reason is this. That's why you'll ask them to shake them before you actuate the inhaler actually. So I will not go into the importance of the spacer actually. The spacer will help the drugs to deliver more drugs to the lungs. So this is a picture you see. I will not go into the technique of how you use inhalers and rotacaps. So the advantage of inhalers, the MDI is it's inexpensive, light, compact, resistant to moisture, quick delivery of the drugs. We can deliver precise and consistent dose. Most of the drugs are available in the form of MDI. Okay. So there are a lot of common errors which happens when you are using inhalers. So you have to train the patient, the people using this every time they come to your clinic. Earlier we used to see whether the canister is empty or not. Nowadays we don't have to bother about that because already we have got devices which have got dosimeters. So you don't have to worry about that. Either earlier you have to remove that, then you have to shake and find out whether how much is remaining, or put the canister into the water bottle and see whether it's sinking to the bottom, if it is full or something like that. That part is taken care of by your dosimeters actually. So there are a lot of problems with the MDIs. If you don't use without the spacer, it can cause oral thrust, then cold prion effect, that is the cold effect. When the pressurized gas comes out, there is a drop in the pressure, that cold prion effect that itself will induce bronchospasm. So all these things are taken care of by the spacers. So the spacer is how it acts is very important. Number 1 is it slows down the particle. Number 2, it traps the large particle. Number 3, it eliminates the cold prion effects. These are the advantages, and also importantly, so you don't have the problem with oropharyngeal deposition causing, candidiasis. Importantly, it will avoid hand-breath coordination. So you have to actuate and immediately you have to inhale and hold the breath for 10 seconds and leave it like that. So hand-breath coordination can be avoided if you use spacer. These are the advantages of the spacer. I will not go into the details about that. Even it can be used even in children. The MDI with spacer, it's easy, and I will not go into it again in details. Nowadays you will have spacer devices which are electrostatic free, it seems. Earlier you used to get the spacer like this. If you rub the spacer inside, it will cause electrostatic charges there. So whatever you put the inhaler, if you actuate that, you used to get deposited inside the spacer device. Nowadays gyrostat, whatever they claim, we are not sure, but they say that this effect will not be there. So that's why earlier we used to say, no, don't rub the inside of the canister, just wash it in the water and keep it dry in the air, so that will cause electrostatic charges inside. So once it happens that, sometimes we have to empty the whole canister to get the drugs out of this chamber. So such is the force of electrostatic charges. So whatever the drugs which actuate into the canister, they used to get deposited inside the spacers. Now this problem is avoided by use of gyrostatic spacers actually. Again, the dry powder inhalers, another thing is that you cannot prescribe it to everybody. So the force required to create a respirable range in this is 30 liters per minute. The person with severe COPD with already hyperinflated lung is not able to create that amount of flow. You cannot prescribe these rotailers to the person. We cannot generate so much of force. Okay, particularly in elderly. I will not go into the details again about that. Again, nebulizer is easy to use. Any age can use this. jet nebulizer, ultrasonic nebulizer, how they work, what are the principles. I am not going to the details about that. Only thing is that the low volume nebulizers, minimum volume will need to deliver proper drug to the airways is 4 to 6 ml. So now the nebulizers that are available, we can use 2.5 ml, it's okay. That depends upon the manufacturer specific about that nebulizer actually. Okay, important is the use of correct fitting mask, so to avoid the wastage of drugs. Okay, the front connecting this front connecting connector is very good for delivery rather than the sideward connection or the downward connection to the face mask. So I am not going to the details about all these things. If there anything, any doubts, we can discuss over the lunch. Okay. The advantage of nebulizers, you can have the can get the same this thing with normal tidal breathing. In fact, the slow deep breathing, breath holding is advised, but normal tidal breathing is okay for this nebulizer to deliver the adequate the doses of drug to the airways actually. So the drugs which cannot be given by MDI can be given by nebulizer, like inositol, cysteine, ambroxol can also be given through the nebulizers. So patient cooperation, coordination is not as critical as it is required for your middle dose inhalers. So nebulizer design again is expensive, require regular maintenance. Important thing is the cross infection. So maintenance of nebulizer, nebulizer is very, very important. You have to advise the people with how to use, how to wash, how to clean, how to sterilize nebulizers and nebulizer masks and the chambers is very, very important to prevent the infection. Of course, it requires power supply. So depending upon the age, you can select the different devices. So up to 4 years, we can use nebulizer as a first choice. MDI with spacer with mask, baby mask. For the infants, you can still use that, provided there is no valve for the spacer. So up to 7 years, you can use MDI with spacer, and DPA better if it is above 7 years, because again I told you a lot of airway deposits need more force to generate the respirable particle to inhale this dipod inhaler, and they have to wash the throat properly. So better to avoid in children actually less than 7 years age group. So after that you can use MDI dipod inhaler with or without spacer depending upon the patient choice and their likes and dislikes. In conclusion, very, very important when you are selecting the aerosol, the patient assessment and also patient likes and dislikes. Some people may like the inhaler, some people may, because of the taste they have, the other factors. So it is left to the choice of the patients. So it is better to know your device and how to use it is very, very important. How to take care of it, how to, every time patient comes to you, you have to keep them, keep telling about the different techniques, because the lot of mistakes happens. The most of the time patient comes to us because they are not improving, because the technique is not good. So device is also equally important along with your drug which you prescribe. So age related choice is very, very important. So elderly people, arthritis people, we cannot just ask them to use inhalers, and there will be a lot of they require breath coordination, okay, proper actuation, you have to press the inhalers, and so many other factors will influence the selection of your devices. So allow the patient choice within their age and ability, and better to limit the use of nebulizer. As far as possible, it is better to prescribe MDI spacer, and only certain cases where they cannot use this, such cases you can prescribe nebulizers. That you know already, I am not going to the details about that. When you prescribe nebulizer, make sure that the infection control practice is put in place, because that will again they'll come back to you again with pneumonia and other respiratory related infections. So individualized aerosol therapies for each patient is very, very important. So I think I end this my talk at this. Thank you for your attention. So just it's the basics of basics actually. We thought most of us will forget about why we're doing it actually day in and day out. We keep explaining the patient, but still we will not be knowing what is the physiology behind why we explain the patient, why they will ask them to hold the breath. So okay. So what is the importance of the selecting different devices? Okay, thank you for your patient listening.
Thank you, sir. Yes, sir. It was an excellent talk by Dr. Jairaj, Professor of Pulmonology, JSS. We were his students when we were in Mysore Medical College. Many interactions were there, and I would like to ask this speaker and the host kindly share these slides, because many slides were self-explanatory. Very beautiful slides, sir. I appreciate and congratulate Dr. Jairaj sir for once again for excellent talk.
Thank you.
It is an excellent talk, and so many things have been explained. But one thing is, every day we remember that the patients, in spite of educating them how to use these inhalers, but still they keep on doing the mistakes. You can imagine in any way you like regarding the mistakes a patient can do. We have to evaluate each and every patient every time he visits and how he takes the inhalation. And we should look into his inspiratory capacity. Looking into that, we have to modulate the type of inhaler we would like to prescribe. That's all I want to add. Thank you, sir. Dr. Jairaj.
Sir, thanks a lot, sir, for that wonderful talk. Always being inspired by you. You are my idol. I always worship you. Whatever I am is because of my boss. I am very proud to say that. And I really got an opportunity to call him, and sir came all the way from Mysore despite the rains being disturbing the roads in between. Thank you, sir. Thanks for coming. I thank Dr. Rajesh sir and Dr. Sri Reddy sir for chairing this session and being a part of this wonderful program. Thanks a lot, sir. Thank you, sir. Moving on to the next talk, again one more important topic which most of us we want to practice, but we don't know how to practice. One more thing. So definitely it's a wonderful topic to discuss on. Skin prick test, allergy skin test. Definitely this plays a very important role in knowing what allergens are bothering us, causing severe asthma. We have an eminent speaker, Dr. K.V. Nagendra Prasad sir. Is an amazing personality. Sir runs his own private setup, and he runs Bangalore Allergy Academy, BAF Academy, and sir also runs RGHS recognized sleep fellowship. It's an amazing thing, and sir's son, Dr. Puneet, is our colleague. Is an amazing person. It's wonderful to have you here, sir. I would like to call Dr. Narasimhan sir, senior pulmonologist, to please come on the dais and occupy the chair. And I would like to call Dr. Lakshmi Narasimhan sir, consultant pulmonologist, Manipal Hospitals, Mysore, to please come and occupy the dais. And Dr. Narasimhan sir, senior pulmonologist, to please come and occupy the dais. Over to chairperson.
The time when nobody even thought of it, and he has stuck to it for such a long time, and that is how he has built an institution of his own. And to talk about this important topic, which is very easy to do as a skin prick test in the outpatient also, allergy diagnosis can be established, and proper therapy can also be instituted. Over to Dr. Nagendra Prasad.
Good afternoon. At the onset, I thank the Trustwell Hospital and Mr. Swami to give me the opportunity to address to the budding pulmonologist. Everybody speaks about SPT. Even the patients want to know what is the allergy which I am having. I am regularly wheezing. And the doctor is also fascinated to go for SPT. And without knowing the importance of the SPT, I think you should not be advisable, or if it is advisable, it should be precise to the patient if it is necessary. Today I will be just touching on the importance of the SPT and its significance, and you can adopt in your practice. What is the relevance of sensitization? Everybody knows when they expose to the allergens, you develop the symptoms, and once you stop avoiding exposure, then there is a disappearance of the symptoms. Just a small cartoon, I want to explain you. There is a mast cell, and IgE is there in the serum. And when the IgE is floating in the serum, and with independent of the mast cells, you don't have a symptoms. But this IgE, when it binds on the mast cells, and the allergens binds between the two molecules of the IgE, then there is a vasoactive amines are released, and that induces the symptoms. So that is how this difference between the specific IgE test and SPT. In case of specific IgE test, you will be knowing the free molecule of IgE, and you will be maybe having a symptoms or may not be having a symptoms, but IgE reports always gives a positive, but may not be having a symptom. But when you do this SPT, definitely it identifies the IgE molecule which is binding on the mast cells, which is releasing the vasoactive amines. So what are these vasoactive amines does? It does have chemotaxis, inflammation, and a smooth muscle spasms. That's how all the series of the respiratory as a nasal and other symptom starts. We call it as type 1 IgE mediated disorders. Already you may be knowing or may not be knowing about one particular sequence. These patients who are having allergy symptoms from the birth to the womb, there is a sequential problems from one organ to another organ. That is, it may start with the skin in the childhood. Later on, it may be having a respiratory and a nasal and the GI tract, and we call it as allergy march. So by history, this is a very crucial point one has to understand, whether that particular the individual having allergy march. And if it's a mild to severe symptoms of exacerbations, or it may be leading on to the persistent symptoms leading on to the chronic disease. So diagnosis of the allergy disorders is very, very important and crucial. And you have to spend a lot of time with taking the history. The diagnosis is already known with the prescription or the drugs which they are using, or the patient himself will be giving the diagnosis. That is not a different. But history will give you a very, very clear picture whether it is allergic or non-allergic. If it's allergic, what type of allergy is. Then the clinical features, then clinical serological test, as well as the skin test and a provocation test, which we will discuss today. There is a patient, is a female, 34-year-old, from Bangalore, is a software engineer, having a history of sneezing, running nose, occasional nose block, and a wheeze since 14 years. And the symptoms observed only in the monsoon, and during the summer, they are totally free. Father and uncle with a history of asthma, so that is a strong history that is atopic in nature, that is runs in the family. So needs symptomatic bronchodilators with antihistamines and sometimes montelukast during the seasons. FEV1 is more than 70%, SpO2 more than 798, FeNO is more than 34. Diagnosis very easy, allergic nasobronchitis or the asthma and rhinitis. So these are the category of the patients which is needed for the SPT. And all these need not be allergic in nature, so one should be very careful. Similarly, the form of allergic rhinitis of various symptoms like sneezing, running nose, nose block, and coughing, etc. Another class is atopic dermatitis. It's a patchy eczematous maculopapular rash which may be seen in the child with both the cheeks during birth or during infantaria, or as advances in the cubital fossa as well as popliteal fossa, these rashes may be there. So any cases with urticaria of atopic nature, because urticaria, all urticaria need not be allergic in nature, which may be infective or autoimmune, or may be allergic in nature. Drug allergy, insect bite allergy, pet allergy, and food sensitivity, these are the places where this SPT can be done. You see, the skin prick test is already known from 1865. Blackley, he is described as a skin test. And again, Montos, which you are very familiar. Earlier it was called as intracutaneous, now it is called the intradermal. Lewis and Grant, 1924, prick test as defined. And later in Pepys, 1970, he modified skin prick test has been defined. Right now, the methods of skin test is only two, that is a prick test and an intradermal test. Earlier, we used to have the scratch test, which has been discontinued. So, EACI, that is European Allergy and Immunology, and a US Joint Council of Allergy, Asthma and Immunology, and they have defined a standardized allergens, prick or puncture test, are generally considered to be the most convenient and least expensive method for detecting the inhalant allergens in respiratory allergy diseases. It should be preferred primarily by clinician to assess the airborne allergy disease. And skin tests are frequently used as a reference standard for evaluating specificity and sensitivity of in vitro specific IgE assays. And the advantages of SPT is very simple and very fast. Within few minutes it can be diagnosed, and multiple allergens can be done at a time. And a cost factor is very, very low when compared to the specific IgE, which may not be as significant. And visibility, even the patient can see the reactions, and it can be done very fast and very high sensitivity. This is how this SPT is done, and the kits are available. And this is always done for air allergens and the foods, drugs and chemicals. And prior to this, starting with a skin prick test, you should have a normal skin, especially in urticaria as well as atopic dermatitis. Skin may not be available, so you should be watching where the normal skin is available. No dermographism, that is called pressure urticaria. So any pressure falling in the skin and causes a triple response, then these are the cases where you can't do it. And symptoms of allergy should always be under control. Never do during the acute phase. Once the symptoms are under control with the pharmacotherapy, then you can do this skin prick test. And there are some medications you had to stop before the test procedures to be done. And on the table, when you are doing the procedures, you should have a negative control and a positive control, which I'll be speaking shortly. And you should have a selective allergens. And you should have a lancet, a metal lancet, stainless steel, of a tip with 1.25 millimeters. And what is available in the market is about 3 mm, which is commonly used in the labs. Or the best, you can use the 26 gauge hypodermic needles. And rescue medications has to be kept. There are certain drugs which I told you that you had to withdraw the drugs at least minimum 2 to 3 days prior to the test, because these drugs will interfere with the test response, especially the antihistamines, and different durations, depend upon the actions. For example, cetirizine, 1 to 2 days withdrawal is important. Astimizole, which is not available freely but still there, but it takes a long sustained effect with antihistamines, that has to be withdrawn minimum 3 to 4 weeks. Other drugs like theophylline, we had to moderately see how effective it is. And a non-blocking skin test drugs are oral corticosteroids, montelukast. So before the test, you can give the montelukast, or the corticosteroids can be given. And inhaled beta-2 agonist, or cromolyn sodium, and inhaled corticosteroids and oral steroids can be given. So before the test, systemic antihistamine stop 3 to 10 days before the test, antihistamine stop on the day of the test, and the steroids and montelukast, there is no restrictions. I told you that controls has to be used. One is negative control. The negative control is always a glycinated buffer saline for skin prick test, and a positive response in dermographic skin, which can be seen with this test. If it is showing positive, then the whole procedures is not considered. And traumatic reaction induced by the lancet or needle also can be seen. So negative control should always be negative. It can be vary with a diameter of 1 to 2 mm. We use the histamine dihydrochloride 10 mg per ml as a positive control, which detect the suppression of reaction with a pre-medication. If the histamine also showing non-reaction, that means they have taken some pre-medication which is not responding to the reaction, and if it's a negative, it cannot be proceeded for further test. And various techniques which can be employed, and a potency of the reagent is available, and a poor reactivity of patient to histamine which vary. Then devices, what is the device to be used, which I already told you. The hypodermic needle is the best, which gives the maximum results, and a lancet tip 1.25 mm, which is not available in India. Only imported lancets are available, but very expensive. The best is you can use the hypodermic needle. And a multiple head devices also available, but not in India, but from abroad. So optimum results expected by choosing a single prick device, and a trained physician is very, very crucial. So these are the devices which you can use: the puncture directly pressing on the skin, or a prick that is intradermal. And these are the different layers, where is epidermis and dermis, 2 layers where the allergens are introduced. A multi-head devices which is available in the abroad, which is commonly used in the pediatric, where you can one drip and one prick, so that can be easily done, but efficiency is not that good as you do the single allergen. Advantages: several tests with one application, and minimize the test time, increase efficiency, more acceptable to the children. Disadvantages: more painful, variable intra-device, and some penetrates through dermis because of the pressure. So prior to the performance of the SPT, which I already told you, you should have a clear indication. You should have how to test is performed, and itching and swelling are signs of positive reaction which will decrease within few hours, and prepared for anaphylaxis, and a consent before the test is mandatory. So like any other consent which you are doing a procedure, that consent has to be taken. So what are the rescue medications which is always should be available next to your procedure? One is adrenaline. Adrenaline is a very, very important drug. You should always be kept next to the skin prick test kit. And second is methylprednisolone. When the choice is given, when anaphylaxis happen, especially the anaphylaxis, and the choice is given, the adrenaline should be given the first, because the action with adrenaline is within few seconds. But in a hydrocortisone or any steroids, which takes more than 3 to 4 minutes. Or you can use the inhaler, and nebulizers also should be available, and supporting oxygen, injectable Phenergan, and laryngoscope or ambus bag should be always be there. What are the sites which can be done with the SPT? Either the volar surface of the forearm, or a lateral surface of the upper arm, or upper back. The reason behind is the distribution of the mast cells in these particular areas are more, and you will get appropriate results. And clean the skin and make it dry with a spirit, and a marking on the skin with a pen is very, very important. So separate lancet is used for each allergen for better results. There are people who use the one lancet with a swiping and a flaming and then dipping into the allergens, which is always go for contamination. So try to avoid contaminating. And so this, a single allergen with a single needle or a lancet should be used. This is how the lancets look like. And put a small drop of the allergen extract on the skin surface and just put it in the right angle to the skin using a lancet and cross the droplet and bevel up, and slowly you rise without the breaking the skin layer. It should be done very gently. By practice it can be done, and within few minutes you can do the performance. And the marking from one allergen to another, at least minimum you should have a distance of 2 centimeters, and small allergen drop is placed, and allergen concentration is 1 in 10 by weight by volume. It is commonly used as a crude extract. The standardized allergens which is available in the world and in India is very, very few. And earlier the standardized allergens was not available in India. Now it is available, but it is given in the different version of their own, like therapeutic units, biological units, or allergen units. Similar names are given for these extracts, but basically it is weight by volume. So after the procedure is over, you have to wait for the reactions to happen. Commonly it happens about 15 to 20 minutes. And you should have a distinctive clarity what is wheal and what is erythema. And wheal is a smooth and elevated area, commonly pale yellow or red in color. And a wheal is surrounded by erythema with a irregular shape, and one can appreciate its boundaries in the bright sunlight or a diffuse light. Don't put a floodlight on the surface. You should have a diffuse light so that you can clearly demarcate with the wheal and erythema. This is very, very important. This is how it looks like and how to measure. So in the practical sessions you will be knowing about it. If the wheel is irregular, it's over almost. She's asking me to wind up. So should I stop it or should I continue? Thank you. So the wheel what you are getting is an irregular shape or a circular shape. If it is a circular shape, you can put a small dots on the circle and take the vertical or a horizontal diameter. Or if it is an irregular reaction, then you can take the maximum diameter from one point to another point, and again another reading has to be taken perpendicular to the first reading, and that has to be taken as D and D1, DU2, and you can add on and divide it by 2, that will give the clear picture. So these things you can understand when you are attending to the practicals things. What are the errors? Allergens placed too close, that means the reactions overlap. So distinctive reactions cannot be seen. And you may be having a traumatic prick which may be having a bleeding, and insufficient penetration skin by lancet. So it does happen in the beginning. You feel you are so nervous. You may be touching on the surface but without piercing on the dermal layer. And spreading the allergen solution while test or by wiping. So while you are putting the allergens in the sequence, the allergens may flow to the next allergens and get contaminated, and that may be cross. So concluding remarks, skin prick test is a gold standard diagnosis of IgE-mediated sensitivity with limitations. One thing I wanted to tell you about this, why this skin prick test is done. The only when there is a criteria going for allergen-specific immunotherapy, then only you have to do it. Just by knowing the type of allergens without going for immunotherapy does not work. Why you want allergen-specific immunotherapy when you are having a pharmacotherapy which is more effective? Yes. Whatever the inhalers right now available in the market, these are all reduces the localized inflammation either in the bronchus or intranasal, but without altering the total IgE or a specific IgE in the system. And as long as you control the specific IgE, these disorders will not come out. So only right now, disease modifying effect is available only with allergen specific immunotherapy in the classical cases, excluding all the possible cases where this immunotherapy may not work and you have to continue only with immunotherapy. And the IgE, when reduces, automatically the inflammation reduces and the people can stop the inhalers. Otherwise, whatever you say, inhalers, once you start with inhalers, they have to continue the inhalers over the period of time. So there is another test, we called it as intradermal test, which you are all familiar. But now, earlier, we were using intradermal test as a routine test. Now the skin prick test has been more friendly than the intradermal because the vasovagal attack, anaphylaxis, much more in the intradermal rather than SPT. So these are all comparisons with intradermal and a prick test. Because of the paucity of time, I am not able to continue. And another confirmation test is only with the provocation test, the allergens directly putting into the particular sensitive organ, either in the conjunctiva or a nasal provocation or a bronchial provocation. But conjunctival nasal provocation can be done in the office procedures, but not bronchial provocation. Never do take the risk. But when you have an ICU, then you can take the bronchial provocation test as an academic interest. And patch test is another test where it is valid only for the sensitized lymphocytes, but it's not a type 1, it's a type 4 reaction. It's a sensitized lymphocyte because of the contact dermatitis, etc. That is, a patch test is useful. So, thank you for your time being. I might have taken much time. Thank you very much.
Thank you very much, sir. Thank you, Dr. Nagendra Prasad, for wonderful brief but comprehensive talk, because this was one thing which I think many postgraduates especially wanted to know. Is there time for questions, or we can take them? Hey, we'll take questions in the workshop, so we can move on to the next session.
Thank you.
Thank you, sir, for a lucid talk. Definitely this was required. This topic was required for all of us to know regarding how to desensitize allergens and get sensitized about the knowledge of allergens and know what we are treating. In fact, thank you, sir. I would like to call upon the next speaker, Dr. Uma Devraj, madam. Madam is professor at St. John's Medical College. They run a DM pulmonology course, and they've been a model for all of us. Their field of expertise is ultrasound thorax, and they run a lot of workshops there. And thank you, ma'am. Thanks for coming here. Over to you.
So one thing what all postgraduates should remember when doing the allergen tests is always keep the clinical context and history. So history is important to identify first which patients, as sir explained, will benefit. So patient selection is most important, and for patient selection you have to take a very thorough history. And allergy always, I like the word what he used, like instead of calling it asthma with allergic rhinitis with atopic, just allergic nasobronchitis, so which gives you the nature of the disease. It's all one allergy. So that's why you should take a detailed history of skin allergy, eye allergy, nose, nasal symptoms, everything. And also to guide the treatment, because there may be some allergens in the test which the patient may be sensitive to, but that is just called sensitization. If in the real world context, if in day-to-day life, let's say some food allergy comes positive, but when you take a history and the patient says, when I eat that food I don't have any allergy, that means it is clinically not relevant. Patient is sensitive, but it's not really causing an allergic reaction. So those can be ignored. But whereas in some cases like house dust mite or certain insects, pollen, they may be clinically also, the patient may give a very good history. So always never forget the history in both diagnosing, identifying who will respond, and also for the treatment.
Anything sir would like to add?
Dust mite is the commonest. Whenever you take a history, night symptoms, early morning symptoms, whenever the patient does normal activities at home, and this definitely gives you an indication that it's probably an indoor allergen. And for severe asthma, patients with alternaria and cockroach are known to have very severe asthma, and hence avoidance and things like that can always be instituted if you do a proper evaluation of the allergy. And immunotherapy in properly selected patients, like the sir said, is excellent because it gives better quality of care than just pharmacotherapy.
Reserve volume, yes. Functional residual capacity and total lung capacity. So here comes the topic of body plethysmography. So this will help us to measure these. No, it's not. This one you can put it. To measure these immeasurable volumes. So though we all know that spirometry is the gold standard lung function, it does not measure the volumes which you've already enumerated, the reserve volume, functional residual capacity and the total lung capacity. So body plethysmography helps us to assess all this. And also the other advantage is that for spirometry, all of us know that person's effort is very important. They have to do a forceful maneuver. Patient's cooperation is very important. Whereas compared to that, body plethysmography, here it measures all these volumes when the patient is having a normal breathing. So it doesn't require much of patient's compliance or instructions to be followed by the patient. So that's quite easy. And it does not require the forced maneuvers. So what are the indications for body plethysmography? So how do we assess airway obstruction? All of us know with spirometry, you compare the FEV1 to FVC. So this is a forced expiration. So here again, patient's effort is very important. So if he's not able to do properly and not understanding your instructions, chances are that you might not be able to identify the obstruction properly. So here comes the body box for your help, because it overcomes the effort required from the patient. It measures the obstruction in a different manner, not by FEV1 or FEC, but by measuring the airway resistance. So by measuring the airway resistance, you can identify whether the patient is having an obstructive defect or not, and confirm also what is the severity of the obstruction. The other indication is, say for example, in a restrictive abnormality, also in a person who has lot of hyperinflation. In both the instances, the spirometry will show only a reduced vital capacity. So you don't know whether the reduced vital capacity is because of a restrictive defect or the lungs are so hyperinflated that you are not able to assess the restriction. So the body box helps us to differentiate between restriction and hyperinflation, because it measures the total lung capacity as well as the residual volume. In a restrictive lung capacity, the vital capacity is reduced because the total lung capacity is also reduced. Whereas in the hyperinflation, the vital capacity is reduced because it is compromised by the increased residual volume. So by this manner, the body box helps us to differentiate between the restrictive lung disease and the total hyperinflation, which is causing the restrictive problem. So this is the body box which is around 700 to 1000 ml capacity. It has many transducers. I'll show you the pictures also. And there are various types of body boxes, but most commonly used is the constant volume plethysmograph. So before going into assessment and calculation, we need to understand what is the shift volume. So the person is sitting inside an airtight box. Okay, what we measure is the thoracic movements. That is how the person is breathing. Thoracic movements are picked up as pressure changes in the box. So the thoracic movements picked up as pressure changes in the box, and we all know that whenever the volume is increasing, the pressure will reduce. Whenever the volume is decreasing, pressure increases. This is the Boyle's law. So the body box functions and all the calculations are based on Boyle's law. So as the person is taking an inspiration, what happens is the volume expands, the thorax expands. So this causes compression of the volume in the box. So that reduces the pressure, and this pressure difference is used in calculations. I will not go into details of calculations because most of it is all automated. It is there in this thing. You should understand what is the calculation and how we derive at the values. So in a constant volume plethysmograph, the person is sitting inside the airtight chamber. We have a pressure transducer which assesses the pressure inside the cabin. We have a pneumotachograph which measures the airflow. We also have a mouth pressure. So person is holding the cheek and the mouth pressure is assessed, whereas he is breathing air from outside the cabin. Okay, so there is a shutter mechanism also. So there are mouth pressure transducers, box pressure transducers. You have a pressure transducer to measure the mouth pressure also, and the airflow is measured by the pneumotachograph, and all these are connected to the computer where all the calculations are done. So how does the measurement occur? So the box pressure changes, these are detected by either the changes of mouth pressure or with the flow rate. So these are under defined breathing. So person has to sit inside the closed box, hold his cheek, there is a nose clip on, and he has to pant gently. So we can see normally how in the body box it is done. First there is quiet breathing. So patient takes a normal tidal volume. Okay, and then at the end of expiration the shutter is closed. Okay, so again there is a few some time lag is there. After that, when the shutter is open, patient again he breathes and then breathes out completely to expiratory reserve volume. He breathes out to reserve volume, and then either it can be a slow vital capacity or a forced inspiration and then forceful maneuver. So a spirometry maneuver is also performed at the end of the maneuver when you are assessing. So this is the normal way in which the body box measurements are done. So what is shift volume? So as I was describing before, when the patient is sitting inside the box, the pressure, that is negative inspiratory pressure which he takes, which initiates the breath. Mind you, you should not get confused with tidal volume. This is the pressure which the person initiates the breath and then the flow starts. So that is the shift volume. So this is the change of volume by which the lung generates the positive or the negative alveolar pressure. So many other terminology is also there, what is called as alveolar pressure and mouth pressure. So in a closed box, when the person is breathing through the mouthpiece, okay, and if there is a shutter, what happens? The whole pressure inside the lung becomes like a closed chamber. It is a closed chamber. So the mouth pressure and the alveolar pressure equalizes. So you can substitute mouth pressure to alveolar pressure. Okay, so the alveolar pressure is the driving force for the airflow. Mouth pressure, because the shutter is closed, it becomes a closed system. You can equate the mouth pressure to the alveolar pressure. So let's, I think I had a video, but it is not going to run. This is the loop where you have the airflow, which is there in the, plotted in the y-axis, and you have a displacement volume, that is a shift volume, which is there in the x-axis. So when the patient is breathing, it forms like a straight loop like this. So there will be a loop formed like this. Depending on the shape of the loop also, you can assess whether the person is having a normal lung or is there some obstruction. So the airway resistance is calculated from, the gradient of the loop is calculated as specific airway resistance, and the airway resistance is calculated as specific airway resistance divided by the FRC pleth. So as I was telling, if there is a straight loop which is almost vertical, then definitely this person has a normal lung. Okay. If the more flatter the curve, that means there is some obstruction. If it assumes a golf club like curve, this loop, then you know that there is lot of, this is the expiratory part of the loop. So there is lot of inequality in expiration, penduloft, or if there is VQ mismatch, this leads to opening up of the loop. So this occurs in COPD. So this type of curve you can see in people who are very obese, or if there is some diaphragmatic problem. So that these problems can give rise to a curve like this. And this type of a curve will be seen in upper airway obstruction. So just by having a look at the loop, airway resistance, airflow computed to displacement volume, you can identify what is the underlying pathology that the person is having. Not only assessing the airway resistance, body box can also help us to identify obstruction and response to bronchodilator reversibility. Whether if there is a reduction in the airway resistance, by you are calculating the airway resistance and then you are giving the dilator, if the airway resistance falls by more than 20%, it suggests that there is a partial reversibility. Whereas if the airway resistance falls by more than 50%, you know that there is definite reversibility and patient is having an obstructive airway disease. So how do we calculate lung volume? So we saw that in body plethysmography you can calculate airway resistance and you also can calculate lung volumes. So the thoracic gas volumes can be calculated if the lung could be treated as a closed compartment. We already saw when the person is breathing through the mouth piece, if you close the shutter, okay, it behaves like a closed system because the shutter is closed, there is no airflow. So all the alveolar pressure becomes equivalent to the mouth pressure. So it behaves like a closed system. So it can be treated as a closed compartment and then you measure the changes in the alveolar pressure. So change in the alveolar pressure as compared to change in the box pressure. So you compare these and these can be used to calculate the other lung volumes like residual volume, your functional residual capacity and total lung volume. So you measure the occlusion pressure because the Boyle's law states that volume into pressure will always be a constant. So volume increases, pressure decreases, it will be constant, whereas volume decreases and pressure increases, again it will be a constant. So if we are able to know what is the volume into pressure before inspiration, how this is calculated is we know the lung volume because that will be calculated by person's height and weight. According to that, the this body cavity's volume we know, and we also know what is the volume in the box. So this is already known. So how we calculate the, so after inspiration what happens is only that part which is not known, what is the inspired air, that is not known, it can be calculated when you know all the other parameters. So the lung volume can be calculated when you know the surrounding air volume, that is in the box, which is multiplied by delta P, that is change in the pressure in the cabin versus delta pressure change in the mouth. So by this calculation, we know that displaced volume by airflow will give you the assessment of airway resistance, and displaced volume by mouth pressure will give you the total lung capacity. So this is a very simplified manner by which we can understand how we can calculate the lung volumes and airway resistance. So this is how it is done. Make sure a person is sitting relaxed and breathing in a tidal pattern, and the airway that it should be at the same level. Patient should not have hyper extension or flexion. So this can be done even for children. So when you're doing, you will have to adjust the height. So close the shutter at the end of expiration, then ask the person to pant quietly. So they have to hold their cheek and pant quietly at 1 Hertz against a closed shutter with the glottis open. They have to breathe. So though there is no airflow, you know the pressure volume changes in the thorax as compared to the pressure changes in the box. So record the pressures inside the cabin and at the mouth. Finally, you will open the shutter and then ask them to do that, complete expiration to residual volume and the forced spirometry maneuver. So according to the Boyle's law, when the panting happens against a closed shutter, if the glottis is open, the mouth pressure will reflect the alveolar pressure. So the absolute changes in the pressure and the volume, usually they are very small, but that is enough to calculate the whatever volumes we want, all the residual volume, functional residual capacity and total lung capacity. What is the clinical interpretation? So all of us know by spirometry, though we can confer that there is an obstructive lung disease, whenever you have a clue of restrictive lung disease with reduced vital capacity, we need to do lung volumes to confirm that there is some restriction. So for restrictive lung disorders, if the total lung capacity is below the 5th percentile of normal values, then you know that there is a restrictive lung problem. So this index, FEV1 by FVC, either FVC or inspiratory vital capacity should be normal. Also by looking at the RV by TLC ratio, again we can calculate what is the degree of hyperinflation. If it is somewhere between 90 to 140, there is a mild obstruction or hyperinflation. If it is 140 to 170, it is moderate. And if the residual volume is more than 170%, then it is very severe. So
Dr.
this is
Uma,
how
we are running short of time. Can you just go to the
this
last?
This is the last slide. This is the last slide. So this is how the final result will be. So here you can see FEV1 is 100%. So you might not know whether this is normal or is there some hyperinflation. FEV1 by FVC is mildly reduced, 63%. So there is a doubt of obstruction. If you see total lung capacity, it is high, it is 130%, and residual volume you see it is 135%. So by this you know that there is a mild hyperinflation, mild obstruction is there, and you can also see that the airway resistance, it is normal or slightly more flatter. Okay. So even though the airway resistance is slightly almost straight or flat, by these values you know that there is mild hyperinflation. So just by eyeballing the loops or looking at all these values, you will be able to appropriately and interpret what is the patient's problem. So just one example, this is a 50-year-old smoker who presented with exertional dyspnea of 1 year and right-sided chest pain. So X-ray shows a giant bulla. Now the plethysmography not only calculates what is there in the lung, but the volume which is not in communication with the airways also. So it can calculate that. So when you do lung functions, you see that FEV1 is 2.25, whereas you see the difference in the calculation of total lung capacity. By body box it is 7.9, whereas with helium dilution it is 4.8. So you can accurately calculate how much volume this bulla is occupying by doing your body plethysmography. So in this way it is very useful, and you can even assess, you know, whether the person will undergo surgery, how better he will become after your surgery by calculating this. Yeah, thank you.
Thank you so much, Dr. Uma, for this wonderful talk. The last example was also very illustrative for the postgraduates especially.
Thank you, madam, for a wonderful talk. Body box is definitely an important topic we all should know, and it's more of research purpose, and also when we start applying it, when now it's time for a lot of lung volume reduction surgeries, and a lot of lung surgeries happen. Body box actually plays an important role when we are assessing a patient pre-surgery. Thank you, sir, and thank you, Dr. Lakshmi Narasimhan sir and Dr. Narasimhan sir, for chairing this session. Next talk would be on sleep medicine and polysomnography. I would like to call Dr. Kavita Venkatnarayanan, Associate Professor at St. John's Medical College, Bangalore, to please occupy the dais. I request Dr. Harihara Murthy sir and Dr. Shashibhushan sir to please chair the session. Both Dr. Shashibhushan sir and Harihara Murthy sir, their keen area of interest is sleep, and it would be great to have both of them guiding us, and also Dr. Kavita madam to enlighten all of us. Thank you, ma'am.
At least no more pressures and volumes in this talk, and no more equations, so you can relax on that. When I got the topic, this is how I felt, but now I think this is how you are all feeling. So I've been asked to reduce it to 15 minutes, so I'll just give a brief introduction of what is important for you to know in sleep medicine. So when do we suspect a sleep disorder in a patient? Classically, you will all know this indication of excessive daytime sleepiness and snoring as the classic indications. But what you should also remember is the other subtle things that the patient may come to you with, especially insomnia. Women are more likely to present with insomnia rather than the classic symptoms, even if they have OSA. So it's important to suspect. Patients having sleep attacks, youngsters coming with sleep attacks in the class, not able to concentrate, going to sleep whenever they have an emotional outburst. Shift workers presenting with just multiple somatic complaints, they may not even come to you with sleep disturbance. And in obese patients with unexplained corpulmonal and for preoperative assessment. So some indications which are not the usual OSA patient that we see. So sleep diagnostics, as you all know, does not just include polysomnography. There are other diagnostic tests that are done, which are done even in the daytime, not just in the night times. So apart from your conventional polysomnography and split night studies and PAP titrations, you have MSLT and MWT, which are objective assessment for excessive daytime sleepiness, and your subjective assessment is with your questionnaires, most commonly used being Epworth Sleepiness Scale, and ambulatory testing, which is not very commonly done by actigraphy, more important for circadian rhythm disorders. So it's important to know as postgraduates when a sleep study is required for a patient. The most common indication being sleep-related breathing disorders, where you have your sleep apneas, be it obstructive or central. Narcolepsy, where you would want to do a overnight sleep study followed by an MSLT. Parasomnia is not really an indication for polysomnography, but if you want to document it for legal purposes, then you may have to do a polysomnography. Where it is not required would be a patient to diagnose insomnia, to diagnose restless leg syndrome and parasomnias, like I said, unless you want to just document it for the purpose of any legal documentation. Circadian rhythm disorders, as I said, can be diagnosed with actigraphy and history itself. So the types of polysomnography, the pictures will explain themselves, I think. The level 1 polysomnography or the type 1 polysomnograph having a lot of channels, the best that you can get probably, and the level 3 PSG, which is more comfortable for the patient in the comfort of their homes where they normally sleep in a normal sleep environment. So not going into details of these types, but what is important to remember is type 1 has most of the channels that you would want to have assessed for a sleep study, and it is attended by a technician, which is more important because he in a real time goes through the events that are happening and annotates those events. The same if it is unattended but has all the channels would be type 2. Type 3, like we saw, is something like a portable polysomnography where you have limited channels but still good enough for patients with a high probability of a OSA. There's a lot of overlap in the new generation devices. It's not really easy to typecast them as type 1 or type 2 or type 3 because a lot of additional channels are possible even in portable sleep machines. So other classifications which are more important for research purposes like the Scoper classification are also used but not required right now. So what are the biosignals monitored? Important ones, the EEG, which is the International 1020 system. The minimal number of channels that are recommended would be a frontal, a central and an occipital channel along with the reference mastoid electrodes. These are the minimal that are required for a polysomnography. Others, I think there's some problem with the orientation, okay. So EOG, which is important for our sleep staging. EMG also important for our sleep staging. As the depth of sleep goes on, increases from non-REM to REM, the chin EMG also decreases. Lower limb and upper limb EMG important for periodic limb movement disorders and in patients in whom you are suspecting a REM behavioral disorder where you want to look for absence of atonia during REM. More important for pulmonologists, the respiratory flow sensors. 3 important sensors you should know, the thermistor, the pressure transducer and the PAP device flow sensor. So if a patient is undergoing a PAP titration, then the PAP device flow sensor is used both for apneas and hypopnea scoring. But if it's a basic study where you are doing a diagnostic sleep study, the thermistor is used for apnea staging and the pressure transducer is used for hypopnea staging because pressure transducer is more sensitive to pick up smaller decreases in airflow. Effort most commonly used is the thoracoabdominal RIP belts that are used most commonly in most of the sleep labs, but what is recommended would be esophageal manometry, but not easy or practical. You cannot put a esophageal manometer for every patient coming to you for a sleep study. Other sensors that are used are body position sensor, more important with positional sleep apnea and for PAP titration where you want to achieve a supine REM to say that is the ideal pressure for the patient. Pulse oximetry, very important for hypopneas and ECG monitoring. Scoring the sleep study, I'll not go into EEG scoring obviously because it's not going to happen in 20 minutes. But this is what an epoch would look like with EOG channels, EEG channels, ECG, your flow and your abdominothoracic movements and saturation. So an epoch is a snapshot of 30 seconds of the sleep study. EEG waves, again not going into details, but classical waves that you would see in each stage. N2 classically seen are the sleep spindles and K complex. Delta waves, more than 75 microvolts amplitude, and slow waves seen predominantly classically in N3 stage. REM mostly identified by rapid eye movements and mixed frequency waves. Definition of apnea and hypopnea, important. More than 90% reduction in the flow signal for more than 10 seconds. 10 seconds is common. So more than 90% reduction or almost absence of a flow would be an apnea. A lesser reduction of more than 30% of reduction would be a hypopnea. Desaturation not a requirement to score an apnea, just the absence of flow is enough. But for a hypopnea scoring, you need to have at least 3 to 4% of desaturation. Two different methods are used for hypopnea scoring, or there has to be an arousal following the event. Obstructive versus central, you all know continued or increased effort in the thoracoabdominal effort channels would say it is obstructive. Absence of these efforts would say it is central. What would this be? This is the flow, absence of flow. These are the thoracoabdominal belts. Obstructive. So this is an obstructive apnea. This one, flow is a bit lower down here, and these are the movement channels. Central. So this is a central apnea. And this, like you can see, there is some reduction in the flow, but that is not really 90% reduction. There is some reduction, maybe 30%. And there is preserved movements in the effort channels, suggestive of a hypopnea. So do every patient of an obstructive sleep apnea need a level 1 polysomnography? Not really required, especially with the lack of sleep labs. Home sleep apnea testing has come up in a big way, but you should know in which patient I should be using home sleep apnea testing. Like I said, lack of sleep labs, difficulty for patients to fall asleep in a lab on the day one, the first night effect where the patient may not sleep in your lab at all and you may be wasting a study in such patients. A home sleep apnea testing can be tried, but what you should remember is you should use it only for uncomplicated patients who do not have any underlying comorbidities, or you are not suspecting a central sleep apnea in them, and they are uncomplicated patients which not many comorbidities, like I said. In simple obstructive sleep apnea suspected patients who have likely a severe obstructive sleep apnea, classic symptoms in them, we can go for a home sleep apnea testing. When we look at the sleep report as PGs, first thing that you'll all look at will be the AHI, but please remember it's always important to look at the patient's history. What is the symptom that the patient has come to you with? What is the work pattern of the patient? Does he have a shift work pattern? Does he have a lot of sleep debt? There has been travel leading to jet lag. Are there any circadian rhythm disturbances? What are the medications the patient is on? All these are very important. And in the sleep study also, make sure that you look at whether any supplemental oxygen has been used while doing the sleep study and what criteria has been used for hypopnea scoring. The summary, I'll go straight to the summary chart where you can see this hypnogram which will give you an idea of the architecture of the sleep that the patient has had. Just by looking at the summary graph, you can have almost all the details that you want about the sleep study. Like here, if you see the initial part of the graph, lot of apneas and hypopneas happening, lot of desaturation happening, no REM at all over there. But in the latter half of the night, you can see there is some CPAP placed here, some PAP therapy has been given, and the patient, the number of events have also reduced and abolished towards the end of it, and the patient has gone into REM sleep. This picture itself will tell you that it's a split night study. Both diagnostic and PAP titration has happened on the same night. So just by looking at the summary graph, you can have a lot of details. Like I said, don't just jump to AHI and end there. You have to look at other things also, any EEG abnormalities that have been scored, any ECG abnormalities, because arrhythmias are commonly associated with sleep disorders, any behavioral or movement disorders that have been annotated by the technician, and the sleep hypnogram like I showed. PAP therapy, you all know the why is it important to treat OSA? Because it has a lot of implications, neurocognitive, metabolic implications, cardiovascular implications, and excessive daytime sleepiness causing a lot of motor vehicle accidents. Whom should we treat? Mostly all the moderate to severe OSAs are treated. The gray zone is in the mild OSA where we don't know whether to treat them or not. It is important to remember that all symptomatic patients, whether it is mild or moderate, have to be treated. Any patient with impaired quality of life because of OSA symptoms, even if it is mild, we may decide to treat them. And OSA with comorbid refractory hypertension is one more indication that you should all remember. PAP therapy, you all know the mechanism, the pneumatic splint, the pressure given by the machine will keep the airways open and prevent the apneas and hypopneas and desaturations from happening. Not going into the PAP jargon, but lot of PAP therapy devices are available. But before going into each of them, you should know the basics of the PAP therapy, which is the main CPAP, that is the basic treatment of OSA. So CPAP, how much pressure do I give? I do a titration study. That is the ideal. Not in all patients we can achieve that again. So a CPAP titration is done to know how much pressure is required to get over all the events of apneas and hypopneas and desaturations and find out that this is the pressure that is ideal for this patient. Like I said, you have to attain supine REM and there should be not more than 5 events per hour for a proper optimal PAP titration. There are other definitions also. I'll not go into the details of that. So when to use BiPAP? It is important to know because a lot of patients are prescribed whatever PAP therapy they feel like. So first and foremost for all OSA is always a CPAP. BiPAP will be used only when the pressures required on a CPAP titration are too high for the patient to tolerate, or despite a maximum pressures of 20 CPAP, you are not able to achieve an optimal or a good titration and the events are not coming down, then you may have to go for a BiPAP titration also. OHS is classically thought of as an indication to start BiPAP, but no, even in an OHS patient, the first and foremost therapy should be a CPAP. Only if they are not responding, then a BiPAP may be required. APAP is something that is usually used in most of the patients. Is it better than CPAP? No, not really. And is the adherence better with APAP? Not really. Even that is not proven. Where would we use APAP? Again, like I said, for the home sleep apnea testing, in an uncomplicated patient with OSA, you can start with an auto-titrating PAP therapy machine to attain a pressure that is required for the patient. It is better in one way because you can have 3 to 4 nights or a week of APAP therapy and attain at a average pressure that the patient may require. Whereas in PAP titration, you will have only 1 night to attain a proper pressure. But again, like I said, it should not be a complicated patient, no underlying comorbidities, and it should not be used for the diagnosis of OSA per se. Oral appliances, alternative treatments other than PAP therapy for sleep apnea in patients who do not or are unwilling to go for PAP therapy at any cost. You have tried your best and he's not able to tolerate it, then you may consider oral appliances. And in patients with primary snoring without OSA, it may be tried, but not the first treatment for any patient with OSA. Humidification is important in patients who are coming to you. You start the patient on PAP therapy, they come back to you and say they are having a lot of dryness of mouth, a lot of congestion in the nose in the morning. Once they get up, they are not happy using the PAP therapy, then humidification can be tried. The interfaces that are used, most commonly used would be a nasal interface or a nasal mask or a nasal pillow that is most suitable for OSA treatment. Oronasal interface rarely used for mouth breathers and patients who are requiring a lot of pressure, where a nasal interface would lead to a lot of leakage from the mouth. Medical management, more in sync with today's inauguration of an integrated sleep medicine program. So it is not just about PAP therapy. There are a lot of other therapies that need to be considered for any patient with OSA. If there is morbid obesity, you may have to consider bariatric surgery, weight reduction programs, positional therapy for patients with supine predominant OSA, modafinil and vagus stimulating drugs, not the first line again. A lot of patients are prescribed modafinil, but it should be used only for patients who are continuing to be having excessive daytime sleepiness despite an optimal PAP therapy. And what is not recommended, only oxygen therapy for OSA, exclusive oxygen therapy, not with PAP therapy. Some patients may need oxygen with PAP therapy if you're not able to attain relief from desaturations despite abolishing all the respiratory events. If he's still desaturating, then you may have to give oxygen therapy. Now, routine use of nasal decongestants and methylxanthines are not recommended. When do we do a repeat study? The last slide. Most important, it's not really required to do a repeat study in any patient with OSA. Most of them will require the treatment lifelong. When is it important to do a repeat study? If the patient has had a significant weight loss, say he has undergone bariatric surgery or he has undergone some upper airway surgeries after your PAP titration has happened, and you think the pressures may have changed significantly, then you may need to do a repeat titration. Symptoms of OSA reappear in a patient who was controlled on PAP therapy, you may have to do a repeat titration. Or if the symptoms are not controlled on PAP therapy, then you may have to do a repeat titration. Otherwise, repeat studies are not really required in patients with simple OSA. So these are the suggested readings. I hope I have stuck to time.
Thank you. Thanks a lot, madam. It was a lucid talk. It's difficult to cover a big topic, but I have done wonderful justice to the thing. Over to chairperson.
Yeah. Thank you, madam. Well covered in a very short time. I think most of the residents are having the sleep medicine training. Most of the centers have sleep centers. I think they are well versed. That's another thing. This is an added thing what you have told. I would request Dr. Hariharan to, he would like to talk on DICE therapy. So over to Dr.
Thank you, madam. That was a wonderful talk. I know that you had a shortage of time. Compressing everything into a 20-minute talk or 15-minute talk is certainly not doing justice to it. Just to add to what she's already said, we also have included drug-induced sleep endoscopy as part of our evaluation protocols in sleep medicine. And we've been doing it for many years now, but now that we've brought it into the ambit of the department, we will be making it as a routine investigation for all patients who come with sleep-related breathing disorders. Now, why we're doing it is something one has to tell about, but that's because we have found that many a time when you have a patient with obstructive sleep apnea, you know what it is, but you don't know, one, the level of the obstruction, the extent of the obstruction, and whether it is a dynamic obstruction or a static obstruction. Dynamic obstructions are not going to be visible routinely because all the evaluations that we do in a wake patient doesn't give us that information. On the other hand, a static obstruction like a deviated septum or a conchobulosa or a polyp or etc., or adenoids for that matter in children or adults will be evaluable, but then not so a dynamic obstruction that happens only in sleep. For example, there may be a few snorers among us right now, but none of us have snored. Nobody has fallen asleep. Maybe that's the reason. But even then, you see that in the daytime when you're awake, you're not going to have those obstructions. Only happens in sleep. So what do? We make the patient sleep in a controlled atmosphere in the operating room, and under the anesthetic help, we make the patient sleep without an assisted airway. So the patient is breathing as normal, sleeping as if normal, and we then do the endoscopy. And when we're doing the endoscopy, we use a flexible endoscope and we decongest the nose before we do that. We pass the endoscope and we evaluate from the nose downwards every single level. The nose, the velopharyngeal area, the oropharyngeal area, a little bit of the epiglottis as well comes in there, the epiglottis and the larynx. So if you are having any obstruction that's happening during the sleep, that's going to show up there. And many a time, just a deviated septum or a hypertrophy turbinate or a conchobulosa causing an upper level obstruction gives rise to a Bernoulli effect causing a collapse of the velopharyngeal area, collapse of even the epiglottis. You can have a floppy epiglottis causing problems there. And those are things that will get compromised and increased during a CPAP. So this is how, when we found problems, we realized that we need to do more than what we're already doing, and that's how the DICE came into practice, and we are doing that as a routine. So just to avoid wastage of time, I'm not going to show you the videos, but I'm going to share them with Dr. Shivalinga Swami, and he's going to send it to all of you. So you can see those videos. They are uncut videos, so you can see them at your own leisure to know what a DICE entails and what you can get to see. You will see the collapse of the tonsils and the pharyngeal cushions coming inwards completely collapsing and reducing the airspace there. You can see the squeezing shut like a purse string of the palate and the surrounding tissues. So all these things are visible for you in the videos. I hope you can go through them at your leisure. Just to give you a bird's eye view, we will be conducting a workshop later, we hope in a month's time, and maybe if you're interested, you can always come to see what our department is doing. Thank you very much.
Thank you, sir. Thank you for a wonderful talk. Quickly moving on to the next session, I would like to request Dr. Sandeep HS. Sir is a consultant pulmonologist in BGS Clinicals Hospital, and his topic will be on chest ultrasound. Thank you, chairpersons, for being here. Thank you, sir. Dr. Uma, madam, if I can request you to please chair this session.
Thank you very much, Shivling Swami. I think at the outset I would like to thank my teachers, Dr. Uma and Dr. Priya, who has made me capable enough to deliver this lecture. I think this is one of the most, revolutionizing development in the field of pulmonology, where we will shortly be replacing, I think I have always been telling it, we will shortly be replacing stethoscope and we will be applying ultrasound in our day-to-day clinical practice. So as we are running short of time, I'll try to run through my slides. Maybe anyway, there is a hands-on workshop. You can sort out one-to-one questions there on the during the workshop. Next 20 minutes, we'll discuss about a few points about the machine, what ultrasound machine are we going to use, when are we going to apply this chest ultrasound, how are we going to do it, and what else you can do with the help of an ultrasound machine in your OPD or maybe in IPD during the IPD rounds. So what is ultrasound? You might all be knowing. It is a mechanical longitudinal wave with a frequency exceeding the upper limit of human hearing. Human hearing is somewhere around 20,000 hertz to 20 kilohertz. Medical ultrasound is 2 megahertz to 16 megahertz. How is it produced? It is by produced by passing an electrical current through the piezoelectrical crystal. So this is how the image is generated. So electrical energy passes through the piezoelectrical crystal. This leads to sound wave, and the same sound waves are reverted back to the piezoelectric crystal, and they will generate an image. The most important thing what you should know is the thickness of the crystal determines the frequency of the scan head. That is, lower frequency scan heads are there and high frequency scan heads are there. Higher frequency is for better resolution. So when you want to see some superficial structures like veins and all those things while doing CVC catheterization and all, you need a higher frequency. Whereas if you want to see a deeper penetration, so you will require a lower frequency. So these are the various probes. This is the TVS probe. So this is the most common ultrasound probe which we use in our day-to-day clinical application, that varies from 3.5 to 5 megahertz of frequency. So this is the vascular access probe, which has got a slightly higher frequency, 5 to 10 megahertz. So higher frequency, better resolution. Lower frequency, better penetration. This is something which you have to remember. So type of machine for chest ultrasound, any basic level machine should be okay. We don't need a 4D, 5D machines. Simple, basic. See, in radiology, they might have scrapped few machines, okay, with the recent advances. So the scrap machine can be used in a pulmonology OPD. Any basic level machine is enough. Advanced machines, there are no additional advantages. Preferably smaller and mobile is something which we look for so that we can carry that easily. I still remember we used to do clinical rounds with ultrasound machine in St. John's. Every patient, instead of auscultating, we used to do ultrasound on them. That will help us to identify. I mean, for example, we are dealing with the pleural effusion, whether it is increased, decreased, consolidation, whether it is increased, decreased, all those things can be monitored on a day-to-day, basis. So this was the machine which we used to use. This is a simple sonocyte machine. So these are various knobs which are seen. I think there are few areas where you have to concentrate. The most important one is initially you have to set up the patient, enter whatever the details. These are the modes which are available for our examination. What is the most common mode which we use? That is a 2D mode. 2D mode is more than enough. The other modes like M mode, Doppler, color modes, they are rarely used, okay, only under certain circumstances. 2D mode is the ideal one. Images are clear and better. They are suitable for routine scan and interventions. M mode, rarely useful, only during special situations, like identification of lung point during the pneumothorax identification. Doppler mode, not very useful in thoracic USG. There is something called as color. So to screen the area before performing an intervention. So if you want to perform an intervention, to see whether there are any blood vessels which are coming in between your needle and the site of action, you can identify with the help of that color mode. This is something which we have to understand. There is something called as color sign. There is always a confusion in differentiating pleural thickening from pleural effusion, whether it is really a pleural effusion or a pleural thickening. How do we identify an ultrasound? It is just by applying a color mode in that particular area where you are seeing anechoic image. So fluid is a mobile one. With every breath of the patient, there will be a vibration set up in the fluid. Okay, that will generate some color artifacts. Whereas in pleural thickening, no such artifacts are generated and that color sign will be negative. So this is how you differentiate between pleural effusion and a pleural thickening. So coming to the left hand side of the machine, these are the various knobs which are used to adjust the gain. Okay, these are all subjective things. Okay, gain is, you can adjust the far gain, near gain and the total gain. It basically helps us to adjust the brightness and visibility of that particular image. There is something called as auto gain, which might help us to, if you press that button, it will give a better image directly without making us do any adjustments. Again, most importantly, it is subjective. There is no hard and fast rule that you have to set it for 15, 20 or something like that. As long as you are comfortable seeing the image, that is more than enough. Depth, again, depending upon the site of lesion, you can increase or decrease the depth with the help of this knob. Transducer plays a major role. So what you have to understand, higher frequency, less deep. Lower frequency, more deeper. That again is a subjective thing. You have to ensure that you have got a better visibility by adjusting the depth. Scale or caliper, this is again important tool. So it helps us to measure the distance from the skin to the site of action. Quantification of fluid also. Is it really important to quantify fluid for us as a pulmonologist? Is it important? What are you going to do? What decision are you going to make depending upon the quantity? Whether it is 500, 750, 1000, how does it really matter to you? According to me, quantification of fluid has got no value in deciding treatment of that particular patient. Whether if it is 500, 1000, the patient is not breathless, he is having a TB effusion, you don't need to drain it. Even if he has got 750 ml and the patient is breathless, his ventilation is compromised, you might have to drain it. So quantification of fluid is not really important in our day-to-day clinical practice, and caliper is something which can be used to quantify the fluid. I will show you the algorithm for that. And it helps us to plan our interventions. How deep is the structure? So how deep should I go with the help of my biopsy needle or something like that? It helps us to identify. So this is just a nomogram kind of a thing. Maximum perpendicular distance between pulmonary surface and the chest wall. So if it is 50 millimeter, then the approximate fluid will be somewhere around 1500. You can get it in the internet. You need not memorize it or something like that. So coming to chest ultrasound proper, air is considered as the enemy of ultrasound. Okay, that is what, see, ultrasound had got a wider application, but it was never applied in a thoracic, in thoracic organs, because we always thought air is a enemy of sound. In thorax, we see air and water are intimately mingled. It is mainly based upon the analysis of the artifacts. It is not the analysis of the facts. It is analysis of the artifacts. All signs arise from the pleural line. This is something which you have to remember. So in these two CT scans, where will you be able to apply the ultrasound? The left hand one or the right hand one? The right hand one, because the lesion is more abutting the pleural line. Here, the lesion is away from the pleura. So the application of thoracic ultrasound in this scenario will be less as compared to this scenario. Okay. Scan lines, again, there is no hard and fast rule. You can just go on putting the probe like the way you put your stethoscope in those areas. There is no there is no principle to follow here. Where all you find the auscultatory spots are there, the same spots can be used to examine the lung in ultrasound. So the most important thing what you have to see when you put your probe is this called something called as a lung sliding. Okay, it is a dynamic line visible at the pleural, that is a sparkling, twinkling, glittering, shimmering, whatever you might say. But this is most important thing which we have to observe when we put the probe. Most important thing to see when you put an ultrasound probe on chest is what? Lung sliding. Okay, it indicates that the lung is touching the chest wall and the one visceral pleura and parietal pleura are sliding over each other. Okay, this is a video. Oh. This is the line. This is the pleural line. Okay. So what are a few normal artifacts which we see and which will help us to identify the pathologies? The most important ones are the A lines. These are the horizontal hyperechoic lines parallel to the pleural line. Okay. So A lines are horizontal. Distance between A lines is equal to the skin to pleural line distance. So from skin to pleural line there is a distance, and at equidistant there are artifacts which are horizontal lines. They are called as A lines. Okay. A lines without lung sliding is a sign of pneumothorax. So basically when the underlying lung is collapsed, the A lines are more, but we don't see the lung sliding. So absence of lung sliding with the presence of A lines is an indicator of pneumothorax. Again, see, everything has to be interpreted clinically only. So you are suspecting pneumothorax, you put a probe, you see absence of lung sliding, you see more of A lines, absence of B lines, then you are much more convinced that the patient might be having pneumothorax. Oh, this is also not playing. What happened? I don't know. Everything is there here only. Huh? I checked there also, no? It was playing only. Without videos it is very difficult. Yadu, namda, idu. Okay. I think without videos it is difficult. Okay, anyway, leave it, I'll just see. So this is the lung sliding pleural line, and this is the skin, this is the pleural line, and at equidistant you are seeing these horizontal artifacts. They are called as the what? A lines. Now coming to another line, after A there is B line. Okay, B lines are also called as comet tail or lung rockets. They arise from the pleural line. They extend across to the bottom of the screen. Normally around 3 to 4 B lines in the lower lateral lung zones are seen because of the increased fluid content in the lower zones. Okay, so A lines are horizontal, B lines are vertical. Again, so unfortunately the videos are not playing. So these vertical lines, okay, it is a dynamic thing actually. Once you see the video, you should have been in workshop. We will be able to demonstrate it better. So when do we do ultrasound? So if you ask me, I would like to do it on every single patient of mine, because it allows for an immediate assessment of the patient and it can potentially augment the physical examination of the chest. What are the advantages? Immediate application at the point of care. It is relatively cheap, mobile, no radiation, short examination time, can be performed by a single clinician. And one of the most important thing in St. John's which persuaded us to perform ultrasound is we had to plead radiology. It is a huge institute. I mean, we used to get appointments after 2 or 3 days, and for a single chest ultrasound patient had to wait for 2 or 3 days unnecessarily in the hospital. So that made us start ultrasound on our own, and here we are. I think madam, they are doing a revolutionary work in ultrasound. I think they have they have conducted so many workshops and made many people capable of using ultrasound in their day-to-day clinical practice. So the indications for ultrasound: qualitative and quantitative description of pleural effusions, pleural thickening assessment, diaphragm function. Again, fluoroscopy is gone out of fashion now. So we can assess diaphragmatic function with the help of an ultrasound. Pneumothorax identification, thoracentesis. You might be knowing that a doctor from Hinduja was sued for not using ultrasound guided ICD placement. Okay, so that nowadays it is mandatory to do thoracentesis under ultrasound guidance only. Sampling of lesions again arising from the chest wall, pleura, peripheral lung and mediastinum. These are all the some indications where we can do sampling also, some interventions also with the help of a ultrasound. So how do I do it? Most basic entry level 2D black and white ultrasound equipment is more than enough. Doppler and M mode are not essential. Frequency of probe around 3.5 to 5 megahertz, that is abdominal probe, is more than enough. Familiarity with the basic controls is what you should have. That is how to adjust the depth, how to adjust the gain and how to freeze the images. Position, posterior chest, sitting position, lateral and anterior chest, lateral decubitus or supine position, whichever is comfortable for the patient. That is very important. Probe longitudinal with the transducer indicator in the cephalad position. You will all see this practical application in the workshop. Technique, most important is position the patient properly. Identify the area of interest. See, before you will not be doing, maybe you might have got a history of the patient. Maybe patient is having an X-ray already with him. You see the X-ray, you are concentrating on the maybe right lower lobe area, means you have to identify that area of interest first. For example, if you are biopsying something, you are seeing a mass in the right upper lobe. So that is the area of interest. You have to have a prior idea only before, planning the procedure. Adequately adjust the image. Keep the pathology at the center. That is very, very important. Examine in a uniform manner, and you can use the, similar to auscultation, you can use the opposite side as a control. How do they look? So how does the normal thorax look? There are few appearances, bat wing appearance, lung sliding is something which you have to see, as I told, A lines, B lines, and the most important one is a curtain sign. So pleural line, this is the pleural line, okay. So these are the horizontal, what? A lines. So they are equidistant from the skin to pleural line, okay. Lung sliding, again, the video might not be playing, so I will skip this. A lines, B lines also. So these are horizontal lines are the A lines and vertical lines are the B lines. Coming to the assessment of pleural effusion, how does the pleural effusion look? It looks like an anechoic image located above the diaphragm. I still remember, I will come to the biopsy. Amount as little as 20 ml can be identified with the help of a ultrasound. Earlier, what is the method? And this is the MCQ quiz question, I think. Which method? Lateral decubitus. What is the amount of fluid required? It is at least 150 ml. So, as low as 20 ml. Again, this might, unnecessarily propagate us to investigate the patient more also. That is why I told you, clinical context is very, very important. Sensitivity of more than 97%, specificity of 99 to 100% is the advantage of this thing. This is something called as quad sign. So this is the pleural line. So from this particular area, you are seeing these vertical lines. Okay, they are what? B lines. Basically, here there is an anechoic image. So this is pleural effusion. Basically, it is not the real B line. They are the artifacts. Okay, arising from the lower border of the upper border of the collapsed lung. Quad sign also here you can see. This is the anechoic image. I think these are all wonderful videos were there. I think they are not playing, unfortunately. So this is the, what is this area? This is diaphragm. This is anechoic image above the diaphragm. So probably it could be pleural effusion. Okay. It is ideal for the detection and quantification, more sensitive than decubitus expiratory films, anechoic homogeneous space between the parietal and visceral pleura. Appearance may vary depending upon the nature also. I think if you are dealing with the transudative, the appearance will be more clear. If at all it is an exudative, there might be some debris inside and they might appear more echogenic. Okay. Anechoic transudates, complex non-septated, complex septated, homogeneously echogenic. These are all the possibilities which we can see during the examination of a pleural effusion. So here you can see. This is more of a clear fluid. Okay. What is this? That is the collapsed lung, which is coming in and going out. So these are the septae. So this is more of a simple pleural effusion. If the patient is having LV ejection fraction of somewhere around 30, would you further evaluate it? No, it is already more or less conclusive that it could be a transudative effusion. So here you can see the septated thing. These are all the septas. So this is a complicated parapneumonic effusion where you might have to intervene. Okay. So this was again an old empyema of one individual. He had come to us with right sided lower chest pain. So this was a small loculi of pus which was seen, and eventually after aspiration it got settled. So quantification, according to me, it has got no role. You can quantify it like minimal, small, moderate, depending upon the distance of this thing. Pleural thickening, focal lesion arising from either pleura that is greater than 3 mm in width. Distinguishing from small effusions can be challenging. I told you, what sign? Color sign. Color sign. If color sign is there, it is pleural effusion. If it is absent, it is pleural thickening. So pneumothorax again requires more experience than the detection of pleural fluid. The more you do, the better you will be. Similar to auscultation only, the more chest you hear to, the better will be your auscultating skills. Absence of normal lung sliding should be there. Exaggerated horizontal A lines, absence of B lines, and presence of something called as lung point. These are the various features which we see on lung ultrasound. Pneumothorax following transbronchial lung biopsy can be readily excluded with the ultrasound with a sensitivity of 100% and a specificity of somewhere around 83%. Ultrasound is superior to chest radiograph in diagnosing pneumothorax following blunt chest trauma. This again with a sensitivity of 92% versus 52% of the chest radiograph. Lung point, it was a very nice video. We could have easily seen the lung coming in and going out. Unfortunately, not getting played. So diaphragm again. The movement of this also was a wonderful video. Not playing. This is a consolidation. Okay. Here, whatever these white dots you are seeing, what are they? What is that? What is the classical sign of consolidation on chest X-ray? Air bronchogram. Okay. So this is the air coming in and going out of that particular consolidated low bar segment. This was a lung mass. I think there were a lot of interventions videos. So what you can do interventions, both diagnostic and therapeutic. Evaluation of chest wall lesions, pleural tap, pleural biopsy, parenchymal biopsies, mediastinal biopsies can be done. Therapeutic, thoracic drain placement. What are the general principles of procedures? Position, mark the intended site of needle insertion, that is very important. Determine the depth and direction. Do not alter the patient position, that is most important. Whatever position you have done the chest ultrasound, you have to keep the patient in the same position. Pleural fluid aspiration, it is superior to chest X-ray for the determination of optimal site of thoracocentesis, minimizes the risk of visceral pleural puncture, risk of pneumothorax is reduced. Again, this is the, what is this? This is diaphragm. What is this? Hyperechoic or anechoic image? This is anechoic image. Okay. So, what is this? This is a needle. So, this is a diagnostic thoracocentesis, what we are doing under ultrasound guidance. So, this is the needle. Actually, there was a nice movement of in the video, but it is not getting this thing. Closed ICD placement, it is ideal for placing the closed ICD, and you should use ultrasound before placing a chest drain. Okay. This was a video of, this was a pleural nodule which we had biopsied. So this was a mediastinal mass. So to summarize the intervention, first is keep the lesion in the center, identify the pathway of the needle, mark the area, that is very, very important. And once you mark the area, prepare the area in a sterile way. Either you can do a real-time ultrasound guided procedure or a blind procedure once you have identified that particular path. Okay. To conclude, it is a non-invasive imaging modality. It has got many applications in pulmonary medicine, allows the diagnosis at the point of care, that is very, very important. Very useful in planning the treatment, guides sampling by aspiration and biopsy. Thank you for your patient listening. Further questions we can take it during the ultrasound workshop.
Thank you, Dr. Sandeep. I think we used to run full-day workshops or 2-day workshops of ultrasound. He's very diligently shortened it to 20 minutes. Unfortunately, of course, the videos were not playing, but yes, he has done full justice to the... Yeah. Any questions? Yes. No, if you have applied to the ethics committee and approval is done, ultrasound should not be... Not necessary, sir. Once you say that This is not in any way related to, see, the major objection comes when they say that, you know, your ultrasound is used for fetal gender determination and then this thing. We have that PCP&DT Act and this thing. No, critical care also every day, day-to-day practice, they are using ultrasound, and there are a lot of papers also from critical care, like differential thickening of the diaphragm, weaning index, all that. These papers have come from critical care only. They are not certified radiologists. So way forward is we'll have to convince them that, like for example, for many years, obstetricians and gynecologists, they've been using ultrasound. Even they are not trained radiologists. But of course, for their day-to-day practice, they are using the ultrasound. So it should not be a... Not both. Yeah.
Thank you, madam. Thank you, sir, for a wonderful talk. Another 2 more talks are there, and I know all are hungry. We will try and stick on to a shorter period of time. The lunch is already ready, and
Good afternoon. Thank you, Swami, for this opportunity. I have too many disclaimers here. One is a dynamic speaker just spoke before me, and I have 10 minutes time, and you are all hungry. So, like Swami gave an option, whoever is very hungry can leave also. Let me start with basics. Non-invasive ventilation is ventilation without any intervention into the airway. May be provided by giving a positive pressure to the airway or a negative pressure onto the chest wall. What it does is it avoids intubation and it prevents all the complications of intubation and ventilation. Basically, there are 2 types. One is negative pressure ventilation and a positive pressure ventilation. Negative pressure, which was developed very early, had all these tank ventilators, iron lungs and cuirasses, and they are outdated now. There is very little available. I tried even to see what were the modes that were used. Only one paper I could find where it said INPV, probably it is intermittent negative pressure, continuous negative pressure and high frequency. That's what I understood, because even the description was not available. Okay, so most of it, what we are doing is a positive pressure non-invasive ventilation today. So everything what I am going to talk is about positive pressure non-invasive ventilation. And why is it so important? Because it has advantages. Early you can initiate ventilation. You don't have to, once you put a tube, ET tube, there are a lot of things to take it out. But NIV, you can put it now, take it off after half an hour. So you have that advantage. You can do it anywhere, not only in ICU and wards, you can do it. And you can do it in an intermittent fashion also. So what it does is it avoids invasive airway involvement. It avoids sedation and paralysis of the patient. You can still have a patient awake. It allows removal of secretions, eating, speeching, and even the patient can cooperate with you. So what about the history? For all pulmonologists, at least 2-3 history we have to remember. One is like if you see invasive ventilation is as back as 16th century. People knew that if you pump air into the breathing tubes, the patient or the person can be kept alive. But then came the non-invasive ventilators, mostly iron lung, where the patient himself was put into the ventilator and the suction effect was done so that the chest could expand. These actually were a boon in polio epidemics, where it saved thousands of people, but it was very expensive, cumbersome and large one. And it is said that each of these negative ventilators would cost equal to building a house at that point of time. Okay. So coming to non-invasive ventilation proper, we all know Alexander Graham Bell as a person who invented telephone, but there are literature evidence saying this is his own drawing from his hands where he lost a son because of respiratory distress, and then he was the one who thought of non-invasive ventilators for children. Then comes the mask ventilation was used as early as late 17th century or 18th century in England, where they used to use glass masks and tubings to resuscitate people who fall into this lakes when it is icy waters. Okay, then this you have to write if any questions are asked on NIV. I think smother the small dog and to see it revived. So one boy was sent to bring one stray dog from the street. They choke it so that it stops breathing, then they ventilate it to revive it. This is how they proved non-invasive ventilators can work. Okay, this happened in May 1908, and this at least history we have to know about non-invasive ventilator. Others are Drager did the first one. They had a single tube. They did not think of expiratory ports, so patients used to have CO2 retention. Then comes a next inventor who makes it 2 tubes or a valve he puts. So those are the history. So this is the evolution chart. You can find it online. So the evolution of NIVs and its usages over the period of time. So this I will take a little time because you need to know the physiological basis why we are using non-invasive ventilators. So lung or respiratory system has 2 functions. One, lung proper does the job of exchange of gases, and there is a series of organs and organ systems involved in pumping the air inside and pumping out. So logically what NIV does is it helps pumping in air. So logically the NIV should be more useful here in helping the respiratory pump. Okay, the air is not going in and coming out, patient starts building up CO2, and there is a type 2 respiratory failure or a hypercapnic respiratory failure. So you are using a device or a mechanical device to pump in more air, and you are washing out carbon dioxide. Yes, however, there is also a role of NIV in hypoxic respiratory failure. How in hypoxic respiratory failure? It keeps your lung, or you can say more precisely, alveoli open. It keeps your alveoli open by providing that end expiratory pressure and helps in gas exchange. So it is also useful to some extent in hypoxic respiratory failure. Indications are many, and they are adding day by day, but you can classify them as acute hypercapnic respiratory failure of various causes, or it can be acute and chronic hypercapnic respiratory failures. We have seen NIV usage in intensive care, like in weaning to avoid reintubation, and also we saw recently in respiratory pandemics also, where we put the NIV just to reduce the respiratory distress or reduce the work of breathing of the patients. We also have NIV indications on the long-term basis. Okay, so coming to the interface already madam told about the interfaces. So whether you have to use a nasal mask or oronasal mask does not matter. According to at least this recently published study, it does not matter because patient convenience is the important one. What is more important is in acute settings or first time if you are putting a NIV for a patient, it is preferable that you use both nasal and oral mask because they are not used to that support. So in acute settings or first time, it is ideally that we have to use a oronasal mask. Are there contraindications for putting any patients on NIV? Very few. Like first, patient should be in a respiratory arrest. What will you do putting NIV? It does not do anything on its own. Active participation is required, so that is absolute contraindicated. You have untreated pneumothorax, which can worsen because you are pumping in more air through the upper airway, and inability to protect the airway. Patient is not having airway reflexes, so you put on top of it, you push the air into his throat, then he is going to go into problems. Relative are cardiac ones, mostly if the patient has angina or evolving MI, all those conditions. Again, this is a procedure which may add stress and worsen the conditions. What are our goals when we are putting NIV? It is to assist the ventilation and to prevent the patient going into endotracheal intubation. However, if there is a respiratory support required, mostly it is invasive respiratory support. To see that if we can avoid that and its complications, we use NIV support. So I will not go into details of interfaces. So these are the types of interfaces that are available. You have oronasal mask, only nasal mask, full face mask, and recently also we saw helmets also.
Okay, there are advantages and disadvantages of each one of them. I won't go into details of that because of lack of time. Now the latest is the customized mask. You can have, for a patient who is planned to have a long-term NIV, there are customized masks which improves the fit, but it takes time for procuring the mask itself. Okay, see that whatever you use, make it comfortable, and the patient, if he is comfortably adjusted with the interface, it is fine. Next, you should know the circuits. Many of us in the beginning, we don't think whether it is a single tube, dual tube that we are using, because we don't think that where is the expiratory gases going out, from where are they going out. So there are ventilated masks where sometimes I have seen they don't open the expiratory port only. Neither the sister would have noticed it, or the resident, a newly joined resident, would have not noticed it. So make sure where the expiratory gases are going out. Either there are two tubes, valve is there, or there is a expiratory port in the mask. Okay. So now again, this is also a little important. I will go slow. There are terminologies that you should know when you are dealing with non-invasive ventilation. There is a term called as IPAP. There is a term called as EPAP. And there is a term called as respiratory or inspiratory times. There are inspiratory times, fall time and rise time. I'll go each one of them in detail. So inspiratory positive airway pressure is the pressure that you give while the patient is taking a breath in. Okay, what does it do? It assists inspiration. It decreases the work of breathing of your respiratory muscles. Basically, inspiration is an active process and expiration is a passive process. So your muscles are working during inspiration. To help them work less or reduce their workload, you are using a pump to push the air inside. Okay, so what it does, it increases the tidal volume, it increases the minute ventilation and effectively the alveolar ventilation. It alleviates respiratory distress by reducing the work on the muscles. It improves respiratory muscle function because you are resting them, you are giving them some rest. Okay, it augments alveolar ventilation and reduces the dynamic PEEP. You are giving adequate time for inspiration and expiration, thereby preventing that auto PEEP that patient would have generated. EPAP is the pressure at the end of your expiration. When the patient is expiring, there is still some pressure that is holding on. It is mostly for a pneumatic stenting of the airway. You does not want the airway to collapse. Whether it is the large upper airway in cases of OSA, OHS, or the small airways in cases of hypoxic respiratory failures, where you are stenting the airway, giving a back pressure during expiration. Okay, so effect is it improves gas exchange. Mainly, like I said, it keeps your alveoli open. Gas exchange is helped. Improves lung dynamics. Lung dynamics, because I can explain this in simple terms. If you are allowed to blow a balloon, it is easy to blow a balloon when it is partially expanded. From the 0 to 100 is difficult. If it is from 10-20, it is more easier. So that is what the improving lung dynamics means. Okay, it improves respiratory muscle function also, because the muscle is working at a much lesser resistance from the already partially opened lung. Okay, so inspiratory times. This is available in few portable NIVs and mostly available on a ventilator, critical care ICU ventilators, where the time is set to deliver the inspiratory volume, particular time is set. So you want that volume or the pressure to be delivered only during that part of the inspiration, and the rest of the time is available for gas exchange or the expiratory time. What happens if you do very short time, if you keep, that means premature cycling occurs. The inspiratory time is too short, so you are not supporting the breath adequately. The patient is still breathing in and the machine has stopped the support. So that's premature cycling. If you take a long cycling, if you give large time, patient is breathing very fast, very heavily, so the machine is still in inspiratory phase and patient is already expiring. So the time that you give for inspiration has to be decided on the needs of the patient. Patient who has a compliant lung or a COPD would require a quick air and more time for expiration. But patient who has a stiff lung is not able to inhale quickly, so you need more inspiratory time to push the air inside. So what is rise and fall time? The time taken for the IPAP pressure to reach. Once the inspiration starts, how much time is it required to reach the maximum peak pressure that you have kept? So that is the rise time. Fall time is what is the time required for the expiratory pressures to come back to what you have said. Okay, these are again depending on how the respiratory rate of the patient is there, we can set these times, and it is available in only few selected NIV machines. What is volume and backup rate? Now current portable NIV machines also give you an option to set a predetermined volume of the tidal volume. So you are setting a pressure and then a volume. We say that between this pressure we want to give at least minimum this much of volume. Rate is when patients you are treating where the adequate respiratory drive is not there, so you make sure that some breaths are given by the machine, so that if the patient stops breathing, machine has some backup rates. Trigger is mostly for when to initiate the breath. So mostly our NIV machines are pressure triggered. There are also volume triggered ventilators where you use in the critical care. Here you have to make what the point to note here is, if patient has lot of leak, so the trigger may not be there. So there may not be trigger. The machine may not sense the change of flow or pressures if there is lot of leak. So you have to see that there are very little leak. Cycling is again changing from inspiration to expiration. When the machine has to change, whether the pressure drop or the flow drop, those parameters can be set to see if there is cycling. Oxygen, yes, various ways we give oxygen. See that it is comfortably given, not interfering with your pressure changes. Humidification is a must. Earlier there was controversy whether humidification is required or not, because the air is going through the nose. Like in natural process, we are breathing through the nose, mask is also giving the air through the nose. But now, no, humidification is a standard of care. So all if wherever possible, all NIVs should have a humidification system. They say that when you are using HME filters, especially in ventilators on NIV, there is a pressure loss, because you are putting a HME filter between the ventilator and the patient's interface. So see that also is taken care of. There are volume preset and pressure preset. I will not go into details of that. Volume preset is where you set a volume that is to be delivered. Pressure, most of the other NIVs are pressure preset. So you set the pressure and it delivers the presets. Okay, these are differences. I will not go into that. Portable or critical care ventilator, which is better? There are advantages and disadvantages for portable and critical care ventilators, but both will serve the purpose if you know how to operate them. Now coming to modes of NIV, one word on each. We know what is a CPAP. CPAP is the same pressure throughout inspiration and expiration. You are giving a fixed pressure, mostly used to keep the airway patent, especially in OSA, OHS, or to keep the lung open, like in cases of pulmonary edema and other cases where you want oxygenation to occur. Then you have BiPAP, where you are giving inspiratory separate pressure and an expiratory separate pressure. You are giving adequate time and space for the patient to expire properly. So that is why you reduce the EPAP. IPAP and EPAP. The difference between IPAP and EPAP is the pressure support that you are giving. Okay, so the distance should be adequate. You cannot keep EPAP and IPAP and EPAP together. So you need to have some gap, so that's the pressure that is driving the gas into the patient. Okay, so others, there are some terminologies I thought you should know. I wanted to detail them, but yes, proportional assist is, it is assisting the patient not with a fixed pressure. It will assist the patient based on his effort. If the patient is having good effort, less pressure support is given. If the patient is not doing much effort, then more pressure is given. This is mostly in patients whose CNS is little down, patient is comatose, or patient's central drive is less. So every breath by breath, his effort will vary. So this is proportional assist. Okay, then there is something called volume assured pressure support and adaptive servo ventilators. These are again depends on the company, they have different names. Here also the assured volume is given, but within your specified pressure limits. It won't cross the pressure limit, but it will see that within that limit some volume is given. So monitoring, how will you do the monitoring when you put a patient on ventilator? You have to see every 15 minutes initially. After that you can go on increasing the time of monitoring. What should you observe? All vital parameters you should observe. How often do you do ABG? First time it is at least 1 to 2 hours after immediately initiating the NIV, so that your NIV is working or not you will know. After that every 4 hours, 6 hours, based on the patients you can do this. This is all what you have to monitor: patient parameters, ventilator, machine parameters, leaks, circuits, ABGs. Okay, there are clinical parameters, physiological parameters, and machine related parameters that you have to monitor. Whether oximetry or capnography is a question, whether we have to monitor pulse oximetry or oxygen saturations or CO2 output. It is said that both are equally effective, but CO2, if you can monitor, that is more better. So there are various methods in various areas how we can monitor CO2, whether it is being washed out properly or not. These are the parameters. Or clinically also we have scores. If there is hypercapnic respiratory failure happening, we have these scores which can help us to monitor. Predictors, how do you predict it is going to be successful? Younger patients, less severe problem obviously will improve. Poor outcome is when you have a very bad lung, or the patient is having a lot of secretions where he cannot bring out. Those are the poor predictors. What if the NIV fails? NIV fails, your immediate next option is to go for invasive mechanical ventilation. What are the complications? Very less. In the literature at least there are very few. If you carefully monitor, then most of the times NIV causes very less complications. Maybe the complications may be there because of interface, because we are using it for the long term. All pressure related, dryness or sinusitis, all these are aerophagia, all these things are related to the interface that we are using. Okay, so most common question only I have put last 5 slides I think, but CO2 retention is there even with all your efforts. What you will do, check for adequate ventilation, whether the patient himself is breathing properly or not, you check, whether his chest is rising or not, whether he is generating adequate tidal volume or not. So you can increase the pressure to increase the tidal volume. Okay, and if possible sometimes change the mode of ventilation that you are using. If you are using CPAP, try a BiPAP level. If you are using only BiPAP, change that and see. Okay, rebreathing, synchrony and leaks also should be checked if you are having CO2 retentions. If the patient is CO2 is good but hypoxia is still persisting, what you do? First thing is you increase the FiO2, increase the oxygen supply. Then EPAP, only these two things can help. Or you confirm with the ABG whether your pulse oximetry is proper or not. Is oxygenation may be good. If nothing is working, go for invasive ventilation. So what is the take home message? A great deal of variation exists between devices. Clinicians need to be aware of different terminologies, performance characteristics and capabilities that exist in the devices that they have, because each device, each company has different parameters, terminologies and settings. NIV requires active participation of both the doctor and the patient. It is not like invasive mechanical ventilation. You sedate and paralyze the patient, set all the ventilatory parameters and you can go off until the alarm buzzes. It is not like that. You have to stay with the patient. You have to, at least first time when you put somebody on the mask, you try on yourself. You have to talk to them, you have to console them, you have to say nothing is going to happen. Okay, so active participation of the patient and the doctor or the caregiver is required. Constant monitoring and looking out for signs of worsening and minor adjustments as and when required is the success mantra. If you can do the NIV properly. These are my acknowledgement. I was very inspired by Dr. Ajay Anda's presentation. These are your references and further reading. Okay, thank you.
Thank you, sir. Thank you, sir. It was just up to the point and very lucid and amazing. And I was seeing everyone very attentive and listening to the talk. So I'm sure all your insulin levels are pretty high, blood glucose are low, and glucagon is breaking down. Last but not the least, let us have the final talk, and we're privileged to have Dr. Syed and have not seen a bigger physiology man like him. So sir will definitely take you through a wonderful topic, iOS FOT, which is a very important topic. I hope all of you please gain attention. I'm sure I am between all of you for the lunch, so please bear. See, you are definitely getting a greater advantage of listening to all high-value speakers who are imparting you great knowledge. That's more important here, what I want to really say. So let us go through this last topic, and I request Dr. Basha Khan sir, so please chair the session. Sir is a senior pulmonologist and lung transplant physician at Narayana Hridayalaya Hospital. I welcome Dr. Syed sir. Sir is a senior consultant pulmonologist at Narayana Hridayalaya Mazumdar Shah Medical Center at Narayana Hridayalaya, Bangalore. Welcome, sir.
Mic idea? Caller mic.
Hello.
So actually we are all seasoned test players. This fellow is making us play a T20, and he has applied a duck with liver system also for me. In so much time you have to finish. It's a big task. It's a difficult topic. I'll try to finish in whatever 15 minutes, 17 minutes he has told, and probably we'll have a case-based discussion in the workshop. Few basics, very difficult, lot of physics involved. Okay, I'll start with this case. I think most of us see this case like this. 63-year-old gentleman, chronic smoker, breathlessness for 5 years, cough with expectoration, breath sounds decrease bilaterally like a typical COPD breathing. You don't find anything apart from some hyperinflation on X-ray, nothing you will see. So this is the PFT. If you carefully see, I don't think this is eligible for interpretation by any standards. Nevertheless, if you see the FEV1, FEC, everything, he qualifies to be a obstructive type of lung disease with good reversibility. And in the same patient, this is what we have done. So if you see this iOS, there are a lot of lines. Unfortunately, there are no colors in this, but at this moment, remember, this is how a FOT or a iOS. What we do is the iOS, and iOS looks like this. Parameters like R stands for resistance, X stands for reactance, which I will be talking in subsequent slides. What is this resistance and what is this reactance? And here you can see the resistance post bronchodilator is around 242%. It's significantly high. Anything above 140 we take it as significant, and also reactance is also quite high, and there is a significant change in the values after giving a bronchodilators. At this moment, remember, here simple way to perform actually. Okay, if you ask, you don't need any special instruction in this. Ask the patient to do just tidal breathing. So parameters which are there in iOS and spirometry. Spirometry, I think most of us are aware. So the principle in spirometry is nothing but flow displacement, measuring the rates and the lung volumes, whereas in FOT and iOS, it is the sound waves which act as pressure waves which are superimposed on tidal volumes, and you measure the lung mechanics like resistance and reactance. So important parameter Z here is impedance. I will tell you what exactly is impedance, resistance, reactance. There is something called as resonating frequency and area of reactance. These are the parameters which we will see. You require tidal breathing, and it gives an idea about both central airway resistance as well as peripheral airway resistance, while our spirometry, though it detects, the sensitivity is very low in our spirometry, and reversibility is around 12 to 15% in FEV1, which we normally do in our spirometry, whereas for iOS and FOT is around 40% for resistance or reactance. Different guidelines say different, but at this moment remember that change in the resistance by 40%, decrease in the resistance after bronchodilator is significant. So it gives an insight about the lung mechanics, while the spirometry just says about the physiology, whether it is obstructive, restrictive. So what does oscillometry do? So through a loudspeaker you are generating sound waves, and these sound waves are nothing but the pressure waves which are superimposed with the tidal volume, and once there is change in the pressure due to the superimposition, you measure the mechanical properties of the lungs. This is the principle. So as I said, simple tidal breathing doesn't require so much of cooperation, hence I think it is very useful in children, elderly who cannot follow your instructions properly. So this is how it works, tidal breathing, and you are giving oscillation. In FOT you give specified frequency of sound, whereas in impulse oscillometry you are giving different frequencies at the same time. Okay. So this gets superimposed and you are able to identify the different mechanics. The most important parameter you have to remember is lung act as a low pass filter. This is the physiology, normal physiology of the lung. That is, only the lower frequencies are transmitted throughout the respiratory system. The higher frequencies are reflected back. They don't get transmitted by the parenchyma. Only in the larger airways they get reflected back. This is what I am trying to show. So any change in the frequencies above 20 hertz, okay. So anything above 20 is larger frequencies. Any change detected gives an idea about larger airways. While change in the R5, you can see here R5 represents the entire respiratory system. Change in the frequencies below 20, especially 5 or below, it just says there is some problem in the respiratory system. So larger frequencies, larger airways at this moment. So most of the mechanisms, equations, everything are derived from physics. That is, lot of things can be stimulated to our current electricity. Okay, the flow of current depends on the presence of all these things. So whenever there is some kind of a force, there will be equal and opposite force. Though it may not be equal and opposite, definitely there will be some opposition in the entire system. So when it comes to current electricity, you can have resistance, direct inhibition of the flow of the current, that is the resistance, or you can alter the current which is flowing. So that is what happens in inductance, what we call it as inductant reactance. This is the way the tissue or the material reacts to the force which has been applied. So that is reactance. And if you have capacitors, okay, they will generate a negative energy in the opposite direction to oppose the force. So that is called as capacitive reactance. Now the sum of all these forces is called as impedance. So impedance Z, what we measure as, is respiratory resistance with respiratory reactance. So most of the time I put up this very simple illustration, what exactly happens during breathing. You can stimulate your breathing to inflating a balloon through a straw. So when you have to inflate a balloon through a straw, first you have to overcome the resistance in the straw, then you have to overcome the elastic recoiling of the balloon. That is what exactly happens in our respiratory system. First you have to overcome the resistance in the airways, then you have to overcome the elastic recoiling of the lung. So if you see the tidal breath, so whatever is in the blue, I think most of us are aware, if you have seen a ventilator actually, PV curve, if you see. So whatever is in the blue is the resistive work, that is the work done by the system to overcome the resistance in the airways, whereas in that red or the brown color, it is the work done to overcome the elastance of the lung. So in respiratory system, resistance is a direct inhibition of the flow. So that actually happens in the airways. So problem in the resistance means it is largely airway problem. Also these airways will have air in it, so they will have lot of inertia. So that will react when you give all these pressure waves. So whatever the opposition you get because of the presence of the air in the airways, it is called as inertive reactance, that is I. Okay. And as I told earlier, because of elastic recoiling of the lung, there will be a rebound resistance and opposition to this pressure. So that is called as capacitive reactance. So this is my diagram, this is how I have understood. So if you divide based on this physiology and your mechanics, so asthma predominantly problem of airways, smaller airways. COPD combination of smaller airways and also a part of alveolar ducts and the alveoli, because elastic cartilage is destroyed in COPD. ILD is beyond that, that is your parenchyma purely and the interstitium of course, and chest wall disease in the chest wall. Some change in the arrows because of change in the system. So, again major disorders, this is how you can divide. So, asthma, what happens when it comes to mechanics? So, the resistance will increase and also the inertive reactance will increase in an asthmatic patient, and this patient physiologically will manifest as obstruction on our PFT. Okay. When it comes to COPD, as I told, it is a combination of both. So, you will have all these parameters being changed. So, resistance will increase, both inertive reactance because the peripheral airways are also involved in COPD, and the capacitive reactance is also increased. All the parameters are increased in COPD. Whereas interstitial lung disease and chest wall diseases, it is purely a disorder of capacitive reactance, C reactance, what we call it as. So, where is the problem? As I told, if there is a problem in the higher frequencies, especially resistance R20, it is larger airways. So, you can see this graph. So, there are two curves here. So, the normal resistance is the dotted curve, and you can see one red line. Okay. At frequencies less than 5, it is much higher, and as the frequency is increasing, the line is sloping down. That means to say, at larger frequencies, the resistance is normal, decreasing. So, where is the problem? Small airways, it is written there, but I want you to understand. Whereas, you see the next line, purple line, it is almost a straight line. Okay. Means to say, even at the smaller frequencies and larger frequencies, the resistance is higher. It might increase at the larger frequencies. Okay. So, at this moment clear, larger frequencies, larger airways. So, I have been talking about reactance so much. So, this is how you identify a reactance. Okay. So, you can see this curve, the red line, and there is something called as triangle there, blue area. So, reactance curve will have initial part that is negative. So, it is the rebound resistance. As I told, rebound resistance is always in the opposite direction. That is why it is negative here. So, any problem there in the C portion, that is the capacitive reactance, you are either dealing with interstitial lung diseases or you are dealing with COPDs, less likely airway diseases like asthma, though some amount will be affected. And you have that line meeting at the baseline, that is called as a resonating frequency or F-res. So, normally this F-res will be around 8 to 12. So, that will be the frequency at which the C portion and I portion will meet. The part above the baseline is called as the I portion, that is always a positive, that is because of the inertia of the gas. Okay. So, as I said earlier, reactance are two types, capacitive and inertive. Okay. Capacitive is due to elastic recoiling, inertia is due to the inertia in the airways, inertive reactance. So, resonating frequency 8 to 12 is normal. Okay. So, it can increase both in restrictive disorders as well as in your obstructive disorders like COPD. So, again AX, it is useful indicator, lot of studies have been done on this AX. Generally it is considered as normal if it is less than 0.33. So, we will try to see what happens in the major, 5 minutes, okay, I will try to finish. So, iOS and FOT in asthma. Okay. So, asthma, as we all know, it is a reversible diseases. These are the criteria. R5 40%, X5, that is a reactance around 50%, area of triangle change is around 80%. So, what happens in COPD? You are able to identify something called as expiratory flow limitations. I think this physiology we are well aware what happend to the end point, equal point theory. Okay. So the equal point will get shifted. So more forcefully you try to blow in a COPD, more will be the obstruction. So this cannot be identified using your normal PFT, but iOS plays a very important role. So what else you can make out in iOS is expiratory resistance and inspiratory resistance, both can be made out. So we are well aware that the problem in COPD is increase in the expiratory resistance, and even the X5 will become more negative in a case of COPD. So these are the various studies. I think I will talk about this in the workshop in the interest of time. Okay. So they have said that more than resistance, it is the X5 which is more important, and comparison has been made with the gold staging. So there is something called as delta X5. As I told, the difference between the expiratory X5 and the inspiratory X5. Okay. At this moment, remember, if this delta X5 becomes more negative, you are dealing with COPD. If it becomes positive, you are dealing with ILD. May not change in asthmatic and may not change in normal individuals. Very less literature on ILD. We have done study in ILD, and this is what we have found. So these are all the statistics at this moment. Remember that, you know, what we see in COPD, it is reverse of in ILD. As I told, delta X will become positive. And very important thing which we noticed is we were able to see the difference between IPF and non-IPF. So important. What all had IPF pattern on a CT scan had changes different from what we saw in non-IPF. So probably I will talk to you in a workshop what parameters were different. So still lot of studies required. So what I feel is iOS should complement. We cannot choose between either of the investigative modalities you have. Why? Because when they add up, you get a extra benefit rather than separating them and replacing them. So useful tool in understanding mechanics of different respiratory disorders. And one more important thing is, before the patient becomes symptomatic, before even the PFT shows any changes, you can pick up the changes in iOS, and additional information about resistance and reactance can be derived using our iOS, especially in COPDs. And as I told, what we are doing study in ILD, we can differentiate between peripheral and peribronchovascular ILDs like IPF and non-IPF. And of course, we need lot of own population equation, what we are following in Western equation. I don't know how effective it is. So far we are a part of study in Pune, I think. So we probably will come in next few months with the reference equations for our population. So there is a lot more to learn. I know enough confusion I have created. Have a lunch, okay, and then probably you can refresh and ask me less questions.
Thank you, sir. Actually, thank you, sir. Actually, you kept it simple. You kept it very simple. And once you see the machine and once you put your hands on that, definitely you'll understand. Dr. Bhashakan, sir, thanks a lot. Thanks a lot for chairing session. And sir, both of them will join us even in the workshop, and they'll give you more information about that. Thank you. We come to the end of the didactic lectures, and thanks for all the participants, delegates for patiently listening. I remember Dr. Satish sir's words, focus and perseverance and consistency. Thank you. I would like to call upon Dr. Vishnu Sharma sir. Sir is going to give you an information about the PG quiz prelims round, and please keep all your WhatsApp on.
I'm really sorry to stand in between you and lunch. This is only for postgraduates. I think faculty can please move for lunch. Please keep your mobile phones on with the net on. All of you have joined that
The PG's one WhatsApp group.
Physiocon PG's group. Everybody has joined?
Yes, most of them are.
Already been announced in the morning, no? Anyone else to join? You can add them quickly. If there is someone to join. Yeah. Please open the. Everybody is able to access the link. Anyone is not able to access the link for the quiz? Please hear the announcement. We have 40 questions to be answered in 15 minutes. Quizmaster's decision regarding the answer is final. You have 5 choices. Choose the single best choice. 10 marks for a correct answer and no marks if not answered, no negative marks. The first page you have to put your email ID, enter your full name and number. You can start now. Your time starts now. The time is 3 o'clock and 4 minutes. So 3:20 we will be closing. Okay? Please start.
ಬ್ರೇಕ್ ತಗೊಂಡ್ಬಿಡಿ. ಒಂದು 4 ಚೇರ್ ಸೆಟಪ್ ಅಷ್ಟೇ. ಓಕೆ ಸರ್. ಒಂದು ಮಾತ್ರ. ವರ್ಕ್ಶಾಪ್ ವಿ ಆರ್ ನಾಟ್ ಡೂಯಿಂಗ್ ಓನ್ಲಿ ಪಿ ಜಿ ಕಿಸ್ ಥರ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. Here only.
No discussions, sir?
Same laptop. Vijayan. Same laptop. But wonderful laptop. You know, since my PG time I've been using Innova. PG ಮುಗಿಸಿ ಕನ್ಸಲ್ಟೆಂಟ್ ಆಗಿ 5 ವರ್ಷ ಕೆಲಸ ಮಾಡ್ತಾನೆ ಇನ್ನೋವಾ ಒಂದೇ ಲ್ಯಾಪ್ಟಾಪ್ ಇವಾಗಲೂ ಕೆಲಸ ಮಾಡ್ತಾರೆ ಚೆನ್ನಾಗಿ ಹಾರ್ಡ್ ಲ್ಯಾಪ್ಟಾಪ್ಸ್ ಅಲ್ಲ ಲಾಸ್ಟ್ 1 year 1.5 year ಬ್ಯಾಕ್ ವಿಜನ್ ಕೊಂಡ್ಕೊಂಡೆ ವೆರಿ ಸಾಲಿಡ್
Hello, check, check.
Hello, good afternoon to everyone. We'll start with the final round for the quiz. It is my pleasure to announce the top 8. Akshata P. Kumar. Akshata P. Kumar is here. Congratulations. I request the faculty to move 2 chairs behind. These chairs are for the final participants. Please come forward. You can occupy the front row. Akshata P. Kumar, congratulations. She has stood first out of the Dr. Roshna Raju. Congratulations to Dr. Roshna Raju. Roshna Raju is here. If Roshna Raju is not here, we will go move to the next person who has scored the highest. Roshna Raju is here. Any of our friends are here? Please call, na? If she doesn't come in 5 minutes, we will be starting the proceedings. Amrita Haridas. Dr. Amrita Haridas is around. Dr. Amrita Haridas is around. Please come. Congratulations. Come, come. It is your day.
Both are coming.
Please call, na? If they don't come in 5 minutes, the next person.
Amrita, who is Amrita?
For the final rounds. So we have the first 3 participants here. Please be seated. Please take your chairs. Spurti P. Dr. Spurti is there. Please come. Dr. Sharmila PC. Dr. Sharmila. You are Sharmila? Please come now. It seems you still have not had a good lunch. Tilaka, yes, Vijayan. Dr. Tilaka, please come. So, how many are there now? 6. Where is the 6th one? Okay. Vijay Balaji. Congratulations to Dr. Vijay Balaji and Muhammad Hafiz Sadiq. Please come. Take your chairs. No, we will form a team. We will decide. Please sit. We will form a team. So, who are all from the same college? Please sit. You are from the same college. Okay. It's okay. Anyone else from the same college? You both. So, you will form a team. Okay. What about you? You are from different colleges. One more person who is said to come? Okay. What is her name? Amrita. She is from which college? Narayana Hridayalaya. So you decide and make a team. I think both of the boys will make a team. Yes. All right. Fine. Sit on that. You can move a little that side. No. You can sit there only. No. One seat is here. No. You can come this side. No. Let it be there. We can have one more person sit next to him. Yeah. So can you see the display properly? No, not individually. Yeah? His partner has to come. Yeah. You can come this side. No? You will not be able to see the display. Timings? Yeah, I'll tell you as you start. So, congratulations to all the participants. Give them a mic. No? So, we have 4 teams now. Team 1, 2, 3 and 4. Who is the scorer here? So, team 1, 2, 3 and 4. Okay? Write the names. Please introduce yourself. Give them the mic. No? Introduce yourself. It's on. Please introduce yourself.
Good afternoon. Myself Dr. Tilaka from Narayana Hridayalaya, Bangalore.
I am Dr. Roshna, final year Pulmo PG, Narayana Hridayalaya.
You noted down the names. No? Okay. So amongst you, who will answer? Because both cannot give answer because you may give different answers. No? Decide among yourself who will give the answer. Okay. You will sit on this side. So whatever you want to convey to her. Give the mic to her. Yeah, please.
Myself, Dr. Mohammad Hafiz from JNMC, Belgaum.
Congratulations to Dr. Mohammad Hafiz.
Myself, Dr. Vijay Balaji from MS Ramaya Medical College.
So please decide who is giving the answer. You will give the answer. So hold the mic. Don't give the mic to him. Yeah, please. Please note down the names. Yeah.
Sharmila from Bangalore Medical College.
Congratulations, Dr. Sharmila.
Akshata P. Kumar from Bangalore Medical College.
Congratulations. So who will hold the mic? Okay, fine.
Spurti from Vaidehi Medical College.
So congratulations to Dr. Spurti.
Myself, Dr. Amrita from Narayana Hridayalaya.
Congratulations to Dr. Amrita. So who is holding the mic? Okay, fine. So those who are on the right hand side, my right hand side, will be giving the answers. All right. Shall we start? So those who are on the back side, please do not give any answers. This place, no? Okay. So medicine is changing very fast. What we learn today changes tomorrow, or sometimes there can be a lot of dispute regarding the answer as well. But as far as today's quiz is concerned, whatever the quiz master decides as answer is final. So correct answer will fetch you 10 marks, a wrong answer -5. No marks if not answered. Time is 30 seconds once we display the image. So please keep the timings. All the participants, can you see the display properly? If you want to adjust your chairs, no, please adjust. Afterwards, don't complain that you are not able to see the image properly. All right, shall we start? You are ready? Okay. I think, okay, don't tell the answers. Please don't tell the answers. Anyone who is in the back, no? Please keep mum. So we'll be starting from team number 1. Team number 1 is ready? All right. So this is round 1. So you have to tell the radiological diagnosis. We will be displaying a X-ray. So see the X-ray carefully and tell what is the radiological diagnosis. All right. Any doubts from the participants? If you have any doubts, you can please ask. So shall we start? You have any questions? All right. Okay. So what is the radiological diagnosis? Others, please keep quiet. If you don't answer, it will go to the other team. Only if you don't answer, okay? Your time is up. Your time is up. Within 30 seconds, you are supposed to give an answer, no? You are told your time is 30 seconds.
Sir, right middle and lower lobe collapse.
Yeah, your answer is correct. Congratulations, but they don't get any marks for that. Because you can see the silhouette sign there. So it's a middle and lower lobe collapse. We have told you in the beginning itself, you have to answer in time. Okay? So scorer, please note, they don't get a marks for that, even though they are given a correct answer. Okay. So right middle and lower lobe collapse. Yeah, team number 2. Your time starts now. What is the radiological diagnosis? Please don't murmur.
Left upper zone mass, sir, causing mediastinal shift.
No. Anyway, you did not get a correct answer. Anyway, once the answer is attempted, it will not be passed. Anyone would like to give an answer, audience? It's a classical left upper lobe collapse in a frontal chest radiograph. You can see the diaphragm very clearly. You can see the diaphragm very clearly. So this is the left upper lobe collapse. They get -5 because they are given a wrong answer. Scorer, please note, they get -5. Team number 3 is ready? Yes. Your time starts now.
Left-sided pleural effusion, sir.
No. Anyone would like to give an answer? Anyway, once you have given an answer, you can attempt, of course. Already, once your answer is wrong, you will get -5.
Left lower lobe collapse.
Yeah, okay, congratulations. It is a left lower lobe collapse because you can see the mediastinal shift. You can see that diaphragm is elevated. There is loss of volume, so you can't call it when there is loss of volume. Yeah, when there is loss of volume, it is collapse. It is not effusion. Scorer, please note they get -5. -5, and now comes team number 4. You are ready? Okay. Yes. Your time starts now.
Right upper lobe collapse.
Yeah, congratulations. It's right upper lobe collapse. So they get 10 marks over there. Can you add on something? No, it is not cold. What is the cause for the collapse? Probable cause. Yeah, very good. It's not the tube. It's a portable X-ray. You can see the endotracheal tube there. So the endotracheal tube is in position. You can see the carina very clearly. The tube is away from the carina. It is not obstructed. So most likely that it's a mucus plug that is causing the obstruction. So congratulations to team number 4. They get 10 marks there. So first round is over. We go to second round. You have to name the radiological sign. Now we will start with team number 2. Okay, scorer, please note team number 2. Okay, we are starting with team number 2. Team number 2 is ready. Not the diagnosis. I am showing you a radiological sign. You have to tell us what is the radiological sign. All right. 30 seconds only. Wrong answer, -5. Okay. Please don't answer. I know many are tempted. Please don't help them.
Signal ring appearance and bronchiectasis.
Signal ring sign. When we have to start with, we will start with simple things only because we want you to score. So it's the classical signet ring sign of bronchiectasis. That's why we start with 1, 2, like that it will go on. So whoever comes first will get rather easy one because the next ones, they know the flow. The advantage is always there. Okay, team number 3 is ready. Please note team number 2, 10 marks. Congratulations to team number 2. What is the radiological sign? Please don't murmur. It will help them. First one was easy. Time up.
It's a dream, but
yes, you are correct, but late by 5 seconds. So they don't get a mark there. Very good. They have made it finally. Because a lot of black things on the left side, right side, you tend to miss what is happening on the left. That's why this X-ray was put. Classical tree bud appearance, maybe in a case of bronchiectasis. Okay, congratulations, you have made it, but few seconds later. So congratulations, but they don't score any marks there, 0 marks for them. So team number 4. What is the radiological sign? You could have answered it either.
Vanishing lungs.
They get -5. Yes, you can give the answer now.
Deep sulcus sign.
Yeah, very good.
Pneumothorax.
So they get -5. Team number 4 gets -5. So it is a classical deep sulcus sign. You can see it's a portable X-ray. You need to read the X-ray properly. What is written there is a portable X-ray. So it is a deep sulcus sign of pneumothorax. So they get a -5 there. So the last question of the final round, second round. Team number 1 is ready? All right. Yes. What is the radiological sign here? Please don't murmur. Those who are at the back, please don't Help them out. Yeah. No, anyway, you don't need to tell. Yes. Your time is up. You can attempt still. Yes.
Hyperattenuation mucus in ABPS. Finger.
Yeah, very good. Fingering glow appearance. Fingering glow appearance. They don't get any marks there. So 2 rounds are over. Fingering glow appearance in ABPA. So we go to third round. Scorer, please note. Team number 3. Yes. Team number 3 is ready. Okay. You have to identify the abnormality, most likely cause for the abnormality. So if you identify the abnormality, you will get 5 marks. You identify the cause for the abnormality, you will get another 5. Okay? Is that all right? We don't have negative marks here. So you can attempt. Okay? This round there is no negative mark. So identify the radiological abnormality and most likely cause for the radiological abnormality. You are ready? All right. Something which is very gross and appealing. We are not asking minute things. So don't worry about small things.
So there is a left upper lobe mass, so like hilar mass, which is probably causing the left diaphragmatic paralysis.
Congratulations. Correctly they have identified. So left dome is higher up and there is a opacity in the left upper zone. So what is the most likely cause?
Pankos tumor.
Pankos doesn't cause diaphragm paralysis. Yes, anybody would like to? Unless proved otherwise, it is a bronchocarcinoma. Rarely other malignant mediastinal tumors also can cause a paralysis of the left dome. But the most common cause for a paralysis of the left dome is a malignancy, intrathoracic malignancy, bronchocarcinoma. Rarely a benign lesion also can involve diaphragm. Anybody would like to answer what benign lesion can cause pharyngeal palsy there? Aortic aneurysm. Anyway, this was a bronchocarcinoma. So congratulations to team number 3. They have scored 10 marks. Team number 4 is ready. Okay. So many things you have heard about diaphragm. Please don't murmur.
Lateral tenting of diaphragm, subpulmonic effusion.
Okay. Congratulations. They have identified that the right dome is higher up, the peak is lateralized, and it is likely to be a subpulmonic effusion. Classical X-ray of a right subpulmonic effusion. Congratulations. So they score full marks there, 10 marks. Congratulations to team number 4. We come back to team number 1. You are ready? Yes. Sorry. Anyway, we will give you another X-ray of the display. Done, huh? ಮಾಡ್ಲಿಕ್ಕೆ ಹೇಳ್ತಾನೆ. Okay. So what is the abnormality and what is the most likely diagnosis? Please don't murmur.
Sir, left lung volume loss with probably post-obstructive bronchitis.
Okay, not agreed. Anybody would like to answer? You can see the classical traction bronchiectasis, with the volume loss. So traction bronchiectasis you should have identified. post-infective. It was a post-COVID. But anyway, at least you should have told traction bronchiectasis with ILD. Okay. So they don't get any marks there. Team number 1 don't get any marks there. Yes. I'm asking you about the X-ray. Team number 2, you are ready? I'm asking you about the X-ray. First look at the X-ray and then look at the image. I know it's little tough.
Right upper lobe. Surgery is done for a mass, sir, that has caused a phrenic nerve palsy on the right, causing a right upper lobe elevation of the diaphragm.
Okay, we can take it. You identified a surgery has caused a elevation of the dome of the diaphragm. Congratulations. They get 10 marks there. So this was a radical neck dissection. This was a radical neck dissection. Anyway, we don't expect you to say that. At least, once that image is shown, you should identify a surgery has been done. Remember, right phrenic nerve palsy is less common. Usually, intrathoracic lesions cause left phrenic nerve palsy, but right phrenic nerve palsy is not very common. But it can rarely occur when a deep dissection of the neck is done. So you see the raised right dome. Congratulations to team number 2. They have identified a right phrenic nerve palsy, which is a rarity due to a radical neck dissection. So congratulations to all the teams. All are doing well, neck to neck fight. So we'll go to the next round. I think one more is there. No, one round is over. No. Yeah. Yeah. So we go to the round number 4. Yes, you are ready? We start with the team number 4 now. What is the radiological appearance? Some characteristic radiological appearance is shown. So you have to name that. What is it? Okay, you are ready now? Okay, your time starts now. What do you call it as?
Radiological negative of pulmonary edema.
Appearance. Anyway, they have already given an answer. Yes, you would like to answer? Anybody would like to give an answer? You don't get the marks, of course. You can take.
Is it reverse battering?
Pardon?
Reverse
COVID
battering.
X-ray, no? Classical COVID X-ray. It's a crazy paying pattern of a COVID X-ray. So they don't get they get a -5 there because they are given a wrong answer. Team number 4 get a wrong answer there. We go to team number 1. You are ready? Okay, all right. Please don't answer. Please don't answer. Yeah, please don't answer. 30 seconds only. Don't think too deep. It is very superficial and obvious.
Ground glass opacity.
Yes. Congratulations. Ground glass opacity. Team number 1 have scored full marks. It is a ground glass opacity. We go to team number 2. You are ready? All right. Yes. What is the radiological diagnosis or the appearance? 30 seconds only. Something which is so appealing. Don't bother too much. Something which is so appealing. Your time is up. So it is. Anyone? Anyone like to give an answer? It's organizing pneumonia pattern. It's an organizing pneumonia pattern. So they don't get any marks there. They are not given any answer there. Go to team number 3. 3 is ready. Yes.
Sir, IPF.
Please don't murmur.
Sir, pattern of IPF, sir, with honeycombing and traction bronchiectasis.
So honeycombing and traction bronchiectasis. But if you look at all these four, what is it? It's all due to COVID and post-COVID. You get ground glass opacities, you get crazy paving, you get traction bronchiectasis, and then you get organized pneumonia pattern also. All these are our own images only. All the images, whatever I am discussing, are the images from the department. It's not downloaded from the net or anything. So we'll come back to, I think we'll start again from team number 4. We'll come back like this now. Okay? Team number 4 is ready? All right. Not required. It's a friendly contest. Let them relax and give the answers. No? Don't worry about the scores. All are doing well. So you have to tell us the diagnosis, because most often our decision depends on chest radiology images. So you are ready? Team number 4. What is the most likely diagnosis? Correlate the 2 X-rays. What is the most likely diagnosis? We have given the dates also. Please don't murmur. Please keep quiet.
Pulmonary edema, flash pulmonary edema. Pulmonary edema, sir.
Okay, congratulations. You should have told cardiogenic pulmonary edema.
Okay.
Because there are so many causes for pulmonary edema. Anyway, I think they score 10 marks over there. The classical cardiogenic pulmonary edema with before treatment and after treatment. You have all the classical signs. Okay, congratulations. Team number 4 gets full marks, 10 marks there. Team number 3 is ready? All right. Diagnosis. Please don't murmur. Please keep quiet. Please keep quiet. Please keep quiet. Others, please keep quiet. It's okay. Don't announce the times. Let them take their own time. If they know their answer will come. Your time is up. Anyway, your time is up. You want to give the answer, you can give, but it will not fetch you any marks. Neither positive or negative marks. Yes, what is it?
Sir, thromboembol.
Something so big and... Yeah, what is it? Yes, anybody would like to give an answer? It's a classical. What is there? What is the structure, anatomical structure there? It's a classical picture of a aortic aneurysm. So please do remember, there are so many things inside the thorax. It's not only the lungs. That's why this X-ray is put. So you should think of other anatomical structures also while giving an answer. Okay? They don't get any marks over there. Team number 2 is ready? Yes. So what is the abnormality here? What is the abnormality here?
Pulmonary artery dilatation, sir. Aorta by pulmonary artery ratio.
Yeah, congratulations. So whenever you see this, you should always see what is the diameter of the pulmonary artery compared to aorta. It should be less. Here there is a dilatation. Congratulations, they get a full mark there. That indicates that is one of the radiological signs of pulmonary hypertension. Should always look and compare the diameters. Congratulations. So they get a full mark over there. Team number 1 is ready. The last question. Yes. Please don't murmur. Something which is very gross.
Pericardial effusion.
Yeah, congratulations. So you have got the clue that there are many other things inside the thorax. You get that pericardial effusion with a small, maybe a small pleural effusion also. Anyway, they get a full marks over there. Congratulations to team number 1. So we will go to the 6th round. Team number 3. We go to team number 3. Okay? Team number 3 is ready? Alright. So what is the radiological sign and what is the most likely diagnosis? Okay? 5 plus 5. No negative mass in this. You can attempt. There is no negative mass in this. Okay. But your answer you should start answering before 30 seconds is over. If you give answer after 30 seconds, it will not fetch you any mark. No negative mass. So you can attempt. Shall we start? Okay. Please don't murmur.
So right upper lobe collapse. Possible cause might be a endobronchial mass which is causing the collapse.
Something more you want to? Can tell something more?
The golden S signs.
Yeah, golden S sign. So they get a complete mass over there. This is a classical golden S sign. So what causes the golden S sign? What is the most common cause? Primary bronchial carcinoma. The most common cause for a golden S sign is a primary bronchial carcinoma. You should know which part of the S is due to the mass, which part of the S is due to the collapse. Okay. Please read what is golden S sign, what is the cause. So the expected complete answer would be golden S sign. Most likely cause is bronchial carcinoma. Most common rather. Okay. Team number 2, you are ready? So they get 10 marks over there. Yes. Please don't murmur.
Chronic lochleated pleural effusion, possible empyema because there is visceral pleural thickening that is there, sir.
So what do you call it as? There is a characteristic name for that, no?
Name.
What is the sign? If you have to get 5 marks, you have to tell the sign also. 5 marks they have secured. Anyway, your time is over. So they have secured 5 marks. I think you can help them out.
Split pleural sign.
Very good. Split pleural sign. I thought you will tell the split pleural sign first and the empyema later. The classical split pleural sign of a empyema. So they get 5 marks there. So team number 1, you are ready now? You got the flow, no? So it should be easy for you. Yes. Please don't murmur. Please don't murmur.
Sir, cannonball appearance in metastasis.
Yeah, very good. So classical cannonball appearance in multiple metastasis. So that's why we rotate like this. Some of the questions may be very easy. So if you are very lucky, you may get a straight forward. So to reduce that chance of luck, we rotate and go in a zigzag pattern. Okay, congratulations to team number 1. They get a full marks over there. You are left. Last question for him. Okay. Please don't murmur. Please don't murmur. Yes. Please don't murmur. The diagnosis is written there. Time. Please don't murmur. Your time is up. Yeah, you can give the answer. Now you won't score neither positive or negative marks, so you don't have to worry now. Yes. What is it?
Looks like some cystic.
Yeah, somebody has given the answer already, but it was in the lung window, which was wrong. It should have. So if you want to give that answer, it should be in the mediastinal window. What is that? So there is the classical appearance of high attenuation mucus, HAM, in ABPA. So when the attenuation is same as or a little more than that of paraspinal muscles, you call it as high attenuation mucus. It is one of the classical, or rather known as the diagnostic radiological sign of ABPA. So this is HAM of ABPA. I thought you will get it easily because we had ABPA X-ray, and already that HAM was told by one of the participants, which I did not expect in a lung window. Because when you project a lung window, you should know what you should see. When you project a mediastinal window, you should know what to look for. Okay, all right. Now, which team to start with? Team number 2, I think. All right, we'll start with team number 2. So, identify the abnormality, okay? You are ready? So here we have negative mark also if you tell a wrong answer. So be careful. This is the 7th round. 2 more rounds we have. Yes, what is the abnormality? Please don't answer. Others, please keep quiet. Please keep quiet. 30 seconds only.
Sir, there is improper positioning of the endotracheal tube that is causing single lung ventilation, causing a left lobe
So
collapse.
congratulations. So when it is a portable X-ray, you can see that endotracheal tube. Whenever you see the endotracheal tube, first thing what you look at is whether it is positioned properly or not. It is a intubation into the right main bronchus, which you are supposed to correct it immediately. Congratulations, they get full marks over there. So team number 1, you are ready? All right. What is the most likely diagnosis? You have the X-ray, you have the CT cut also. Please don't murmur. Others, please keep quiet. Others, please keep quiet. All these are our original images only, so there is no chance of you browsing these images anywhere. So your time is up. What is that? Something looks inside the thorax so muscular. Something inside the thorax so muscular. What is it? Yes, anyone? You can see a left paracardial capacity in this mediastinal window. You can see something is there inside the thorax which is so muscular. That is stomach. So it is hiatus hernia. It is hiatus hernia. Okay. So which team now? Fourth team. Okay. Team number 4 is ready. So they don't get marks, I think. Okay. Team number 4 is ready. Okay. So what is the abnormality here? Please don't murmur. So many things to be seen, of course. Time is up. Yes, you can still give an answer. Yeah, give it. There is no problem. Yeah, anybody would like to give an answer?
Esophageal
yeah, very good.
mass.
So I have told you already, there are so many things inside the thorax. Don't concentrate only on the lungs. It is a mediastinal window. So once you see a esophagus which is open, it opens only when there is some fluid or obstruction. So there is something that is causing opening of the esophagus. But then it looks very thick, is it not? So that is compressing the trachea rather. So you can see a thickened esophagus with a wide open lumen. So it is likely to be esophageal carcinoma. Please remember, a lot of patients with esophageal carcinoma will come with respiratory symptoms. They may not go to a surgeon or a gastroenterologist. Because of the obstruction, they may come with a chronic cough, aspiration, or sometimes even a fistula can occur in the very late stages. So a lot of patients we do see with esophageal carcinoma. So don't think about only the respiratory diseases when a patient comes with the respiratory symptoms. It may be the neighboring organs that cause the problems as well. Team number 3, right? Yeah, what is the most likely diagnosis? Please don't murmur.
So that's the enlarged thymus.
Enlarged thymus. So they gave a wrong answer there. They get -5. You can modify your answer now. Already you have scored -5. We will not be giving you any answer. Something which is encircling the trachea from all round, unless proved otherwise, is thyroid.
Thyroid carcinoma.
So this is thyroid, which is compressing the trachea. Thyroid is very closely related to the trachea, anteriorly and laterally, but not posteriorly. So anything you see which encircles the trachea from anteriorly and laterally, unless proved otherwise, is thyroid. Rarely an intrathoracic part of the trachea can be compressed by a thymus, but not so common. So they get -5 there. One more team is there, or one round we have finished? We have finished one. 7th round is over. Okay. We come to the 8th round. We will start with team number 1, right? Yeah, we start with team number 1. What is the radiological diagnosis? Okay, you have to give the radiological diagnosis. What is the most likely diagnosis? Please don't give them the answer.
Bullous lung disease.
We don't accept that.
Paraseptal emphysema.
Anyway, you are told a wrong answer. They get -5 there. This is which part of the lung? Upper part or lower part? Upper part of the lung. When you see multiple bullae like that in the upper part of the lung, you can see the trachea over there, is it not? So it is a, what should be the answer? What causes a bulla in the upper part of the lung in a CT most commonly? Emphysema due to smoking. That is the classical. So multiple paraseptal bullae in COPD. It is not bullous emphysema. It is not bullous emphysema. To call something as bullous emphysema, I should have shown you whole of the lung, and then intervening lung should be normal. Here the intervening lung is also involved. You can see a lot of emphysematous changes. Intervening lung is not normal. So it is a multiple paraseptal bullae in COPD. All right, we'll go to team number 4. All right. Please don't.
Asagus lobe.
Yeah, very good. So you are lucky this time. It's a straightforward CT. So each round one will be lucky. So azygos fissure or lobe. Okay. So they get full marks over there. Team number 3 is ready. All right. Yes, please don't murmur. Please don't murmur. Please don't murmur. Time is up. I think you are still not hungry. Popcorn. Popcorn. Classical popcorn. What is the diagnosis? Hamartoma. Classical popcorn calcification is hamartoma. Congratulations to team number 1. They have given the correct answer. Team number 2, right? Yes. Team number 2, please see. You are busy writing. Please don't murmur. Don't bother about the peripheral opacity on the left side, okay?
There is some mass. So left lower lobe, there's a pleural based.
I told you, don't bother about the peripheral opacity.
Along with tracheomalacia, trachea.
Anyway, your time is up. Your time was up, and your answer is also not correct. Anyone would like to give an answer? I told you, don't bother about the peripheral opacity on the left side. So anteroposterior diameter of the trachea is increased. So that is the classical saber sheath trachea. Please read what is saber sheath trachea and what is the diagnostic value of this saber sheath trachea in case of COPD emphysema. Okay, all right. They don't get a mark. They don't get a mark because whatever answer they are given, it is after the time. So they are lucky for not having scored a negative mark. So team number 1, right? Or one round is done. Okay. I think penultimate round. So what is the most likely diagnosis? I think where shall we start now? I think we'll start from team number 3. We'll come like this because we have started from this side, that side. So we'll start from team number 3. Okay. So what is the most likely diagnosis? Okay. All are images only. Please don't murmur. So correlate these 2 images and tell us what is the likely diagnosis. Skin and lungs. Just some lateral thinking, that's all. In the MBBS days, you would have studied, but when you become a postgraduate, you start thinking too much. Time up. Yes, anybody would like to answer? Very good. So that is
herpes.
Pneumonia with herpes labialis. You would have studied in the MBBS days, but we don't see straightforward pneumonias after in the respiratory medicine department, maybe because most often we see complicated cases. Classical pneumonias we don't get to see. Battery. So they don't score any marks. You have not given answer, no? They don't score any marks. So we go to team 4. Yes.
Sclerodermas.
Please
Scleroderma ILD.
Yeah, very good. So you are again lucky. Very classical. X-ray. Nobody can afford to miss that. Congratulations to. So that is a classical scleroderma, a female patient. Congratulations to team number 1. And we go to team number 1. Sorry, congratulations to team number 4. We come to team. They get 10 marks over there. And team number 1. Okay, are you ready? Yes. Please don't murmur. See what is the abnormality in the X-ray and what is the abnormality in the leg. Correlate these two. Not very common, of course. Please don't murmur. Please don't murmur. Please have the timings.
Sir, right upper lobe cavity with erythema nodosum.
Yeah, very good.
Tuberculosis.
So, yeah, very good. Congratulations. It's a right upper lobe cavity with erythema nodosum. Characteristic of tuberculosis, because whenever you see a cavity in the right upper lobe, the first thing which should come to your mind is tuberculosis, sputum positive patient. But erythema nodosum in tuberculosis is not that common, rare. But we are fortunate to see one patient, so we could get a image. Congratulations to team number 1. They have made a wonderful diagnosis. So they get 10 marks. Team number 2. Okay. Yes. Please don't murmur. Skin and lungs.
Neurofibromatosis, sir.
Yes. Please don't murmur.
What is that causing? Kyphosis, along with kyphosis, sir. And increased retrocardiac space that is there.
You have made a diagnosis of neurofibromatosis, that is fine, but something that is looking at you on the lateral view, no? Posterior mediastinal mass. What is that posterior mediastinal mass in neurofibromatosis?
Schwannoma.
So the correct answer here would be a posterior mediastinal tumor, schwannoma, in a patient with neurofibromatosis. So they don't get any marks because they are not told because neurofibromatosis is very obvious. What we expected them is to identify that there is lateral X-ray, posterior mediastinal mass, schwannoma, most likely to be schwannoma, because that is the most common tumor associated with neurofibromatosis. Team number 1 round is over. So we are coming to the last round. I think we will start with team number 2 now, because we have never started with them. So we'll start with the team number 2. Okay, you are ready? All right. So last round. What is the abnormality?
Right mastectomy, sir. Only one breast shadow is seen, the other side is not seen.
Yeah, very good. So you are thinking like a man. But don't think every time you don't see one breast, it is due to mastectomy. This was a lactating female. She had some cough. We took X-ray. We also found that there was no breast, but it was congenital absence of right breast. Anyway, you identified that there is no breast shadow on the right side. They get complete 10 marks. They are lucky to have this X-ray. So team number 3, they get a complete marks. So team number 3. Yes.
So right sided loculated pleural effusions.
Complete diagnosis.
So right sided loculated pleural effusion, sir, probably empire.
Time up. Anybody would like to give an answer?
Pericardial calcification.
Is there. Heart is looking at you. So you see the beautiful pericardial calcification with a pleural also. They're very rare, of course, but at least you should identify that there is a pericardial calcification, not very common. So what is the common cause? Most common cause? Unless proved otherwise, tuberculosis. Rarely, pyogenic infections and trauma. You can get hemopericardium with hemothorax. That also can calcify. Alright, this is a patient with tuberculosis. Team number 4. Yes, what is the diagnosis? No, they don't get mark. They don't get mark.
What do you want for that? I don't know.
Something which is very obvious.
Calcification.
But you have to tell what it is. What type of calcification? Where is the calcification? Calcification agreed, but you have to tell.
Plural, sir?
Plural. You would have got negative mark. Anyway, you have told the answer after the time was up, right? So they don't score anything. That is the classical punctate calcification of parenchyma. Parenchymal calcification. This is how parenchymal calcification will appear. You can see multiple dots over there, no? This is a parenchymal calcification. So we come to the last question for the day. Okay, team number 1 is ready. Okay. Yes. Please don't murmur.
Sir, subcutaneous emphysema, continuous mediastinal, the continuous diaphragm sign, pneumo.
So congratulations. They have hit a sixer of the last ball. You can see the continuous diaphragm sign of pneumomediastinum. There are so many signs in pneumomediastinum, and the surgical emphysema. You can see bilateral tubes, intercostal tubes, ET tubes, and so on. So thank you all for the participation. I think the results will be announced soon. Already done?
Thank you, sir. That was a marvelous quiz competition. Literally, it was an amazing thing to have you around, sir. And it was a wonderful quiz competition. Very beautifully done. It shows your proficiency in conducting quiz competitions. Really, we admire you as our quiz master today. We're really lucky to have you here, sir. Thanks a lot. I would like to call Dr. Shashibhushan sir to please hand over a token of gratitude to Dr. Vishnu Sharma sir from Trustful Hospitals.
So thank you all for the participation in the quiz. The results will be announced soon, and those who want to know the answers for the preliminary, please stay in the group. Later on, I will put the PPT with the answers.
Thank you, sir.
Thank you, sir.
How many pages?
In our institute.
Yeah, the quiz finalists kindly stay back here. Just give me 2 minutes, and now we all will move to workshop. So 10 to 15 minutes we'll take for each station. There are 10 stations. I want you to 5-10 minutes. You can keep moving different stations. Basically, you have seen already the workshop stations, what are all there in the list being announced already. You get to do a hands-on on mainly CPET, iOS FOT, and the most important thing is pulmonary rehabilitation, which is a very important thing for all of you guys. You have to practice. We have eminent doctors, physiotherapists who are going to teach you how to do proper chest physiotherapy and how to do pulmonary rehabilitation practice. Dr. Prem and Dr. Aarti Prasad and Dr. Shilpi, all three are eminent physiotherapists. They have done wonderful work in their field, and they are waiting for you guys in the 3rd floor. And also Dr. Syed sir is there, who is going to teach you about CPET. And also we have all other faculties who have come here for teaching all of you at various workshops. You get to have a hands-on on non-invasive ventilation, your DLCO, FeNO, 6-minute walk test, everything is there. Please make the best utilization of all the workshops we have. I know it is delayed and time is extending further, but it is worth it. 1 hour of spending extra time is always worth it. Don't worry about it. So all of you can gather in the 3rd floor for the workshop. Ready? I would like to call Syed sir to please come up and distribute the prizes for the winners. The fourth place goes to Akshata P. Kumar and Sharmila PC. Congratulations, Akshata. The 3rd place goes to Spurti and Amrita Haridas. Final marks, just want to tell. Second place. Congratulations. And second place goes to Dr. Tilaka as well as Dr. Roshni Raju. Congratulations. So the 4th place got 20 marks, that is team 3, and the 3rd place went to team 4 with 40 marks, and the 2nd place goes to team A with 45 marks, and and the 1st place team B, team 2, they got the 1st place with 50 marks. Congratulations. What happened? Oh, signature we missed. It's okay, no problem. Congratulations for both of you. Yeah, thank you for wonderful participation. All of you, please move to the third floor. All of you have your badges with you, I believe, and there's a number on it. So that's your workshop station. So workshop station number 1, 2, 3, 4. You guys divide among yourselves and kindly head to the third floor. And let's conclude the session by then. Yeah, thank you.